back. So anything peculiar about this X-ray? Okay. So diagnosis is almost clear on examination. So certain findings of this patient, along with that, she had a short stature, there was a frontal bossing, hypoplastic jaw, crowding of teeth. The next question is, what else would you like to examine in this case? Apart from these physical findings, anything else you want to examine? To the house? No problem. So usually a case of osteopetrosis, the patient presents with the symptoms of many times auditory problem, vision. So that can we expect something on examination of the abdomen? If you go for an USG examination, can we have something? Okay. The patient may have the features of hepatosplenomegaly because there is extra hemolytic. As you can see, the hemoglobin level of the patient is around 9.5, not much different. So the line of treatment, what to do? Operative, non-operative, intramedullary device, surface implant. Operative, okay. Device, intramedullary or surface? Can we go for intramedullary devices? Okay. 14 years.
So titanium elastic nail to protect from future fracture and end of the plate, otherwise the plate, but a titanium elastic.
Okay. The patient was operated. Now, what is wrong with this instrumentation or fixation?
This seems like a 3.5 plate. Femurs of 14-year-old would usually require a 4.5 plate. First.
Yes.
Second, long bone fractures, especially the femur, if you are even plating, at least 8 cortex on each side.
Very true.
Third, plate needs to be pre-contoured. Straight plate was put, so medial opening is there.
Right.
Because of the wrong contouring of the plate.
Right.
And
yes.
there is a stress riser at both the ends of the plate. Locking screws are put, and this is osteopetrosis, so bone is sclerotic. There is a high chance of fracture at the ends of the plate if this unites, which it might not.
Very right. If you see the second X-ray, I am marking out 2 points, these 2 points.
Yeah, titanium nail they have tried to put.
They had tried. So the surgeon failed on the table. He could not negotiate a nail.
Even if this was not a femur, you have to just remember that if you're putting this kind of a plate which is not contoured, short segment fixation, if you leave small gaps, increases the strain on the implant.
Right.
So if it's in a 14-year-old in osteopetrosis, this has a lot of chances of breakage. May unite if the surgeon is too lucky. But short gaps in a short segment fixation is totally against the principles.
So in nutshell, this is an inadequate fixation. There is a medial opening. All these are going to cause a stress riser and there is a possibility of fracture. And this is what happened. 6 months back, a trivial fall. The girl fell down and again there was a fracture with the breakage of the implant. Causes of failure we already knew what the panelists have suggested. Now how to proceed from here?
Just remove the plate,
Yes.
freshen the bone ends, take bone graft, put 2 plates now, one a long lateral plate because you know that a titanium elastic nail was tried. Try another one, titanium elastic nail. If it doesn't go, a long plate from GT to the distal femur and one more plate orthogonal at either on the anterior surface with a lot of bone graft.
Very good. So we are already knowing that the doctor had tried the intramedullary device, he failed, so we should go for a surface implant again. Okay. Now what is the challenge basically with these patients? So a few challenges I have just marked out. There is always a possibility of increased resistance while ramming or you're putting in the screw. The reduction maneuvers, these kind of patients with osteopetrosis, they are not able to tolerate the tensile load, where the compressive load can be borne, but the tensile load is there, there is always a possibility of fracture. And you have got a risk of breakage of the drill bits. And always there is a possibility of high infection and malunion. which leads to surgical revisions. Now, just look at this picture. We had opened this case and see the amount of narrowing of the medullary canal. It's very narrow and sclerosed. This is what we did. A longer plate was applied on the lateral side and the other plate was also applied. And we hoped, let's see what happens. The follow-up of the patient was taken up. This is in July, October, and the recent X-ray in Feb. Signs of union, difficult to say, but it appears that it is doing well. We don't know what will happen.
How long from the second surgery now?
This is 8 months.
Does the patient have pain?
The patient doesn't have pain. The patient is able to walk. Sorry, I could not bring the video. Oh, sorry. The patient is able to walk without pain, and we are keeping our fingers crossed. Let's see. But there's always a possibility that she might have a fracture again. But what I want to say is the take-home message. While you're operating these cases, you should be doing a continuous cold saline irrigation to clear off the debris and prevent the heat osteonecrosis, number one. Secondly, there should be a frequent drill bit change. There should be spaced cycles of reaming or drilling, and that too at a low speed. And while drilling, you should try to avoid the toggle, because the toggle can lead to breakage of the drill bit. And the drill bits needs to be frequently changed, and the bone which entangles in the drill bit, that has to be removed. The power system to insert the screws, that should be self-time. You should try to put in the screw with the power system. What happens with that? Because of the fatigue, that leads to toggling of your screwdriver, your hand. So that can again cause a fracture. So try to use a power drill or power system to insert the screws. You should be having a spare battery for the power system as a standby, long plates, and try to do a fixation with a bridging mode of fixation. And the last screw should be either unicortical or try to angulate it a bit so that it can reduce the stress and prevent the...
So one small point I want to make.
Right.
Once you're dealing with a peri-implant fracture or failed fracture, what it needs is total absolute stability.
Right.
It does not need bridging mode. So you
Right.
have done it total absolute stability. You put one plate on the lateral side,
Right.
one on the anterior. So you have given it total absolute stability.
Right.
Non-union needs absolute stability. Right. So I don't think bridging mode will work. One point. Second, so with the power tools, when you're doing it, you can do the tapping once or twice again in such a special situation. But if you use the power tool, it generates so much of heat that you're going to end up breaking a lot of drill bits.
Right.
It has happened to me. So I don't know what it was your experience, but sometimes power tools can be not so handy in these cases.
Okay.
A tap is a useful thing.
Double tap.
So normally all these screws are self-tapping screws that we are using nowadays.
Right.
But keeping a tap in this case is
That is
really
also helpful.
Yeah, it really saves your lot of issues.
And one thing which was raised
screw
from
head
you,
breakdown is very common here.
from the
If you're
panelists,
going,
one thing
screw
was
head
raised
breakdown is very
regarding the bone graft. So when you're looking for a bone graft, where would you like to harvest it from? In a
For
case of osteopetrotic patient.
So for a 14-year-old in my hospital, we have a bone bank. So I would use a lot of allograft. But if someone does not have access to allograft, then I think artificial bone graft substitutes like something, this is a long surgery, and with drilling you can have a lot of thermal necrosis.
Do we really need a bone graft in a 14-year-old? That is also important.
Yes, because
Transfer.
these cases are not very common cases. A study was conducted at Ganga Hospital. They had a series of only 8 patients. And they had done a fixation. 1 or 2 was intramedullary fixation. The rest were the surface implants. They had added on the bone graft, which helps in the union a bit. So that can be added on.
One more thing is there is a lot of risk of thermal necrosis here.
Right.
That's why the biology is not so good. So adding a bone graft would slightly help. Another point that I have noticed in my little experience is drilling is possible with power tools, but when it comes to putting the screw with the power tool, the torque of the power tool is usually not enough. So either you have to tap by hand and then put the screw by power tool, or you have to directly put the screw by power tool. When you are putting these screws, use very good quality screws, because the run of the screw, which is the junction run out of the screw, is between the head and the shaft. that part has to be really strong. Otherwise, you will have a lot of screw breakages while putting at the
Head and shaft junction.
Head and shaft junction. And third is, although it is done really well, but the proximal most screw is ending at the subtroch level. Now it is a high risk of a periprosthetic fracture at the subtroch level,
High stress site.
which will be very, very difficult to handle. So I think in these patients, longer plates, last hole empty, second last hole unicortical, and then fixation should be done, because we don't want, no one wants another peri-implant fracture in these patients.
Okay. Thank you.
Thank you so much. Very nicely done. Thank you. Wonderful case. Great experience. So for the next talk, we'd like to call upon Dr. Ashish Devgan, please. He's not coming. Sorry. Dr. Ram Chadda sir, if he's around. Thank you. Dr. Ram Chadda sir will be speaking on adjacent segment disease.
Morning, everybody. Respected panelists, chairpersons, dear friends. I'm going to be speaking about adjacent segment disease, the gravity of the problem. We have this problem because we stand and move against gravity. I take you to the turn of the century, about 2002. We had this 72-year-old film producer with unresolved low back pain for more than 15 years. He had worsened claudication and back pain for 3 months. And just because he was this high-profile patient, many of us were treating him non-surgically, trying our level best कि मेरे पास नहीं हो, किसी और के पास चला जाए. He finally ended up having seen me earlier, but this time with a left toe drop and foot drop for 3 weeks. He was at that time 72 years old, otherwise fit and healthy. These are what his images look like. He has an L4-5 listhesis, which tends to move on flexion extension. And if you were to study with an MRI and look for a cause for that recent onset left foot drop and claudication, you would find that there was a pre-existing L4-5 listhesis with stenosis, but now at L3-4, there was also this new synovial cyst. That means there were 2 levels with compression and there was 1 level with an instability. How would anybody address this? Any idea? Yes, Samarth?
Sir, this is unstable listhesis, it is moving, so it requires a delay for some form of fusion with fixation.
Perfect.
And at one more level, it will require decompression. At this age, I think 2-level fusion and compression. Sir.
Fantastic. I love the answer, and we would probably have done that, but we were at that time much younger than I am today, hence far more techno-savvy, wanting to do what is the latest. So we decided we'll do and address, as rightly mentioned by Dr. Samarth, the L4-5 listhesis with the decompression stabilization and do something for the 3-4 cyst, which if we just removed it would have been adequate, but we felt अब 72 साल के हैं, इनके लिए कुछ ना कुछ तो करना चाहिए, तो इनको decompress करेंगे, अगर decompress करेंगे तो adjacent level पे instability हो जाएगी. So let us protect it. So what did we do? We did what was at that time state of the art. We did a T-lift, as rightly mentioned by you, at the 4-5 level, and we did decompression with a flexible rod at the higher level. So it allowed physiological loading but did not allow supraphysiological movement. Having done that, this man was good for the next 4 years. I was very happy because he continued as a film producer and I felt good about it. Unfortunately, he came with higher thigh pain and discomfort at the end of 4 years. What do we see there? We now see that there is an ascending stenosis at the level above both the levels. यानी flexible level पे कुछ नहीं हुआ, उसके ऊपर, adjacent to the adjacent level that I had protected, there is a stenosis, a suspicion of a facetal cyst again. What would you do now? Well, I lost faith in that flexible rod. I said, नहीं यार ये काम नहीं चलता. We should learn, unlearn and relearn. So I took one step back. And at the end of 3 years, because of the L2-3 ASD, I decided that I am going back to what I had learned conventionally and what Samarth had said, that I would now do a 4-level rigid rod and keep my T-lift at the lower level, but do a posterolateral fusion intertransverse at the other levels. This looked good. I was happy and I said, now he was a 76-year-old uncle. I said, uncle ji, ab bahut acha ho gaya, aap badhiya hai. Kabhi kabhi dusra operation karna padta hai. So he said, beta koi problem nahi hai, we'll do it. And he was very happy with that. Well, he now goes from the age of 76 to the age of 80. And I walk you through what we've done till date. Till date, we've gone through the flexible rod and now come to the rigid rod. At the age of 80, he says, beta, abhi bahut dard ho raha hai. मैंने 2 साल वो जादू का इंजेक्शन भी रोज का लगा लिया है जो आपने मेरी धर्मपत्नी को दिया था. I had given him teriparatide because it had just started and we were happy using it. He was also osteoporotic. His wife had been treated with that. But he says, अभी बेटा मैं जब हिलता हूँ ना तो पीठ बहुत दुखती है. So he had pain above that level. I did imaging, but I decided, I said, sir, अब आप 80 साल के हो गए हो, क्या करना है? Let's hold on. He said, नहीं नहीं बेटा बहुत दर्द है. And that बहुत दर्द suddenly became a situation where one day his one-sided groin gave way and he could not walk. I was a little worried. I got an MRI done and we found that he had now popped a disc above the instrumented level, besides the fact that he had cut through the superior end plate. What would we do now? We are at the thoracolumbar junction. How would we address this patient? Well, I had never seen this. I was feeling very unhappy क्योंकि इनके मैंने already 2 ऑपरेशन कर लिए थे and I told him अब आप ठीक हो जाओगे. But he was unhappy. Any call, anybody would decide what to do in this situation? Well, you would normally want to send it to your best friend, but he was not willing to go anywhere. So what we did was now look at him because he had neurology creeping in, and we thought from what we'd learned that we cannot stop at the thoracolumbar junction, so we went beyond the thoracolumbar junction up to D10. I said, uncle, abhi aap bahut अच्छे हो. ये हो जाता है कभी कभी, बहुत रेयर सिचुएशन है, 3 बार ऑपरेशन कर दिया है. सो वी वेंट टू D10 एंड ही वाज गुड. ही सेड बेटा अभी बहुत बढ़िया हो गया. आई हैव स्टार्टेड वॉकिंग, आई हैव टेकन माय मॉर्निंग वॉक्स. आई गेट सम चेस्ट पेन, शुड आई गेट माय चेस्ट एड्रेस्ड? आई सेड नो अंकल, डोंट डू एनीथिंग फॉर योर चेस्ट पेन, यू ऑलरेडी 80 प्लस, होल्ड ऑन. He went on to be 82. At 82, I was traveling for a conference when I got a call. बेटा चलना फिरना बंद हो गया है, यूरिन का कंट्रोल चला गया है. I said, क्या हुआ uncle? Come back. And he came. I was to leave and I did an MRI. I had never seen this. He had a D9, D10 disc prolapse with a cord compression, with a neurology very shut down, bladder bowel involved. I said, uncle, this is an emergency. बेटा तुम कॉन्फ्रेंस पे चले जाओ. I said, नहीं मैं नहीं जा सकता. We took him up within about a day because he was on blood thinners and all those things. We had to actually optimize him to a certain extent. And then went in. I said, uncle, very rare, I've never seen this. Now I will go across the thoracic kyphosis. So I went across the thoracic kyphosis and went up to D4. Now I've gone across the thoracic kyphosis. The D4, there is a thoracic kyphosis, thoracolumbar junction, there's a full S, then a lumbar lordosis. So it's right up to there. I said, uncle, you're good. He said, of course I'm good. And believe me, he improved. He again started walking. By this time, I didn't know whether teriparatide could be given again, but I didn't have the courage to do that. He then lived well for another 6 months only. At 6 months, he said, बेटा छाती भी बहुत दुखती है, लेकिन अभी वापस मेरा बैलेंस छूट रहा है. I said, I've done 4 surgeries. This cannot happen again. So I did another MRI. This MRI now showed me that this gentleman has popped a disc and cauda equina with spinal cord compression, everything happening at D3, D4 level. What would I do now? I had never seen such a patient. I said, uncle, mujhe nahi pata kya karna. I took opinions from people all over the world. There was nobody helping me at that time. I was already now 10 years older almost than what I was when I started working on him. I said, now I'm going to go something which and do something which is even more. So I went right up to D1. I removed that compression from there and put in not just screws, but I also put sublaminar wires at the laminae. I said, something is going wrong. And I went from D1 all the way down to the L4-5 level. Everything in one single construct. Having done that, He, by the grace of God, started walking with a walker and got his bladder and bowel back. This time he said, Beta, my cardiologist says chest में बहुत गड़बड़ है, कुछ ना कुछ करना पड़ेगा. Till now, I was scared. I said, now uncle, go ahead and do what you want. Because I was scared कि इसके बाद अगर ये आ गए तो मैं क्या करूँगा? Why should I stop him from living longer because of his cardiac ailment? He went for the cardiac procedure. Unfortunately, did not come back from the hospital. Ladies and gentlemen, I do not know what I would do had he come back with a C7T1 pathology. I have no answer. But he taught me that adjacent segment disease just exists. Anything from translation more than 4 millimeters to an angular change more than 10 degrees to severe collapse in intervertebral space to herniated nucleus pulposus to vertebral compression to pedicle screw loosening and non-union. These are the 6 types of ASD which are described. This man had all of those 6. How does one prevent it? No idea. You can replace this in the neck. Lumbar disc cannot be replaced as of today because we don't have access. You can use these flexible rods like I used, where we put in either a rod which has got a part which is solid and a part which is flexible, or one which has a drum in it, which is like this, which has a spring-loaded device. I've used both of them. That's the Soft Flex, the first one, and this is the Isobar TTL. Or I have tried these things which failed. Don't ever do it by putting an implant only on one side. This does not work. Anyway, you can put these interspinous spacers which came and went. You can do Charité which came and went. Love it or hate it, adjacent segment disease is here to stay. It's not that we can change the way we can think. I don't know whether genetic bioengineering will ever make a breakthrough. Unfortunately, I do not have an answer. You have your answer, I have my answer. The correct answer is somewhere in between. And I hope that someday, together, everyone achieves more as a team and we find some light at the end of the tunnel. Thank you very much for a patient hearing.
Thank you, sir. With that, we have Dr. Sanjay Dhawan to present a case on distal femur non-union.
Herculean task by Dr. Chadla sir. And the thing is that we should learn from him that how he managed to maintain the faith of the patient for so long. So that was a great learning. So this is a 54-year-old male, had a grade 2 compound fracture, intercondylar femur with bone loss. Patient had head injury, grade 1 compound injury in hand, also in mandible. There are associated injuries, but diabetic. So obvious choice of treatment. This is, we are talking about 15 years down the line. So,
sir, I think first we see grade 2. So if
it was just no infection. It was not contaminated. Inside out injury with the big wound.
So if it is not very bad and 15 years back.
Yeah.
So if it is not too bad, then and injury is not too old, within 6 hours, then I would do for acute fixation. Back then no nail, so plate, sir.
We do had interlocking nails, retrograde nails that time. But yes, the fragments seems to be short. At that time we didn't have CT on there also. So this at that time CT was not that popular in our area, and I was too young to convince the patient to get a CT for fracture. So now this is what, any comment on that? He was operated after controlling the diabetes.
Sir, looks good. The distal femur screws are all long. They are going too far on the medial side.
Yeah.
So stiffness is a risk here.
Okay. Anything else in this X-ray? Would like to add anything? It's perfectly done.
So there is some medial void. So in hindsight, you can say if this fails that you could have plated it, or you could have grafted it, or you could have docked it.
Yeah, it was bone grafted and chronos were used to fill the gap.
The antero-posterior screw which you see, that you have used as a lag screw or a position screw?
That's a fragment there, which is interfragmentary screws.
So it's just like a position screw, not a lag screw?
No.
So whether it is going to cause a lot of stress on the plate?
No, it's yes, but LCP was the very much in that time. And that was the time when if you talk of medial plating or supplementation, everybody was ready to kill you.
Yeah. So this is not classical, but it is going into kind of like a golf club kind of a deformity if you see on the medial side. If this does not unite on the medial side, you will lose that medial condyle. So
sir,
probably.
So
Okay, but that was not there. Okay,
to
I'll move ahead. Huh?
What we are trying to say is that it has a chance of medial non-union, risking the structure to go into varus collapse.
Went to varus collapse, yes.
As a result of which the plate will break at the site of fracture.
If you go to the literature later on, they say that if you have a gap of 1 centimeter, 1.5 centimeter, you can do away with the lateral plate alone. But that doesn't work actually. So that's what here is. This is at 4 months. Knee movement is 110 degree. So that is the problem is gone. What about weight bearing? Would you allow?
It is going into varus that we predicted. So on the medial side, you see the gap is slightly decreasing.
Slightly decreased, yes. So you'll not allow weight bearing, of course, because you are expecting that. Any intervention at this moment?
Pain?
No pain. So since I have done it, I would like God will help and it should unite at 4 months.
You are presenting, so kuch to hua rahega.
6 months. Now this is what is there. This will make you more clear actually that
it has collapsed and moved actually. And medial side, I think the medial fragment is just not going into union.
Yeah, you don't feel any sign. There is no infection, but there is no sign of union anywhere.
Union, and it is sliding up as well.
Sir, abhi CT कर सकते हैं शायद sir.
CT कर सकते हैं, yes. But then any intervention right now you would like to suggest? Still no pain.
So you see, the option is either you let this take its natural course, whether the plate breaks or it completely goes into non-union, it cutouts, or you can actually remove everything again and do a refixation. So these are the two options. And
why you want to, if the fixation is stable, why you want to fix it from, remove the plate and fix it?
Because you know that it's going to fail. And patient is weight bearing at this point?
No.
So that is the problem. 6 month patient is not weight bearing.
He is partial weight bearing with the knee brace.
Sir,
yeah,
sir,
only he is not, but not weight.
I think you're the primary surgeon.
Yeah.
If you know you're seeing this patient, it is very well fixed and stable. No need to remove the whole construct. You can either go just medially put some graft and put a medial plate and give a bicolumnar support and take care of the varus address, or take out the screws from distally, correct the deformity, and then put another plate.
Sir, sir,
I offered him,
Sir, if patient is not having any problem, he will not accept anything. Any surgery, he will not accept.
So, I offered him because for me, for last 2 X-rays, 2-3 X-rays, I was not seeing any signs of callus activity. So I suggested him to go for a plate, bone grafting, and if needed, medial plating. That time, medial plating was not at all in practice. So I suggested him, but because he was not having any problem.
At 6 months, if you don't have any progressive radiological signs of union, then you have to intervene.
So that's what I suggested him, but he didn't agree because he said, I have no problem. Why should I go for that?
Why did you put a short plate, but short plate?
Short plate.
Why?
15 years.
That's no, it's not the 15 years, but technically it should have been a little bit longer.
Long plate ka.
Yes, longer. This is one thing which you have to use a longer plate. So this was a learning curve. At that time, LCP, we started doing it, and we thought that LCP will do everything because we are out from DCS and all. So we thought this is a very good fixation. So now, what next?
Plate removal, freshening of the bone graft, and I think now if retrograde is available, a nail is available, then a retrograde nail with a plate on the lateral side.
Yeah.
Or so if nail is not available, then 2 plates, bone graft, freshening.
Yes, so you have all these options. And type of nail, of course, retrograde, antegrade does have no role here. So since those were the days when we used to see that if your plate has failed, go for a nailing and bone grafting. So this is a AO nail. With that flag, we thought that this will be very sturdy, and this is what was done at 11 months. I'm sorry for the poor quality X-ray that time. It's not digital
Spiral
X-ray.
blade.
Spiral blade is there with bone grafting. So we have to remove and do this. And he was just moving with partial weight bearing. So this is at 5 months now. I'll just move fast. So on X-ray it looks uniting callus activity is there, but of course the CT would have told you that it's not uniting, but on X-ray it seemed. Again, patient had no pain. So I moved ahead. A good range of knee motion still is there, almost same what it was there before. Now at 9 months, you can find anything.
Said looking like hypertrophism right from the previous X-ray.
So that was a bone graft actually. We have already put bone graft, so that has to do callus activity. Of course, otherwise it's a hypertrophic non-union.
Sir, this is going into non-union and varus.
Yes.
So we need to intervene or the nail will break.
Yes. So that's there. You see the toggling sign coming out there, and it's going into varus. So again, I advised revision surgery to him, and he didn't agree because he didn't had any problem. He said, I'm moving everything I'm doing, and he was happy with the knee brace. Now at 13-month post-op, if you just magnify, this is where the nail broke finally. So it's not very clear there, but now what?
Sir, same nail removal, re-nail with the thicker nail, increase the medullary canal vascularity, bone graft and a lateral plate, or if you don't want to re-nail, then 2 plates, medial and lateral plate.
Now which plate lateral?
I think we have failed 2 times. Now it has to be a final surgery.
Yeah.
So for me, I will remove this nail, put a long lateral plate up to the lesser trochanter, put a good sturdy plate on the medial side, total absolute stability with fibular struts in between, if I can, and cancellous graft. 1 final surgery. You can take help of a colleague or a junior or a senior, but 1 final surgery.
It failed because of the design of the nail. It has got only 2 screws.
That time that was the only available, and that was supposed to be the best one that time.
Yeah, so this nail is not the right nail to be done in the retrograde now.
So that's why I'm presenting it. So that's why it has gone. It's not in the market now. So lateral plate, what problem you are going to face putting lateral plate? Because now you have a big hump there.
Yeah, you can. I mean, you can just take it out. You can shave it off. You can. I mean,
sir, you can do a re-nail and a medial plate also, sir.
If you,
otherwise, this bump can be shaved off, and that bone can be used as bone graft also.
So the consensus is that you need to go for a dual plating. So what I decided, now this is what is the per-op picture. This is now 2 years down the line. The chronos which was used in the first surgery was still there lying. Didn't help at all. With the bone graft, I used it with bone graft, but it didn't work. For 2 years it didn't get incorporated. I had a lot of problem with that at that time because of lateral plate. And I was scared to shave it off because I thought whatever bone is there, it will give me a problem. So I was ready with all sorts of plates. So that is what I planned, that I use a medial plate, because at that time we didn't have any medial plate. The reverse plate of proximal tibia was used on the medial plate, and I tried with the lateral plate, I couldn't succeed. So I just used this plate, and this is what was done. So any comment on that with the bone grafting?
Short segment, sir.
Short segment, yes.
We needed something longer.
Yeah.
And your fixation in the distal fragment is also now 3.5 plate ke 3 screws distally, 3 or 4 screws distally on the medial side, and on the lateral side you have only 2 5 mm screws across the fracture. So it is not as rigid fixation that you would have wanted.
It has to be a longer plate on the lateral side, which was not done. But at that time, I was very scared of putting medial plate because everyone was not happy with the medial plate. They said that you are making a dead bone sandwich, so you have to use lateral. And nailing was not there, but on present scenario, I would have used for a nail and plate combination. That would have been a better.
Sir, and there
but
is still
finally,
varus, sir. There is still
yeah,
some
there
varus.
is a little bit of varus. But finally, went on to heal. I was lucky that it healed with the dual plane and bone grafting. So final union occurred at 3 years. Now this is a case study of 2012, and the picture here on the right side is on 2022. And this patient, after that third surgery, he was so scared that he never ever tried to go for a flexion of the knee, because he said probably this is the culprit. If I'll move the knee, it will break. So still he uses, for 10 years down the line after union, he is still using that flimsy knee brace. He comes to my clinic. Unfortunately, we have lost him 6 months back. But till his last breath, he was so scared that he never used. He was just thinking that this is something is going to help you. So the problem is that one single mistake, a basic mistake probably, which I did on the first operation, that I would have put a small plate and a bone grafted there, along with the bone grafted, probably would have saved the 3 years, productive years of this patient. And almost, because I changed his psyche, though I'm thankful to him and his family that they continue with the faith, but still I left with a stiff knee, which was not actually there, shouldn't have been there, but that's what the story is. So careful preoperative planning, create a detailed plan to minimize the risk of complications and optimize the chances of successful outcome. Fix all that needs to be fixed and get it right the first time to get the patient out of this trouble from the day one. Whenever you have a medial void, especially at metatarsal junction, needs some sort of medial supplementation, be a bone graft, medial plate, bone cement or nail, depending on the situation. And if good bone impaction, bone grafting is possible, then only you can have a single LCP. Otherwise, if you have a medial void, always go in and add medial plate. If you don't get a proper impaction bone grafting, go for a dual plating or some sort of support. Once you encounter a non-union, assess properly and plan perfectly. Be ready with all possible options. In present scenario, recommendation is to go for a dual fixation. So in my case, I have done 2 mistakes in the beginning, that I didn't put a medial plate and the plate should have been longer. Though the longer plate wouldn't have helped me, but secondly, in the final operation again, in today's scenario, with all these knowledge, I would go for a longer plate.
So just primarily you will go for a medial plate in such a situation?
Yes, because that
primarily.
Yes, there is a big void. Nail or plate combination I would prefer in today's scenario, or if you are plating it, just you are taking a swashbuckler approach, just a small medial plate will help you. And even this 1/3 tubular plate, not 1/3 tubular plate, this is a forearm plate, if you just curve it and fix it, I have done it. It works very well.
So I think just one small point is that 6 months, if the patient comes back to you, you have operated it and the lateral fixation is very strong, don't hesitate and go ahead and do a medial plate and grafting. That can also help the patient.
I offered him, but the problem is if the patient doesn't have problem, he doesn't agree.
Yeah,
I tried my
best. From this, that lateral plate was not good enough.
No, that was not good enough.
For a medial plate to come back.
But to have the whole revision, a small procedure is always helpful.
Anyway, thank you.
Thank you so much, sir. This was a great talk, great cases. I think Dr. Amresh Ghai is next for complex lower limb trauma, amputation versus limb salvage.
Thank you, respected chairpersons and Dr. Amul, for giving me this opportunity to present. The basic philosophy of this presentation is when to draw the line between trying to salvage a limb and to sacrifice a limb. Are we looking at only preserving a God-given anatomical limb, or do we need a functional limb? Do we need to give a patient back a quality of life, or do we need to keep struggling and spending sufficient man hours, probably also satisfying our own ego and trying to achieve a union at the cost of the functionality of the limb? So if I am presenting 3 cases, I have 8 minutes. So I'll present this first case and then I'll go back to the third case, because there are 2 contrasts. One is more or less a success story and the one is not. So my first case is a 31-year-old male, grade 3B comminuted fracture of the distal femur with the intra-articular extension and with a concomitant fracture, ipsilateral fracture patella, sustained in a road traffic accident. That's what the initial X-ray looks like. Yep. So any special investigations excepting for a CT scan? Okay. Would you like to, at this point of time, it's a grade 2 fracture, so would you like to go in for a definitive fixation, or would you like to probably just use a fixator and then come back subsequently?
So it all depends upon where the fracture has been handled at the first go. Who has handled it? If your unit has handled it, if you yourself are very confident with your team, you can go with a definitive fixation if the contamination is not too much.
True. So at a tertiary care center, you would prefer to go in for a definitive fixation. And would you like to close the wound at this junction?
It needs a good debridement, good wash. At the end of wash and debridement, assessment of how good the debridement is, definitely I will try to close the wound.
So the take-home message you would want to close it. Any role of bone grafting in the primary stage?
Yeah, maybe.
It depends on from case to case scenario. Seeing this kind of a communication, you'll have a divided house. Someone would like to go in for a separate, but since you're going in for a definitive fixation, you can think of a bone graft, but the copybook teaching is avoided in the first case. So anyway, what was done was wound debridement, knee spanning external fixation with multiple K-wires. This is day 2 of the injury. I'll skip the literature part of it. This is what the wound looked like at 2 weeks. Now, subsequently, the fixator was removed, proximal tibial skeletal traction was applied. Now what would you like to do? Means we go back to the first slide. We are back with in the same scenario, but now the wound is healthy.
I have to ask a question. This K-wire in distal femur, is it a recommended thing?
No, basically, so what happens is when you're putting a fixator, when you're looking at the C-arm, you want to keep the bone pieces together.
But you can always have plates over there also. You are putting K-wires, there are also implants, so many K-wires. They can get infected.
True.
So the pre-op X-ray does not show intra-articular combination so much. There is a metadiaphyseal combination is extending up. You could put one screw and convert it into an extra-article if that was the case.
That's a pre-op.
Yeah,
that's
put one screw. But so many wires is not good for this combination in that kind of a wound which you have shown. I think, sir is absolutely correct. Amit sir, yeah. I think
this is after almost 2 weeks post-op.
So I think
at 2 weeks, what was basically done was a temporary stabilization.
Did you have the wound connecting to the joint intra-articular?
Yes, sir.
Wound was connecting intra-articular.
Because there was ipsilateral fracture patella also.
Yeah. So what I would have done in that case, give a good wash and did a primary nailing.
Yeah. Absolutely perfect.
Or you could have, after putting those K-wires, sir, I think...
At this juncture now, sir, would anyone prefer doing, would you again go in for a fixation with a grafting? Whether it's a nail, whether it's a plate?
Now, with this fixator, now it's, I think, probably infected.
No, now the infection is controlled.
The K-wires.
So now the infection was controlled. 2 weeks later,
but it's difficult.
So in this scenario, there are 2 possibilities. Okay, so you have done it, but then I'll be very skeptical. Suppose this was done in trauma and it was sent to me. The patient was referred back to me in the department.
19 months in the hospital.
And I think the plastics have also done their part in the leg as well.
Yeah,
they have done rotational flap and everything
so
is there.
What we always end up classically when you receive a patient back from the plastic surgeon is a stiff knee, a stiff joint below.
So I think this patients need a lot of counseling.
And for
the ankle is not going.
You will only be able to get a plantigrade ankle. You will not be able to give him a mobile ankle. He is only 32 years old.
Sir,
so my question is, would you want an amputation? Would you offer him an amputation, or would you want to salvage the limb? That's the question to you. That's the question to the house.
Sir, मेरा विश्वास है कि मेरी शादी है तो मैं डिसाइड करूँगा लड़की कौन है.
Perfect.
मेरा बाप नहीं डिसाइड कर सकता कौन है लड़की, तो पेशेंट डिसाइड करेगा क्या होना है. I can give him both options, that I can try and give you fusion, and how functional the limb will be, that I cannot tell you, and I can give you an option of an amputation, and this has to be the patient decision. We are not gods at surgeons, we should not decide. We can only give options.
Would you not?
But I think, sir, the point is if it's a survived limb, it's a 32-year-old male, in my setup, in my practice, I will never amputate this because of myself. Because
absolutely correct.
I can't take the decision for the patient.
There is no contention. There is no contention on that.
From down and take care of the ankle in this tibial non-union, and can give him a plantigrade ankle, and he can weight bear on with a caliper.
So I'm from the army, so I could retain him for 15 months. How many of you will be able to keep your patients with you for such a long time? That also is a parameter of consideration.
Samarth, can I?
So can we move?
How's the sensation in the sole? If the sensation is good,
it's sensate. It's sensate.
If it is sensate, there is no reason to amputate. It might be stiff, but no artificial limb is going to replace a sensate foot.
Anyway, this time he chose for the amputation, and that is the picture. That's the present status.
You can just chop it out, get a freshening and go a retrograde nail. And that will suffice because you have a plantigrade, even with the this thing also amputation. The thing is that if you want to amputate hip, then you have to counsel to the day 1. Because if this decision would have been taken on the day 1, he would have a mobile knee. Now he is with the stiff knee and amputation. So from day 1, he would have had a flexion. Though it's a very difficult decision, but the counseling has to be done on the day 1.
Thank you very much, sir. Very interesting cases and a lot of learning. And thank you, Dr. Amrish. So we'll now like to hear Dr. Amit Ajgaonkar, sir, on his talk on non-union in intertrochanteric fracture.
Intertroch नहीं है वो subtroch है ना, whatever it is. हाँ, simple case, एकदम simple, nothing much done. Yeah, tell me now what to do. Very simple.
Nail, sir.
Nail.
Nail.
Only nail.
Cephalomedullary nail, sir.
Yeah. Cephalomedullary nail, but only nail with plate. Subtroch है ना?
Only nail, sir. This is far down, sir.
Open it or what?
I will try for a closed, but good reduction. Open or closed does not matter. Good reduction and a nail.
But you see this, you can see this. There is a impacted butterfly, and there is a look. There is a void starting from here.
Sir, closed fracture, sir.
Closed fracture.
So
subtroch level. Closed nailing, as you said. Closed nailing. How will you get that butterfly back? This, Sanjay?
Yes, sir. Is the rotation?
Yeah, there is a rotation. Okay, agreed. But even
there
if
is
I
a
would
rotation,
have got,
and still I will say the point of entry is not perfect. You have to have more medial entry to make it straight, and you should have a nail which is having a much better locking option proximally.
So
it has to be some sort of 4 screws there. Expert femoral nails probably would have been a better choice, except for PFN. That will make a straighter, because still the fracture is in the varus, sir, and rotation.
There is varus, sir. If you see the proximal screws, they start lower down in the neck and they go higher up in the head. So this is a sign of classical varus. So when I meant nail, I meant good reduction, and varus has to be right. Subtroch fractures.
No, okay. If I would have got a better reduction over here, but what about this void? If it was left like this, is it okay? I would not have got a closed reduction of this butterfly.
So if the rotation was correct, and in a subtroch, what I ideally feel now, even now not medial to the tip of GT, it is almost like a piriformis entry, so that you don't end up in varus. If the rotation was correct, so much of void you would not see. This is because of the translation of the proximal fragment laterally and the rotational malrotation that we see so much of void. Only that piece is there. The entry is the problem, like sir has mentioned.
What I feel is I should have opened it and reduced it properly and got a perfect medial continuity. In subtrochs, medial continuity is very important. You can't have gaps in subtroch. This was around 5 months. So when to intervene, and if not, should I continue with this?
See, even with the 2 screws, Dr. Amit, even with the 2 screws, it is varus and instability also there. Proximal fragment is wobbling. You cannot hold the proximal fragment with these 2 screws. So it has to have at least 2 more screws, one at
more
least
screw
transfer
over
screw there. So nail should have that stability. So if you have a perfect reduction, no varus, entry is correct, and then you have a 3 screws, probably that will help you without going into the medial side, because medial side is more vascular. If your alignment is correct and stability is better, you could do away with that.
Sir, I will revise at this stage. The proximal screw also, the tip apex distance of the most proximal screw is almost close to 5 from the previous X-ray, sir, not on this. The TAD of the most proximal screw is not something. I think with this nail, there is a high chance of Z effect and reverse Z effect. There is a high chance that this screw also might go in or out.
This is a AFN nail, where both the screws are the same size.
Yeah, recon.
It's not
nail,
a PFN.
Yeah, recon nail, sir.
Recon.
But the proximal screw can move a little, and it is very close to the joint, sir.
Okay. So at this stage, you can revise 5 months or whatever, 6 months. With what?
Sir, at 5 months I will revise with nail and a plate with
you will open it. Open it.
Open it, sir.
Open
at
it.
5 months.
Open it, and then what?
Clean, wash, remove the nail, put in a thicker nail, get the alignment right first. Maybe to get that alignment and keep it there when I'm nailing it, I might need a small plate on the lateral cortex just to get the valgus right, and then nail and keep a plate on the anterior aspect or the lateral aspect with a lot of copious bone graft, sir. And if I want, I can put in a
bone graft where?
Sir, medial. Wherever
medial.
I have gap.
Would you put a strut graft?
Medial, that is what I was saying, sir. Fibula strut I can put, sir.
Fibula strut you would
yes,
put.
Sir.
Then you cannot nail it.
No.
No, he's talking about an onlay.
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 If you're going to open it, then you can use a unicortical plate or one-sided plate. But if you're going to open it, direct reduction you're going to do in front of you. You can match the rotation and get a good continuity on the medial side also by direct reduction if you're opening it. So you can just do it by manual maneuvers.
Would you put a condylar blade plate and another plate, or only a condylar blade plate?
I think only condylar blade plate would also suffice if you have a good inlay or an onlay graft, because condylar blade plate is biomechanically much stronger than the routine surface implants that we are using.
Okay, Amit and panelists, Amit, can we have any tips and tricks for changing the point of entry in such situation? So from the panelist or you yourself, because you already have a wrong entry point. Now if you want to go medialize
I had put it from the tip of the GT, and the AFN nail or the recon nail is suggested to go from the tip of the GT or slightly medial, or you say piriformis fossa.
Sir, see, my take is in subtrochanteric fracture, by use any nail, it has to be medial to the tip of the trochanter, because that adds to your valgus.
Yeah. So just to answer your question, sir, you want to change the entry point now. Let's forget the case. The entry point, if it needs changing, one is getting a good reduction first. So a lateral small plate, put it in this hole, and then make a medial entry, and then you put your reamer, and the plate will act as a lateral wall so that you don't ream more lateral. Otherwise what will happen, no matter what entry point you make, the reamer is anyways going to ream what is already reamed, and it will keep coming more lateral. So to push more medial, use a blocking. Sometimes I use a Cobb's periosteal elevator, keep it in this gap, put a reamer, and try to use a reamer like a cheese cutter reamer or a channel reamer.
Yeah, or you can use a long artery also, put it inside that hole and then ream it again.
Yes.
But all likely while inserting the nail, you have to push it more medially and then lock it. So after you lock it, then only release the pressure medially. What I did was this: exchange nailing, shingling, bone graft, intramedullary plus on the medial side. Intramedullary was just a crushed bone.
So are you happy with the medial void?
I was happy on table. Everything was there properly. It was very sturdy. But look what is happening. I'll show you. Shingling is, I think most of you know what is shingling. By the use of a chisel, 10 millimeters or 20 bone chips, unicortical, are just elevated from both the sides. It's like this. You just put and just elevate. Yeah. So that is shingling. And this is at 1 month. This is at 3 months. I will, of course. I have put, though I was really surprised that it's not seen radiologically. This is 6 months. Now? No pain.
I think if I am the operating surgeon and I think I have done a good job, then some of these fractures take a longer time to heal.
This is at 8 months. Age was around, look, it's written somewhere, 59, 60.
CT scan, sir. At 8 months, if there is still no
Actually, I lost this patient after 8 months. He didn't come to me. And suddenly after a year or 2 years, I saw him walking on the road. Here he was, and he was very comfortable walking on the road. There.
So to be very honest, I'm very happy with the last X-ray actually.
You are happy?
Yeah, because I mean, we want to do a CT as orthopedic surgeons.
If you can
three
see,
sides, 3 sides are taking up. Maybe it will take 12 months to
unite.
unite.
Yeah, exactly.
Subtrocks, and especially a subtroch non-union, is going to take at least 12 to 14 months to unite after the second surgery.
So I was also happy looking at this X-ray, and the patient was very much happy because he was walking there, and there he was. And this 3 years. 3 years.
It was taking up in the last X-ray. It was very good actually the last. I was skeptical about the first X-ray that you showed post-op. It was showing some translation. But it
so
is
basically,
very well
subtroch fractures do not tolerate gaps on the medial side. There should be continuity. Primary bone grafting can be done if there is a major bone loss medially with a discontinuity. Shingling and bone grafting is necessary for uninfected gaps. Thank you.
Thank you very much, sir. That's a very good case, and I think it gives a lot of teaching. With that, we call an end to the session.
Dr. Samarth, I want to add something. Sir, very nice case, but I think the last point you showed that the medial continuity is important. But I think the plan and the execution of augmentation was the more important here. What you did in the second case was augmenting it. You augmented it with a plate, you augmented it with bone grafts, and that was more important.
Correct, but Aditya, primarily I had not got continuity on the medial side. I was not happy there.
But
primarily,
sir,
even
sir,
if you do a single implant.
Sir, but I think if you are doing any surgery, it should be by the principle. If you are doing it as a close reduction, then there is a very good saying that if you're doing close reduction, then you should take any bone as a black box. You cannot see it, you cannot touch it. If you are touching it, you are seeing it openly, then it's the concept of intramedullary bridging and callus doesn't.
No. Now, subtrochanteric fractures, even if you are opening up,
yes,
you have to get a good union.
I think
reduction.
We can continue this discussion
Medial
without the
reduction
mics.
is very important.
I request the next chairpersons to kindly come. We call an end to this session. I request Dr. N.K. Singh, Dr. Mithilesh Kumar, Dr. Ratnesh Singh and Dr. Bipul Prakash here, and I request Dr. Samarth Mittal to present his.
Thank you, everyone. Ratnesh.
Thank you. So, I'll be presenting on plating in coronal. हाँ आ जाएगा सर. तब तक time use कर रहा हूँ. Screen. Yeah. So I'll be talking on plating in coronal plane fractures of distal femur. I know by coronal plane fractures of distal femur we usually think of Hoffa fractures, but Hoffa fractures are not the only fracture of the coronal plane. Hoffa fractures are only fractures of the posterior part of the condyle. If there is a metaphyseal extension or even a trochlear fracture, these are also coronal shear injuries. And we know from our experience with Hoffa fractures, there is a lot of debate, A to P screws, P to A screws. P to A screws are biomechanically superior, but slightly more challenging from surgical standpoint. Number of screws, 3 screws are obviously better than 2, but if there a study will come, 4 screws will always be better than 3, 5 screws will be better than 4. The more the number of screws, the thicker the diameter of the screws, the stronger the fixation will be. How much do we need biologically or biomechanically is still debatable. A lot of studies are going on, but if you have a very unstable fracture pattern, you can keep adding screws P to A to P, medial to lateral, lateral to medial on the fracture configuration. So I've shown you some of my patients where I've put different configuration of screws. And a lot of studies have been conducted, and all these are mechanical studies where all of them say if you add a plate, it adds to the stability. If you add more screws, it adds to the stability. If you go from posterior to anterior, it adds to the stability. So whenever you want more stability, go from posterior to anterior and then add more screws and then add a plate. And probably if there is a study that says you add 2 plates, it will obviously be more stable. But starting from that, I come to this, a 42-year-old male, history of road traffic accident. These are the AP and lateral views. Anyone who wants to conserve this patient, not operate? No one. So how would you want to operate? Dr. Rohan? CT scan? You want a CT? That's the CT scan. So posterolateral component and articular impaction going into the joint, small piece. Amit sir.
Yeah, I would reduce that intra-articular portion, and probably this is a spike which is going metaphyseally, so a plate would be better.
Anyone else? Any other thoughts?
The beak is on the posterior side, so
yes.
You have to buttress that beak from posterolateral side.
Perfect.
That is very important to prevent the collapse.
Yes.
So 2 plates, one from posterior,
one from lateral,
and one from lateral.
And something for the joint, sir. What about the joint? The small, yeah. the small articular piece. If you see this piece here,
that has to be reduced and fixed with the lateral plate.
Okay. Fine, sir. Any other thoughts from anyone? Dr. Puneet, your thoughts? Fine. So I'll just go on to the intra-op picture. Most of the times when you get these patients, those small fragments are like this, and they have little subchondral bone to them, and they are broken off at the articular level. So you see there is a technique where you can use a transosseous PDS suture to get those cartilage fragments right. So if you have a lot of comminution, sometimes these become the critical fragments. The moment this fragment falls in place and you try to reduce the metaphyseal spike, then the joint reduces. So getting this right is important, and especially when this is the weight bearing area. So I put PDS to make these 3 fragments into one, and then a subchondral small wire putting it into back, and then I reduce the metaphyseal spike. This is a osteotomy plate of a distal femur, because the distal femur lateral plate, if I show you the x-rays, usually they sit on this aspect. They miss out completely here. So you need something that falls posterior, and hence I have used a osteotomy plate which goes more posterior, and I have slightly tilted it to put it in that manner. How I did it is I used a shank spin to reduce the fragment, the lateral fragment, and headless screws to get reduction and fixation of this small fragment after the PDS suture, and then I used a osteotomy plate, yes, to add to the, you see this screw here is to get the metaphyseal spike perfectly right. Hindsight, I could have added a lateral, posterior lateral plate like one of our panelists has suggested, and then I added these screws and 3 6.5 mm screws in a to P direction to get more stability. And this is the immediate post-operative X-ray of the patient. You see this plate is slightly lying anterior because I've tilted the plate distally posterior, so it's coming anterior at the proximal part.
You didn't buttress the apex?
So I've buttressed the apex here, but not at the posterior part, sir. Yes. No, the plate is on the buttress only on the posterior lateral side, not on the posterior side. Like. So that will be a buttress plate. What I've done here is I've used it as a neutralization locking plate. I have locking screws going on to the distal fragment. With the posterior buttress plate, yes, it will add more strength biomechanically, I agree. This is the immediate post-op X-ray. This is the 1-year follow-up of the patient with good range of motion. Thankfully, this did not fail, but like everyone has said, adding a posterior lateral plate would have helped. Another case, I have time left. So another case, anyone, I think a CT is required in these normal looking X-rays, and when you get a CT done, you have sometimes a fracture like this on the medial side. So same opinion, posterior medial plate. So here, Rohan, for you a posterior medial plate. And posterior medial plate or a medial plate?
I will first do a posterior, buttress.
Mm-hmm.
And if I need a medial plate, I'll add another one.
Perfect.
Whenever there is a medial beak, whenever there is a metaphyseal beak, then you should buttress it.
Perfect. So that's the same message that I want to give. In these innocuous looking fractures, the point is to reduce the beak and put a plate on the beak of the fracture. And sometimes when they have 2 beaks, you need to put 2 plates. What happens is these fragments can rotate in this direction and they can displace in this direction. With a beak at the back, you prevent this, but this movement does not stop. So sometimes you need 2 orthogonal plates, and they can be something as simple as a forearm plate and a 1/3 tubular plate. If you block this movement in both the directions, add a plate, and both of them can be pure buttress plates, then you will have good stability and good outcome, which is what we did for this patient. We did not do a subvastus approach, we did a medial approach, but that is the same, whatever approach you use, if you get to the posterior medial and the medial corner, then that is good enough. This is the follow-up of the patient. Another similar patient, posterior lateral corner, again a buttress, sir. So like everyone says a buttress, so I'm skipping the CT. A posterior lateral plate, which everyone wanted in that case, and a lateral plate. So if you add a lateral plate, you see this fracture still keeps moving because you are just blocking one movement. The moment you add a posterior plate, it blocks movement in both the planes. So coronal and sagittal, both the planes need to be addressed. And then you add stability and they will have good outcomes. Something like this, one of my colleagues has done this. It has failed posteriorly because there was no plate posteriorly. All I did is removed what he did and just added, the patient did not have much fun, so I've taken a long plate, cut it, and used the cut plate on the lateral point and a posterior plate, and I've fixed the same patient. These screws were from the old surgery. I've just reduced it at the spike, and this is the follow-up outcome of the patient. Thank you.
You can use even you can use the low profile plates and very thin plates also. That also works.
So I've shown a 1/3 tubular plate in a femur.
1/3 works, even the T plate works.
Yes, so as long as you block both the movements in both the planes, they are acting as buttress plates. I think it works. Mostly I use a 3.5 forearm plate, but you could use a recon plate or anything else as well.
So the message from your talk, Samarth, would be to use 2 plates in all the HOPAs? To use 2 plates in all the HOPAs fractures? Because if all the HOPAs have an apex going back, is the message is that use 2 plates or just buttress it posteriorly?
Sir, in HOPAs fractures, they will not have metaphyseal part at all. So HOPAs fractures need P2A screws mostly.
The one which is going
HOPAs with metaphyseal, you see on the CT if they have a only posterior spike or a medial and posterior or a lateral and posterior. They will definitely have a posterior spike most of the time. So add a posterior plate for sure and check if there is a spike going medially, which corner it is. It is like a proximal tibia. You need a posterior medial plate, and sometimes you need both plates. So where the apex of the fracture is coming, if there are 2 apices, then you need 2 plates. That's what I think.
Great.
Thank you.
You are using lateral.
So I think he is trying to address the elephant in the house. It is easy to say, but sometimes adding a posterior medial plate and a posterior lateral plate can be challenging. It is easy to put those plates if you take off the MCL and the LCL. It is very easy, but the problem is to put them on with the MCL and LCL on. So
that is why I asked. It is important to put 2 always every time. That is
so if you are doing posterior medial, at least for me, going anterior does not help. I need to go medial so that I can go posterior medial. But for lateral, if you're going lateral and you flex the knee a lot, then you get some relaxation of the tissues and then you can put a posterior plate. Yes, putting in the distal most screws can be challenging with the LCL and the hamstrings on. If you take them off, then the clinical picture and the x-rays look really good, great, but the patient is never happy.
Which position you are using to fix this fracture, supine or lateral?
Sir, most of my fixations are in supine position because I feel it is much faster positioning the patient, getting the patients out. It saves me time even for my proximal tibias, even posterior lateral corner, posterior medial, posterior, everything I am doing only in supine position.
Yeah. So
femur nailing.
Yeah.
Dr. Ajit.
Yeah. Ajit nahi, Amit hai.
Amit. Sorry.
Okay. Acha, distal femur nail, the day before I was just talking about that we should be doing more and more of distal femur nails with the correct design and the correct length. So look at this. This was a patient wherein, I thought of doing a nail and this is the position I generally do. This is on a tibia frame, but nowadays I put a pillow, a rolled up pillow, and so that the pillow can be just moved up and down on the femur, so you get a good reduction. That's a small infrapatellar incision you take and go ahead. And this is the guide wire with the introducer, and this introducer, the guide wire is kept slightly out, and there it goes inside exactly center in both Blumenstedt's line, anterior line, and this is the way it goes. If at all it is slightly away, then you can just turn your bevel. It is in this fashion. You can turn the bevel and make it central. This is the way you just put it inside and put a long guide wire, remove your introducer, and then you can use a finger. This finger instrument here. Wait, I'll just. Here we were putting just because to get a good slightly better reduction, polar screw. So this is the nail exactly, And this is the nail with all these 4 lockings in the distal part. Look at the screws pitch, and it gets locked in the near cortex whenever it's passed. So this is the way we put the nail. It's a very simple procedure. It goes there inside from the distal part. C1 type of fractures, I do it regularly, but C2, C3 also I would recommend if there's good bone stock in the distal fragment to take 2-3 screws. The plate takes 2-3 screws, so why not a nail? Nail is a better implant. You need not worry of your combination. Now look, this is another C1 type of fracture, severe combination, metaphyseal. So what we did is about this. And these are the condylar screws. These get locked from both the sides. If you have, if you're not confident of your C1 type extension, you may use patella holding forceps, or you may put K-wires anteriorly, or you may pass screws anteriorly to get an intra-articular reduction and then pass the nail. And this is at 14 months, the patient is doing well. Generally, a nail is a very, very simple procedure, nailing. And it hardly takes time, and it gives better results because of its biomechanical advantage. No patellofemoral joint problems. Now look at this. This has got good enough bone stock, and we put this, just a small infrapatellar, no need of opening that whole thing and passing a plate. And here, look at this. The nail design should be good. You should get at least 3-4 distal locking screws in multiplanar and multiple directions, and it should go up to the lesser trochanter. It should not be a short nail. I generally lock it antero-posteriorly up. And here, this is day 1. Another patient, C1 type of fracture, look at the metaphyseal combination. We would have definitely discussed over here, medial plate, this, that, after doing a lateral plate, but why not do this? Look, don't look at the metaphyseal combination. You should get good hold in the distal fragment. We have used those 2 condylar screws, you can see. They have got a male and female component. This design is particular. I think the design has to travel. This nail marketing should be done everywhere, all over the country. Probably it's not available. Everywhere, this is 6 weeks. Distal end of the bones are funnel shaped. If you have porotic bones, then this happens. But to prevent that, you may use blocking screws and then put the locking screws, and then you will get a good calyx. And I do it now for all fractures which are below the mid shaft. This is a segmental fracture, and look at this. It is basically a distal load bearing implant. You can start day 2 knee mobilizations and day 15 full weight bearing mobilization. Look at this. This is an oblique fracture, junctional fracture, and here we have done this. And I have very few indications for the antegrade nail now. And for all these fractures, I do the distal femur because it automatically centralizes in the distal fragment. It has got multiple screws in the distal fragment. What happens with the antegrade nail with 2 locking screws is this transitional movement. And this causes instability. And this causes the non-unions. And here we did this for that type of a fracture. 4 screws, distal locking, 2 obliques and 2 lateromedials are good enough. There are different designs, but multiplanar, multiple lockings in the distal fragment. Now this was a very challenging case. 4-part fracture. What I did is, I first reduced the medial condyle, then put the distal femur nail. After that, I went ahead and these are the condylar screws. You can see from both the sides I am locking using both the sides screwdrivers. And there it went up. This is the AP locking at the lesser trochanter. DHS for the upper one, DHS hole I got through the DHS as well as the nail and out. And there, this was the final construct. After 15 days, I rotated that butterfly, which was not needed to be done. I rotated it 5 months. This is 18 months down the line. And this patient united in one surgery. So plan it out in such a way that patients do well in one surgery. And this is another case, junctional fracture. I did this. This is at 3 weeks. And this patient is doing well. He's got good range of movements. He's doing good. And yeah, so distal femur nail using the correct design length has made life very, very easy. If you are operating, if you have combination, if you think otherwise, if you're not getting good hold in the distal, you may add a plate. But a nail for distal femur fractures, please try doing it and do not have inhibitions to enter the joint. Femur fracture from the mid shaft to the knee also can be nailed by a distal femur nail. Entry point Centralization of the nail in the distal fragment is very important. Use the proper instruments, polar screws if needed, and multiplanar, multi-level, multiple lockings is very, very important. Thank you.
Thank you, Amit. Next speaker is Dr. Manoj Padman. He is speaking on treating recurrent osteosarcoma.
Just to add the distal femoral nail, the Synthes recently came up with the nail plate construct that is more stable and yet to launch in the India.
But do not think that Synthes is only right. Indian manufacturers are better. I'm telling you, do not go on Synthes always.
No, they have different concept.
Yes, but look at that nail which they had made with a spiral plate. Was that concept right?
No.
Sanjay presented. It was not right concept. So do not think that Synthes is God.
Nebula is also giving good DF and they are having four 5 screw in the distal fragment. Nebula nail.
Good morning, everyone. So, those who are in the hall waiting to hear about the recurrent osteosarcoma have to wait until the next speaker. So, I'm going to talk about sequelae in pediatric hips. And sequelae can be from a range of etiologies, but my remit is going to be, I'm talking on post-septic sequelae, a fairly common situation and very challenging situation. So, what do we understand by sequelae? Some form of deformation of the hip, usually the proximal femur. It can be extra or intra-articular, and there is correspondent consequent acetabular changes, eventually leading to premature degenerative arthritis. And throughout, until it leads to, it's not as if like the arthritis is an endpoint. Until that point, the child, or adolescent, or the young adult continues to limp, have pain, stiffness, functional restriction. So it's not as if like, it's arthritis and nothing happens in between. And why does it happen? It's usually a manifestation, it's almost inevitably a manifestation of the proximal femoral growth disturbance, and that causes an extra-articular disturbance. Why does it happen? There is relative growth between the femoral neck, there is mismatch between the femoral growth and neck growth and the trochanteric growth. So the insult happens usually, and as a result of it, this growth stops. And the trochanter remains kind of relatively untouched and continues to overgrow, as a result of which varying degrees of varus or valgus and torsional deformity, producing coxa breva, coxa magna, coxa vara, and things like that. In addition to that, there is avascularity of the femoral head itself, or the capital femoral epiphysis, which makes the femoral head deform. Sometimes in a very young age, the femoral head epiphysis completely disappears. So, and it is not a one-off event, it changes during childhood. So here is a neonatal septic arthritis, bilateral septic arthritis, which is treated with Pavlik harness, and at around 18 months, his left hip was operated upon, implants come out, and this is the net result at 4 years. And you can think, okay, that's not too bad, some sort of a femoral head is inside. Look what happens as the child grows. Further 7 years down the line, the head, whatever remnant is still in the acetabulum, you can see that the trochanter kind of continues to overgrow, and this child was lost for follow-up. There are things that you can do at that stage. You can stop the trochanter from growing, and that's how at 9 she presents, because now you can see there is going to be abductor insufficiency, gait abnormality, significant impingement, extra-articular impingement, and a whole bunch of problems which are going to increase and cause problems. So it changes. So I'm just going to touch upon present you two cases at two extremes, one early on and one closer to adolescence. So here is the first one. It's a 4-year-old when he presented to me, left-sided limb from the time he started walking. He had neonatal septic arthritis, which had been operated thrice for whatever reason. There are no signs of active sepsis at this point. And this is how he's presenting. Okay? X-ray can be quite daunting, but you just have to kind of look at sequentially how to kind of address this. So it's not just at the hip, there is acetabular changes. You can see that the teardrop is so well developed here. This is already kind of starting to show extensive dysplasia. So you do a traction, you try to see if it moves. The pseudoarthrosis is stiff, there is no sign of movement, and the limb length discrepancy at this point in time at 4.5, as a rule of thumb, it's going to at least double. So the MRI, you obviously want to know, not that it's going to influence the management, but it will give you some pointers. It's not going to, there's no magic answer from the MRI. And yes, you can use any form of classification to kind of this thing, but what I usually like to look at this is, I try to list out what are the problems, irrespective of what Choi classification, Hanka classification, whatever you use. So you have a situation where all these problems are there. There is mechanical instability. We do not know what is the viability, even though the MRI report says that the signal changes are identical, and none of you would be comfortable accepting that this epiphysis is viable and just as normal as the other side. There's a high riding trochanter. This is just where the bony end, probably the cartilaginous is probably at least another 2 centimeters proximal to that. Acetabulum is this. Why is it important that the acetabulum? I keep harping about the acetabulum because at some point if you consider femoral lengthening, if you don't have a stable socket, that hip is going to come out. So you need to kind of factor that in. And of course, limb length discrepancy. When you list out, then you can think about what are the ways, then it's a little bit more easier to kind of think about how to approach it. So if you think, okay, I've got an unstable construct, what am I going to do? I have these options. Viability, I need to be careful about, I don't want to kind of add on to the vascular insult. So I'm going to have problems with fixation, getting hold in that epiphysis. High riding trochanter, I can consider a valgus osteotomy and bring it down. For the acetabulum, do I think about a pelvic osteotomy at this stage? And limb length discrepancy is something that I would kind of wait until later to manage. And this I touched upon yesterday as well. Those of us who deal with pediatrics, we want to live and the patient's joint to survive to fight the battle at another day. Okay, so sometimes, we don't want to do all of it in one stage. So these are the technical issues, okay, which I touched upon. So what am I going to do in this, So here is this. This is what I chose to do. So I chose to do a subtrochanteric valgus osteotomy. I get an end-to-side apposition. I'm not interested in end-to-end contact. So this is the end of the distal fragment, and that's the side of the proximal fragment. I have a fibular strut going across. So that's end-to-side apposition. I have a fibular strut going across the neck, recreating the neck. Okay? And just to kind of explain it a bit further, so that's the head, that's the tip of the trochanter, that's the lesser trochanter. And the corresponding points are, that's the head, that's where my greater trochanter, I brought it distalized, and that's where the lesser trochanter is. Yeah? So I always after this want to see what the joint is, and there is no better way to visualize. No MRI is going to give you this information. So I can see that the head is sitting very well. Am I happy with that? I still talked about the acetabular dysplasia because I know that I'm going to have to lengthen this femur, so I'm going to have that socket brought down. So I add an acetabuloplasty to kind of address the dysplasia at that stage. So immobilize it in a spica. Believe me, they're quite robust fixations. You almost think, oh, do I need a spica? So that's him at 3 months starting to weight bear. And lo and behold, after 3 months after weight bearing, he went and broke his distal femur. Okay, unrelated to this, had a fall and which was managed conservatively. This was during COVID time, so it was managed elsewhere. So that's him at 16 months down the line. And pediatric orthopedics, and for all orthopedics, there's a famous saying by Robert Salter, there is nothing which screws up or buggers a good result like follow-up. Okay, you have a great result and you can go happy. There's nothing which screws up a good result like follow-up. So you have 16 months. Are you concerned? So I'm concerned about what's happening here. By now I should have seen a bit of a neck. So I take a CT and there you go, fantastic X-ray on day 1, month 6, but look at what's happening. So I went back in, redid the fibula graft, exchanged the screws to longer screws. Went on to Unite. Okay, that's 2.5 years after my after my reconstruction, not the revision. LLD is come down because of the valgus, but it will continue to increase. Okay, this is when he came back for implant removal. Implant needs to come out, needs to be removed because there is going to be subsequent surgery on that hip. I always do an arthrogram at that stage. Nice pictures, looking like that. That's great, reasonably well shaped. But when I load it, it's starting to sublux. So going ahead, I still may have to do something on the pelvic osteotomy to kind of get, before I consider lengthening. So the story is not finished. Maybe if Dr. Amulya invites me after 5 years, I'll have the rest of the story for this. Okay? So take home message on this is, it's not a sprint. Nothing in pediatric orthopedics is sprint. So think long term. It's never over until the growth is finished. Then you can pass it on to the hip surgeon. Yeah. So just a quick this thing through another case, which is in a different age group. So that's a 12-year-old proximal femoral osteomyelitis, was passed off as fine, cured. It's, follow-up. That's what happens at 18 months. Okay? So that's him. And he's starting to have symptoms because he says he can't play his cricket, he's limping, it's painful, there is leg length discrepancy. And what can you do? Either you wait for it to kind of degenerate and replace it. So there are issues. Why he's having these problems is because of significant abductor insufficiency. That trochanter is much higher up. Okay, in addition to all the intra-articular problems. So we went in, this was early on, probably about 8 years ago, yeah. So I went with the thought of reducing the femoral head and reshaping it, but found that the damage was quite extensive, so bailed out, did a neck lengthening to bring the trochanter down, reshaped the head as best as I could. In hindsight, I probably would have removed it a little bit more on the lateral corner. So that's what he looks 1.5 years down the line. He was lost for follow-up until just before around COVID time he came for the last time. And he was doing very well at that time, no limp. You can see that bump, I should have removed it a little bit more. Yeah, it will cause some problems, but he's asymptomatic at this point in time. And he came back at that time because he had joined medical school. He came in to give me a box of sweets. Okay, that's him functionally. That's his gait. Okay, so sufficient enough hip to kind of, for someone to work on it at a later stage. So in terms of surgical management, one size does not fit all. So you need to have different ages, different range of pathologies. So you need to kind of think long term. And what you want to achieve is all of this as best as you can. I'm not saying that you'll get a healthiest cartilage under the skin, but as best as you can. Okay? And before I conclude again, you know, this is one organized by us at Pediatric Orthopedic Foundation. We have a 2-day dedicated trauma meeting in the first week of June. Those of you who deal with pediatric trauma, it will be a fantastic update with hands-on workshops and things like that. Thank you.
The next speaker is Dr. Jagdish Menon.
क्या सर?
नहीं ये वाला
नहीं है
नहीं हमारा इसके बाद So good morning on a wonderful Sunday, and I had a wonderful couple of days, and just for a change, this is on tumor. And so with the permission of the chair, I've just modified the talk a little bit to talk about a technique which would be a little more connected, which is treating malignant tumors in a resource challenge scenario. People with malignant bone tumors are living longer. They're living longer because of better chemotherapy, better investigations, better critical care, and a better understanding of tumor margins. We also know that people who get limb salvage done, and people, when you compare them to people with amputation, the oncological outcomes are identical, which means the local recurrences and all are same. And between function, we had a big discussion on prosthesis versus continuing the same limb. We still believe that if the person has his own limb, the function is much better than most prostheses that we can offer in India today. So what is the role of surgery in bone tumors? It is usually curative, and it is usually combined with chemotherapy. The chemotherapy is given before and after the surgery, which is sometimes called neoadjuvant. It is critical to know whether you're dealing with local disease or disseminated disease, and the hallmark of surgery is to make sure you cut through normal bone and don't leave back tumor bone, which causes a recurrence. So this is the fundamental two things that you do in tumor. One is you resect the tumor, you take it out. Now you're left with a gap. And the second part is how you deal with this gap through reconstruction. So the tumor could be in the center of the bone, where you do what is called an intercalary resection. You have got good bone on either ends. Or it could be an osteoarticular, where the joint also has to be sacrificed. So what do you do for this gap? You reconstruct with prosthesis. the numbers and the types of prostheses are going up, and all of them have one thing in common. They're very expensive. And in a growing child, prostheses don't grow. So you have a second problem. So the other solution to this problem is to use biological reconstruction. You could have a bone bank which has allografts. You could have autografts. Distraction, the Ilizarro and the Mascule that we spoke over the last 2 days has a big role to play here too. We are focusing on one point which is called processed tumor bone. Now what does this mean is, you resect the tumor, process it in such a way that all the malignant cells in the tumor are destroyed, and you put back this tumor inside. And what are the processes that you use? Are autoclaving, which is basically boiling the tumor, pasteurization, cryo, which is liquid nitrogen, or give radiation. And this little talk is about the last one, which is radiation, and it is called extracorporeal because you're taking this little bit of bone outside the body and you're subjecting it to very high radiation, which kills everything. So what you have is just dead bone, which is the shape of the original one. So it fits beautifully. So it's extremely cost effective and it's anatomical. And since it's outside the body, there is no radiation injury. Just an example, an osteosarc in a child. We have resected it out, taken it out, and we put that in that little bag, that little acrylic box. This goes to the radiotherapy departments and gets a dose of radiation, 50 gray for about 20 minutes. That 20 minutes gives us some time to have a cup of tea and refresh for the thing that comes back, and we put it back into the patient. So that is what is done. This is just another example. This is, I think, an undifferentiated sarcoma of the proximal tibia. The same thing has been done. You take the tumor out, send it back, and refix it up. Now, another case, this is an osteosarcoma in a younger child. Younger children, the younger the child the tumor has, the bigger the reconstruction problem because of the factor of growth. This is a small procedure in which this is called the Canadell's procedure. What we do is we distract using with a fixator. What happens is the physis ruptures. We get what is called physiolysis. And therefore the dissection of the tumor distally becomes easy because it has ruptured through the physis. We do take out the bone, irradiate it, and put it back, and this is something which you get. So this is our first cohort. We have, I think, crossed about 135 ECIRs, and this is our first cohort of 61 patients where the complications were a little high. The most common complication and reoperation was due to infection. And most of them subsides with debridement. Remember that the entire bone that you're putting back is actually dead. It's avascular. So just like you have avascular necrosis of the hip, you will get avascular necrosis of this bone also. And that is why you have the middle three part, the condylar collapse, which causes laxity. These are related to the avascularity. So this is one of the cases. This is after, I think, about 9 or 10 years of follow-up. You can see the condyles have disappeared. Now the flip side is, this bone is insensate. It doesn't have sensation. So the patients are extremely comfortable. So you would believe that this patient with the nail here would be in a lot of pain. The answer is no, because actually you have taken out everything. They're very comfortable, and sometimes when you offer to revise them into a prosthesis, they refuse. Somebody was saying, it's very difficult to convince a patient that you need a surgery and he is asymptomatic. The same case here. These are the more drastic complications that occur because the bone is dead. You have a fracture to the avascular, and this is what we need to revise. This is an unusual case where we had plastic deformation of the physis. It didn't fracture. It just got squashed and got misshapen. Osteosarcoma again. And all these patients, after some years, when you do a bone scan, you find that the avascular bone has actually picked up circulation. So it has become alive again. This process may take 6 months to about 1.5 years, but the bone starts living again. And what does that do is, that allows you to reduce your amount of resection. So this is the patient that underwent a revision into a bone prosthesis because the bone had revascularized. So extracorporeal radiation is a cost-effective solution. It's a great choice when the tumor is in between two ends of growing bone, of good bone. And then if it is osteoarticular, maybe later life or in a second surgery, you can reduce the dose of metal that you use to treat these patients. Thank you so much. This is Pondicherry, and I welcome you on to come to this wonderful place. Thank you.
Thanks, such a nice presentation. Sir, have you ever tried drilling the bone before putting back? Means multiple drills which can add the vascularity later on.
It's already weak, that's the problem.
Yeah, but you are actually bypassing with the graft. So have you ever tried putting multiple holes just with the 2.5 drill? That, yeah, but that will help in vascularity because
It comes from top, not from side. It comes from the alive bone on top, and from top down.
Thank you. The next speaker is Dr. P.K. Raju.
At the outset, thank you, good morning, and at the outset I would like to thank the chairperson, Dr. Amulya, for inviting me here for this presentation of a case of 48-year-old male who met with an accident and presented to us 9 months after the accident. And he was treated initially in a trauma center in Bangalore. These were the initial X-rays. Comminuted transfers, posterior wall dislocation, and type 3B open distal femur, highly comminuted fracture. So these were the CT pictures. You can see the transverse fracture with a posterior wall comminution with a dislocation. Some of the other pictures, which were taken at that time, and it was diagnosed as a floating hip injury. Yes, some experts in the field do not believe in using this term in contrast to floating knee or the floating elbow, but it's been classified by Muller and Leibergal like this. Well, the importance of such a combination of injuries is the challenge of reducing the hip and the distal femur to save the neurovascular compartments and to prevent the adverse outcomes like AVM. So management options, I think all of us agree, probably since it's a type 3B fracture, debridement, external fixation for distal femur, and open reduction internal fixation for acetabular fracture, probably anatomical reduction. So the sequence, in this case, he had planned X-fix initially, and then open reduction. If you look at this evidence, some surgeons do operate acetabulum first, then go to the femur, or femur first, or acetabulum. But the priority is reduction of the hip dislocation. Well, initially X-fix was done, but X-fix has some issues. If you do X-fix, knee spanning X-fix, it might cause problems in positioning of the patient in the flappy lateral position, and also you need to keep the knee flexed during surgery for acetabulum, so it might cause problems. Anyway, he had done an X-fix, knee spanning, and 6 days later, open reduction and internal fixation was attempted, and for unknown reasons, he was, it was not reduced, and no fixation was done. No internal fixation was done. So later on, they removed the X-fix, and after 6 months, he presented to us like this. So this is the scenario. Patient had a little bit of infection on the hip side. Head is high reading, pseudoacetabulam, severe comminution, no posterior wall, probably non-union or malunion of the acetabulum, and infected non-union of distal femur. Well, this was the diagnosis, and we need to address the fracture-related infection. You need to achieve union and a stable and a mobile hip to give the activities of daily living, what he has to do. He is a Muslim, so he wanted to do namaz, sitting on the chair at least. For the last 6 months, he was bedridden. Then there was a seropurulent discharge. We identified the bug. Then we decided to go ahead with the fixation of distal femur first. So debridement was done, Elizero was put, and this is the lateral view, which was not aligned properly. Then realignment was done, but at the end of 2 or 3 months, we could tackle the infection, but not the union. So then we removed the X-fix. After removal of the X-fix, This is the scenario. So what next? So we planned for fixation, doing an open reduction and internal fixation. Patient had 8 centimeters of shortening, total limb shortening. So we went ahead with the fixation, open reduction. I could do the debridement to as much as possible, removed all the loose fragments. Then that was done, and we did do bone grafting, took bone grafts from iliac crest and fibula. This is how it was fixed. The massive bone grafting. This is the post-op X-ray. And after 3 months, and this is after 6 months. So absolutely no signs of infection, fracture united well. Patient was quite happy, means no infection, and there was no infection in the hip side, site also. Then he started walking with a crutch with a severe shortening with a stiff hip. But patient had, severe pain in the hip. He was unable to sit because he was not able to flex the hip. He wanted flexion at the hip at least to 90 degrees. He repeatedly asked for surgery, but we refused to operate because we told him, you are comfortable at least now. We were skeptical about the future infection, flare-up of infection, and told him to walk with a limp and support so that he can lead his life. And so he was adamant. He was admitted twice. In fact, we scared him about the complications. Again, he got readmitted. He insisted. We were adamant. He was insistent on getting the THR done because he was happy with the first surgery. Well, we did do a lot of counseling, and this is a clinical failure. We went through the literature, and conducting THA in a context of previous acetabular fracture presents real severe technical challenges, which includes, it's a more complex dissection due to poor, incisions or soft tissue scarring, bony loose fragments, defects, retained implants. Here, no implants were there, and potential chances of flaring up of subclinical infection. Then secondary conversion, if you look at this evidence, it exhibits compromised outcome and shorter survivorship because of the high postoperative complications. Look at this, there will be a lot of capsular damage, muscle damage. There will be no muscle, gluteus medius would have been atrophied. And then bony defects, a lot of problems, and infection, surgical site infection following the revision, due to prolonged operative time is very, very high. So what is the basic prerequisite is meticulous planning and know the pathoanatomy of the fracture and the surgeon's experience. If you look at this article, high surgeon's volume, that revealed a notable 2.6% reduction in the risk of arthroplasty for each revision procedure. And if he has exceeded surgeries like this more than 10 a year, so that the incidence of complications comes down. So to be truthful, the results are worse, and it's very difficult to manage. So we planned, all investigations were done, incision, debridement, implants, bone grafting was planned, and the most important thing is whatever soft tissue is there, we need to keep it viable during surgery. So everything was planned. The only thing which I have not written is prayers. We did pray God. So previously, we went through the same operation, incision, digastrectomy, the flip osteotomy was done, and we deglued the whole proximal femur, reduced, exposed the acetabulum, then identified the deficiency, that is posterior, superior, as well as medial defects were there. We thoroughly curated, and then went ahead with bone grafting. I planned for a uncemented cup because that is better than a cemented cup in an infected, previously infected hip. So this was the thing. We used a Gripson cup and hydroxyapatite stem. You can see the bone grafts being fixed by screws, and this is the picture. So this is this post-op CT showing good positioning of the cup, and later on, at the end of 15 days, there was some serous discharge, it stopped. At the end of 6 months, patient was able to sit, ambulate with a walker frame support. But Kahani did not end there, video is not running. At the end of 3 or 4 months, patient did have some serous discharge. So that was a nightmare for us, and then I thought, okay, it's infected. We planned for explantation. We thought we should remove the implant because it's definitely might become loose and cause a lot of problems. But patient did not agree for explantation. He insisted that he wants to continue with the same implant. Then we gave 3 weeks of antibiotics. Patient did develop some GA side effects. It was stopped. Serious discharge stopped. Everything became all right. No discharge, no fever. This is the final picture just 1 month before. 1 month before. Good consolidation proximally. A good consolidation. No discharge. Nothing. And he has a hip flexion of 70 degrees. He can sit on the chair. Shortening of 4 centimeters, still persisting. Knee flexion is about 70 degrees. Good union distally. He can stand. And he can walk. You can see the shortening of 4 centimeters. He's quite comfortable. And still I am making him walk with the walker support. Now I know I'll start making him walk without walker support. So this is the take-home message. Thorough knowledge about pathoanatomy is required. Prioritize, plan properly, do a proper counseling, and prevent, try to, avoid this thing, too much of dissection of soft tissues so that you can prevent further infection. And most important is you need to have good experience. So thank you very much. I would like to say as a patient's expectations might be a surgeon's nightmare in cases like this. Thank you. Thank you very much.
Thank you, Dr. Raju. The next speaker will be Dr. Aditya Jain for the peri-implant fractures femur non-union.
Good morning, everyone. I thank Dr. Amulya again for giving me this opportunity, and Team Gofcon. Very wonderful experience being here. My talk again would be a case-based discussion, and I want everyone to be interactive and keep this. So this is a patient who came to me with this X-ray. Is it good? Dr. Amit? I don't know. She just presented to me with this X-ray. But are you happy with this fixation, like the plate length? And no, it's not a failed fixation. What failed was this. So that was not the X-ray which I got. I retrospectively asked for that X-ray, that what was there and what would be the factors which led to this. So trivial trauma, any history of infection, maybe we can ask. Atypical fracture, stress risers, inadequate fixation, short plate length maybe, and the status of the previous fracture union as you just asked. So these were the questions which was in our mind. So she was a 65-year-old female, hypertensive. TKR was done in 2016. Periprosthetic fracture happened in 2019, and it was fixed with this short plate. She was doing well, but after 3 to 4 years, out of nowhere, one unfortunate day, she did not have any fall, and she suffered this injury, and she presented to me in emergency with this picture. She, after the injury, she was in pain and stopped, and the weight bearing was delayed. And I also asked this history, which was very important, that she was taking bisphosphonates since 2016. She did not have any fall, so we have to consider all the factors: infection, stress risers, maybe stress fractures. So we inquired and did ESR CRP, it was normal, so less likely infective. NCCT, metabolic workup, and these are the treatment options which you can offer. So anyone for A, just a show of hand, who would do A, B, C, D? For A? Okay. For B? For C? And, okay. And D? Any other panelists?
I think
all the options are there.
I think the plating is an option, but
that is why any other plan, the E1.
The plating is an option, but since the patient is an old and you treat not only the fracture, you treat the whole bone, so you have to span the full femur with the plate.
Okay. So I think plate removal and The A you would choose.
Yeah, replating.
Yeah.
So if you're suspecting a bisphosphonate-induced kind of a fracture SSBT, then of course you have to nail it. That's the option you can go for.
Okay.
Retrograde is the better option.
Okay.
You can supplement with a plate because that fracture down
Yeah.
is also not healing. That is another problem. So you have to address that as well.
Okay.
You can add a nail and a plate.
So the augmentation, you mean?
Yeah.
Yeah.
And it's an open box.
Yeah. Yeah.
You put a longer plate with the last screw of the plate going into
towards the neck.
Because you don't want a peri-implant fracture now, and no THR will be possible with your
So
nail
2 points which are good here, that is augmenting and putting screws in the cephalomedullary areas. And
Can I
nailing.
add
3
something?
points. Yeah.
Even with the PS knees, we have had a couple of cases wherein these days we are able to negotiate the nails by using Judas burr.
Yeah.
We try to enlarge the entry point through the femoral component and then
Definitely.
get
So
to a
currently
retrograde nail.
Synthes are out with a nail that is called RF, a retrograde femur nail, and it has specially designed bends 5 degrees and 10 degrees, and even they can go through a PS knee.
Mostly all nails go through PS knees if the box is open.
Yeah.
So he's only talking about enlarging the box. But if the box is closed, then it is a real challenge.
Yes,
and you can use a Midas burr to do and then change the polyliner.
Okay, great. So bone grafting, anyone you would want to put bone graft here? No, it's a fresh fracture, right? Anyone for bone graft? No. Biopsy, cultures, beads. So we did the same thing which was, I think, sir was telling. We did ORIF and freshening of the margins, sclerotic edges were there, which again showed that there might be some atypical fracture because of the bisphosphonate induced. And distal fracture was clinically and radiologically stable. When we removed the plate, we do the stress views. The distal fracture was not moving. Still, we treated it with a long plate, and this was the construct. Dr. Samad was trying to tell a very good point to put a cephalomedullary screw in the head, but we didn't go for that. And bisphosphonates were stopped, teriparatide was started. Anything skeptical about this X-ray 2 months down the line? Yes, Dr. Rohan. Yeah.
If you are worried about the age and bisphosphonate fracture, what I would like to do is remove the previous plate, put an intramedullary nail like Samath has said. It's absolutely correct. It's a segmental kind of a presentation. It's a big, and now the middle segment is so rigidly fixed that we don't know how much callus will happen in which site, and maybe one will unite and the other will fail.
Yeah.
So the better thing is to remove that previous plate, put a long nail to the lesser trochanter and supplement with a plate.
We removed it with the previous plate, but we put the long plate. Instead of long plate, there would be a nail.
Yeah,
and a plate. So augmentation, nailing,
and pad
screws
fixation.
to the head. Yes. So three points. Okay. Yes.
Aditya.
The distal fracture was uniting.
Yeah. So Aditya, only just forget the knee, forget the distal fracture. If this was a plain shaft femur, would you be happy with the fixation that you have?
No.
Then why is it adequate for 2 fractures? If it is not adequate
That
for
is why the discussion, yes.
If it's a segmental, it's a 2 fracture kind of a situation in the pan diaphysis of the femur, this kind of fixation may or may not give union because one side is going to become more stiff, one fracture site, the other is going to lyse up. It's going to go into osteolysis and the implant will be stiff and the implant will break. So you have to put a pan diaphyseal nail and you can supplement with a plate and not so many screws.
Definitely. So this is 6 months down the line. We are still hoping that it should unite. And I think what Dr. Rohan was trying to tell and Dr. Samar and Sir was trying to tell, exactly the same thing happened. The plate broke and the 3 points which we were missing was putting an intramedullary nail, fixing it long till hip, and augmentation. So these 3 points were there, and after, yes?
So bone graft was added, sir, in this case?
No, because it was not added at this point. Okay. So we are now with this thing, and this is our face maybe, and this is the plan again. So what would you do now? D or C? Okay.
because it is at the fracture site and it will cause stresses. So plate
Yes.
needs to go far.
And it is broken also.
Broken also. And freshening of the fracture is also important. Bone grafting is also important. And now you need to protect the neck. So antegrade nail, removal of plate, bone grafting, probably another plate.
Okay. Anyone with some other plan? Okay.
One more plate to augment at the fracture site
Yes.
from either medial or posterior side.
Okay. So nailing, augmentation, cephalomedullary nail, and bone graft. Okay.
Aditya,
So-
I have
Now
a small
two
point to
implants.
make. I'm
Yeah.
not going to interrupt you more. I think I know what you must have done. I know it would have ended up very good. But see, we need to discuss here why all of us are here, is why that plate has failed.
So
I think, Amit sir.
Yeah.
So we should be discussing why this plate has failed, about the mechanics which we have used here. And that is more important, I feel. Why not to do this kind of a rigid fixation when you
Yeah,
got a segmental fracture? Any
So
configuration
you are
you would change.
You are trying to tell the exact thing which we are trying to prove.
Yeah,
that
but any
it was not a
configuration-
good fixation. It was a very rigid fixation. In the typical sharp femur, as Dr. Summers said, we would not do this thing in nowadays. We would nail this.
But now a nail.
Yeah. Definitely.
And that is the reason for the plate failure. You know.
Definitely.
Aditya, has your distal fragment united?
Yes. So still, but the point is we have to fix it anyway. We have to go till down. So we removed the proximal part of the plate. Guide wire was difficult to manipulate because there was so much sclerotic bone. We planned out to put distal locking screw through the nail, like that is called marrying. But plate was obstructing the C-arm view to locate the distal hole and the TCAR implant. So we just did a nail cephalomedullary, as Dr. Sampath said, to avoid any new fractures in stress riser and proximal hip fracture again. Serial reaming accentuated marrow stimulation at fracture site. We continued teriparatide and we started early weight bearing. I did not just restricted the patient to avoid weight bearing, and that is I think the aim of putting a nail. So 3 months down the line, we could now see these callus has started forming. And this is 1 year down the line, the fracture is almost united. And she lives in Bihar, and I asked her to come to Delhi, but she was not willing to come. And she sent me this video from her home. And she is comfortable. It's been now almost 3 to 4 years. So take home points, periprosthetic or peri-implant fractures are not uncommon. Atypical fractures can happen anywhere from lesser trochanter to supracondylar flare. It's not just at the proximal part. Intramedullary nailing is preferred, as we all just discussed, that any sharp femur fracture treated as a normal sharp femur fracture. Cephalomedullary nails are better because you can prevent the future hip fractures and put a cephalomedullary screws. With new generation and new retrograde femur nails, we can put the nails distally in the retrograde manner, and which can provide early mobility and minimally invasive and less stress riser. But if you're putting plates, you use long plates, as one of the panelists said, and putting the screw towards the head. Teriparatide may be useful, always keep subclinical infection in mind, and as I said yesterday also, that counsel the patient, that's the most important thing. Talk to the patients, explain them all the possibilities. Thank you.
Thank you. Now, next session will start. We call chairpersons Dr. Anil Kumar, Dr. Yasan Sarraf, Dr. Amit Rastogi, Dr. Ravi Bhardwaj. The session is on complex fracture around shoulder and elbow. Please, all chairpersons come.
So I have a question for Raju sir, if I can ask him. Where is he? Yes sir. Sir Rohan. Sir, that case you showed is excellent. It's very difficult to even handle such patients. So only point was you have put the distal femur plate and screws and used a primary stem. What I feel in such a case where you know that there is no proximal femur, just remove the screws and put a distal diaphyseal loading stem. Yes, please.
Good morning. After
Okay,
the
type
complex lower limb
distal
session,
diaphyseal
I'm
loading.
Just a minute, sir.
I'm
we have got a lucky draw of this first session. Registration number 45, Dr. Rajkumar. Dr. Rajkumar is here. No, no, then you can pick up one more.
Loading stem, so the proximal you have to forget because the patient will walk on this type.
Dr. Amit Ajgaonkar, lucky draw.
Registration number 103. Dr. Navratan Deepu. Yeah, please, please. May I request Dr. Sanjay sir, please present this. Dr. Navratan deserves this. He came early morning at, yeah, please, please. Thank you.
Okay, we'll resume the session. Dr. Puneet Agarwal, this all yours.
So, terrible triad, terrible or not so much. So, some basic points I am raising here. So, this is the case, the young male who is having dislocation of the elbow with comminuted radial head, avulsed ligaments, and so this patient was labeled as terrible triad elbow with avulsed collateral, coronoid and radial head. So we are basically dividing elbow dislocation in two parts on the basis of involvement of whether it is having a fracture or not. And in 2014, there are studies which labeled it as a terrible because of lots of complication associated with this injury. And this complication ratio was up to 54% in this study, and it was related to hardware fixation problem, joint stiffness, joint instability, ulnar neuropathy, heterotropic ossification, and arthrosis. Even after the 10 years of many advanced in the implant techniques, the ratio of the complication remains the same. This was a study done at Sancheti Institute in 2024, and the level of complication was up to 45 to 48% here, and the same complication he faced there. So if we are having any case of elbow instability, we should look for the evaluation for this instable situation. And this is the common mode of injury where the axial compression in supinate forearm who landed up in valgus stress over the elbow, and whole of the joint will having problem. And there are lots of theory to explain the this injury pattern, like Hori circle, reverse Hori circle, and spiral. This ladder concept was also there for explanation ki soft tissue involvement in elbow dislocation. And this is the 3-column concept of Wrightington, who explained this terrible triad very well, who divided this elbow in 3 parts: medial, middle, and lateral column. And on the basis of involvement of this column, he classified this injury in 6 parts, and type C was considered as a terrible triad elbow, where the middle and lateral column was fractured, disrupted. After the diagnosing that this patient is having terrible triad, we can proceed further to assess how much is the radial head is comminuted, fractured, like type 1, type 2, type 3, and coronoid we can classify in which class coronoid is there to finalize which treatment this patient will require. So this is the treatment algorithm based on Wrightington classification. So one more important point, does timing of surgery is affect treatment in terrible triad. So we should take this patient either in emergency period within 24 hours or within 2 weeks. If we are treating this patient after 2 weeks, the ratio of stiffness will be very high. So I am coming back to the first case, who is having this X-ray after the reduction, and this patient is having comminuted radial head and type 2 coronoid, and he was treated with radial head arthroplasty, repair of anterior capsule, lateral ligament complex, and repair of MCL. So surgical tips, I'm using basically posterior extensile approach, and with this posterior approach, I'm approaching both medium column and lateral column. And if radial head is not so much comminuted, usually medial column or MCL complex will be preserved most of the time. If radial head is comminuted, then most of the time MCL or medial column will be disrupted. So radial head, if we are going for the radial head replacement, that lateral defect, we can address anterior capsule to repair the anterior capsule, or coronoid we can approach. Coming to the next case, who is young male having low energy injury, fall down over floor, and this was his pre-op X-ray, and this was his 1 week after post close reduction. He is having type 1 or 2 radial head and type 1 coronoid fracture, and this was 4 week post CR X-ray, and 4 weeks post CR he is having good range of movement. So non-operative management is also possible in terrible triad, sometime where the coronoid fracture is small, radial head fracture doesn't need surgery, and ulnohumeral and radicapitular joint anatomically reduced, and elbow is sufficiently stable to permit early mobilization. Another case where the radial head is comminuted and flipped upward, and this was his intraoperatively instability, and this was his post-operative X-ray and final outcome of the patient with good range of movement. So LCL to be repaired in pronation if MCL is intact, and if MCL is injured, LCL should be repaired in supination to avoid over-tightening with elbow at 90 degree of flexion. We can use suture anchor or direct bone repair over the bony tunnel for the LCL. And in cases where the elbow remain unstable after fracture fixation and LCL repair, especially in extension beyond 30 degree, the MCL should be repaired, and sometimes it will require need for the hinge fixator. Another patient did the same, and he is having good outcome. So radial head processes should be of appropriate size to avoid laxity in undersized and tightening in oversized. And in my practice, radial head arthroplasty is having comparatively better outcome in these situations in comparison to fixation. So this is very an interesting case. A 23-year male having RTA, 2-month-old neglected injury, presented to me for the stiff elbow, and in this case radial head was lying anteromedially, and I have tried manipulation under anesthesia for the stiff elbow but failed. So radial head was replaced because MCL side was having heterotopic ossification, LCL was scarred, annular ligament was repaired, scarred LCL was repaired, and fortunately patient is having good outcome at 6-month follow-up, and she is having 1.5 year follow-up after this whole repair. The last case where the patient is having a large chunk of the anteromedial fragment, lateral column was not too much shattered, so it was held with percutaneous K-wire, coronoid was buttressed with small plate and K-wire, and patient is having 1.5 month post-operative, he is under treatment, he is having decent movement at this time. So this is the treatment algorithm of the terrible triad elbow for these patients. And so whenever you deal with a patient of terrible triad, there should be optimal treatment plan in a timely manner to decrease waiting time for surgery. Each component of fracture and soft tissue injury needs to be tackled in a sequential or stepwise manner, and early joint mobilization to reduce the risk of joint stiffness. Thank you.
Thank you very much, Dr. Puneet. We'll have questions at the end of the session.
Thank you.
So I'd like to invite the next speaker, Dr. Vinay Kumar Singh. He's going to be speaking on ACL injuries and management. All yours.
Good morning, everyone. Last and final day. Now, when I was in England, I used to treat this injury quite common, and it was quite easy for me to treat it. When I came back, it was quite a challenge because of the cost issues, and it was quite frustrating because I used to use ligaments in order to reconstruct it. So my talk today is to basically show you two techniques. If you know two surgeries for this particular injury, you should be able to do this, and also do it in a cost-effective way so that you can offer this even to the poor patients. Now, these injuries are quite common, especially if you involve in sports or physical activities or fall from bike. It is not uncommon, and it's, as an orthopedic surgeon, you will see that very frequently in your clinical practice. Now, two mechanisms. One is directly on fall of the shoulder. You fall on the shoulder and then you have this injury. Or the other option is if you fall with a very high energy, fall on an outstretched hand, it pushes it up and you can have this injury. So these are the two common mechanisms. X-ray, I think we all know about it. Zanka view is one dedicated view, which you tilt it 50 degrees towards up, and you reduce the radiation by around 50% of your normal dose if you want to see the ACJ. Axillary lateral view is sometimes important, especially for type 4 injuries, which you don't appreciate on AP view. So if you're suspecting something is not right, you can go for it. Now, classification, I think we all know, so I'll just skip this slide because it's only 7 minutes, and I would like to cover and discuss few cases as well. Now, when you come to the management of ACJ injuries, there is, for type 1 and type 2 injury, we all know we are going to conserve. Type 4, 5, 6, we all know we are going to operate until unless patient is quite sick, and if patient refuses surgery and other factors. The type 3 is the usual area where we think whether we should operate or not, and still there is no consensus. But for me, in my mind, I am very clear that for me, type 3 injury, I also treat them surgically. So type 1 and type 2 for me is non-operative. Type 3, 4, 5 and 6 is operative intervention. Now, 6 scapular syndrome is one condition which you see in patients who are treated non-operatively. If you see this here, there is abnormal patterning. This is one patient which I have operated, and you see them, he presented to me at around 3 weeks. Even at 3 weeks, you can see the scapula is not moving the way it should be. And this is a scapulothoracic, scapular dyskinesia or 6 scapular syndrome, which is seen in vast majority of the patient. Literature has quoted 50%, and this is in centers who have got good physiotherapists. But when you see it, examine just the patient. If it comes 3 weeks later or 4 weeks later, you will find that most of them have this scapular dyskinesia, which can be quite disabling for the patient. So there are many options. That is one fun thing about orthopedics, but two realistic options I think most of us will choose is either to reconstruct the ligament or to use a hook plate. These are two common instruments that are being used when we deal with acromioclavicular joint injuries. For me, preferred option is always one. I don't like this implant. It's not been my preferred implant, ever since I have started orthopedics, and I have got a reason for it. First of all, implant requirement, you need to remove this. So the only good thing about this implant is, if you are a surgeon, is that patient will definitely come for removal at a later stage. So you can offer him 2 operations. Acromial osteolysis, if you leave it, subacromial impingement, if you don't place it right, and acromion fracture can also happen. So for me, it is slightly more invasive, and hence it's not my preferred approach. Now, in acute injuries, you treat with this. Chronic injuries, it's not uncommon. It's extremely, in fact, it is more common for patients to come late than early in India. That is what my observation is. And sometimes patient will come few years later or a year later or 3 months later, and modified Weaver-Dunn is my option. So I don't take this, we just take this ligament and then pass it on, and I will show you. So if you want to deal with these injuries, you need to need only 2 operations. One is to do a ligament reconstruction using endo-button, and second is Weaver-Dunn. If you know these 2 operations, you can deal any acromioclavicular joint injuries, whether new or late. So this one example, 34-year-old gentleman, right-handed farmer, fell on a motorcycle injury, and injury is 5 days old. So it's a fresh injury, and he presents with these x-rays, and clinically he has got pain, he has got tenderness, there is prominence. So for me, in my mind, I am very clear that I am going to use a loop endo-button. Now, if you go for pre-made loop endo button, Arthrex or any other company, it will cost you a lot of money, which is one major contention that patient refuse because they are not able to afford it in the region that I cater. The patients are poor. Most of them come in government services or government the policies, and the implant code or the operation code is so little that you cannot buy these. So what we started doing is just to show what I do in theater, just few slides. So patient is for me always beach chair. Now appropriate positioning of the C-arm is extremely critical if you are doing ACJ injuries, because if you don't see your coracoid, so if you see this C-arm is not in the center, it is at an inclination, but it is also slightly more towards the other side. And when you do this, you will get this picture. So you need to see this coracoid absolutely like a circle. If you're not seeing it a circle, then you may place or drill it slightly eccentrically, and then you may have a cutout and you may not have a good result. Then it's a straight brass strap incision, or if you have a good equipment, you can do it percutaneous as well. So I'm just locating it, drilling it. This is what I need. So for me to deal with these patients, I just need 2 endo buttons and a fiber wire, and this fiber wire is usually, you get it by end of an ACL, so we just sterilize it and use it again. So if you have got these 3 things, you should be able to. So this is how we make a loop, and if you want to see a video of it, it is on my YouTube channel. And then we just pass the loop on the bottom and then tighten it, and this is what it looks at the end of it. So this is a 6 months follow-up, the same gentleman, and all of them, and I have done many, at least 20 to 30 cases acute, and at least we were done at least 8 to 10, and you will find that these custom made, which you can make on your own in OT, you will have a brilliant results. So this is a case 2, 14-month injury, hit by a bull. I don't know whether it's a problem here or not, but in Rajasthan you have too many bulls everywhere on the roads, and they contribute to at least 1 or 2 cases to your OPD every week. So this was one guy who was treated by Pahalwan, and he comes to me around 14 months, more than a year down the line, and this is what it looks like. So you do the same thing. The only addition is that you take a CL ligament, use a fiber wire, and you just need an extra endo button on top, and you just tighten it. And again, at a 6 months follow-up, you will see patient is regaining. All these are farmers. They involve in very heavy activity, and they can do almost everything. And previously he could do nothing, and he was in so much pain. Another case, 3 months old injury. Anything more than 6 weeks, I go for we were done. So same thing, same procedure. And the cost of treatment is probably around less than 2,000 implant cost. So if you are dealing with ACG injuries, you can make this loop endo button on your own in a poor patient. If patient is affording, it's absolutely fine. But if a patient is poor, you can do the same surgery with a similar result at a very less price. Thank you. So take home message, sorry, I just forgot that's a license. So it is quite common. Type 2 injuries for me is surgical, non-surgical. Type 3, 4, 5 and 6 for me is always operative. And for acute injury, I will use the loop endo button. And for chronic injury, anything more than 6 weeks, we were done.
Thank you very much, Dr. Vinay. We'll take questions at the end of the session, if that's all right. So moving on, do we have the video from Dr. Sergio, or going to skip the talk? Yes, sir.
Yeah, वो वीडियो चला देना. पहले small video.
Hello, my dear Indian friends. How are you? I'm Dr. Sergio Ravensky from Show the Planet, here from the city of São Paulo in Brazil. And I want to invite you, my Indian friend from all of the corners of India, to the next edition of Gofcon, Global Orthopedic Forum, which is going to happen in the city of Patna, state of Bihar, 22 and 23 of March this year, 2025. I, Dr. Sergio, I'm going to be there presenting to you very interesting and complex shoulder and elbow trauma cases, showing you tips, tricks, how to avoid pitfalls. So I hope to see you there. I'm going to take 3 flights, 38 hours to get to Patna. So if I can go, you can go. No excuses. See you in Patna. Oshchatni sepiazna hibushti. Samma hashdar koishara kafihet.
Next
Show
video,
the planet.
please.
Hamesha.
This he made about a month back, and he was so excited of coming to Patna. What
Hello, my
happened?
good Indian friends. How are you? I'm Dr. Sergio Ravinsky from São Paulo, Brazil, and I am recording this video to all my friends in Gofcon, Global Orthopedic Forum Congress, to tell you what happened with me. So now it's Friday, okay, and it's 8 hours and 30 minutes in the night, and this is what happened. Last week, I was in Indian Embassy here in São Paulo, Brazil, and I was with a new visa, a regular visa that Brazilians use to go to every country, and the same kind of visa I always had to go to India. So the visa was okay. So I traveled to India on Tuesday, which means 3 days ago, and after 32 hours I reached Delhi, and I was supposed to pick up a third flight to Patna. In Delhi, they told me that the visa that I had was not enough because I was going to a medical conference and I should have a conference visa, and I got absolutely desperate, and I tried to argue with them. I called Dr. Amulya on the telephone. Dr. Amulya, in front of me, spoke to one person in customs in Delhi, and they were relentless. They told me that if I didn't have a conference visa, I couldn't enter the country, and they told me that I would have to immediately come back to Brazil. Immediately. So I couldn't do anything. I was very tired. 8.5 hours in different time zones. So Emirates was very good with me, and they booked me a flight on the same day, which was yesterday, Thursday, to Dubai. I had to wait 5 hours to the flight, and last night I had to wait 14 hours, 50, maybe 15. I'm sorry, I'm tired, very tired. And I had to wait 14, almost 15 hours, and then I flew back to Brazil today, 15-hour flights. So in summary, I traveled 70 hours and 58 minutes, almost 70 hours and 59 minutes I'm putting here to show you. The thing is, it was not my fault. I want to make it clear that I am super sad with this, super disappointed. I was very bad in the last 36 hours, crying a lot, crying too much. Now that I am in Brazil, I'm better, in better mood, hopefully. And it was not my fault. Dr. Amulya, forgive me. My dear fellows in Gofcon, forgive me. I'm sorry, it was not my fault. I had a visa. It was supposed to be okay. I still want to say that if once and whenever Global Orthopedic Forum, under the leadership of Dr. Amulya, wants me to go again to Gofcon, I totally accept. I have a very good relation with the Indian orthopedic community. I'm developing this for 14, 15 years. It's not this incident, as sad as it is, that will change my good relations with the Indian orthopedic community, and especially with Gof and Gofcon. So I am always in if Dr. Amulya wants, okay, it's just a matter of planning with antecedents. I'm sorry, it was not my fault. And I'm always trying to learn Hindi. I'm sorry, my Hindi is like a child, but let me put it like this, okay? Main Dr. Sergio Rovinsky Hun, main Brazilian Hun, or main Brazil se Hun. For sure, main Bharatian Nahi Hun, or main Bharat se Nahi Hun. लेकिन इंडिया हमेशा मेरा सेकंड होम है और डॉक्टर सर्जो हमेशा हिंदुस्तानी जिंदाबाद. So you can count on me, and I finish this saying from the bottom of my heart, and especially at this moment to Dr. Amulya, to everybody, but especially to Dr. Amulya. मेरा हार्ट हमेशा आपको होम है. धन्यवाद. See you soon in India. Kudos to Gofcon. See you soon.
He landed on Thursday morning in India. Exactly at 3:30 a.m. he called me. I was sleeping. For 8 hours almost we were in continuous touch. I tried my level best, but I'm a very small pawn in this big Indian embassy as such. But believe me, I had never seen a person crying on Delhi airport, and even I could express the way he was telling everything. He wanted to, and one thing he has assured, and the biggest thing is that from Dubai airport again he called me, Dr. Amulya, whatever you have spent, I will pay you back. I don't want any such type of feeling that I have ditched you. I am not ditching you just because a Brazilian embassy. He never blamed Indian embassy, because he told that I went to Brazilian embassy. They told that I can go with this visa, but here there was a problem, and at that time when he was talking to Brazilian embassy, that was closed. They were sleeping, so he couldn't do. And by the time that Brazilian embassy was open, he was back to Dubai flight. So apologies from his side, my side, that's all. Thank you, sir.
Okay.
Next speaker is Dr. S.S. Amarnath.
Thank you, Amulya, Gofcon 25, and Bihar Orthopedic Association for having me here. Like yesterday, I'm going to ask this question again. How many of you are using orthobiologics in your practice? Anybody? None today. One, okay. Right, so it's going to be brief. I've changed the slides last night, but definitely this is one thing which is changing the scenario, the way you and I can approach the sports injuries, be it any kind of trauma, if not sports, and also in a geriatric patient when there are issues. And now, including fractures as well. This is a new horizon, and not to say all injuries need to be operated. As Vinay was telling earlier on, definitely you have a chance and choice. So this is a Pandora's box is going to open in the next 2 days.
Then I made a fixator because he was so small and the bones one had a different configuration. I designed on my own compression distraction device, and this custom made external fixator did his trick, and I compressed this non-union, and sure enough I could get a union of the single bone forearm also of proximal under the distal radius. Yes, this worked. So 2 things achieved: joints mobilized, single bone forearm was stable, and third thing was converting a scar into a mobile, soft, supple skin. So I did a groin flap, and this also went on. So 3 things achieved. So the only 2 things that was simple was sural nerve and the tendon transfer. I took sural nerves, grafted across the 10 centimeter defect in the median nerve, and then waited what's going to happen. An extensor carpi radialis was elongated with plantaris, and mass suture to FDP. Will this work? I waited. And sure enough, down the line, this was the range of flexion we could achieve in these fingers. This was the function he had. If you see the picture on here, the thinner muscles came back in due course. That was the innervation of the motor part of the median nerve. And then he was lost to follow-up. And then I traced him on the Facebook, and he was in Boston 20 years later. And to a person who was given a 100% disability certificate, he said, I make the best chips for Boeing aircraft. He was gainfully employed. He returned subsequently to India because he had restriction of pronation supination. He said, I find so everything was very clear, crystal clear. Was I don't have pronation supination. He found it extremely embarrassing using fork and spoon while he was in USA. And that was a single reason he said, I don't want to stay back in USA. Though he was a high profile person as an engineer in, with the aircraft company. So he had shortening of the forearm, which, so he had about 6 plus 1 centimeter shortening of the forearm. In the end, he had a united fuse stable forearm here at the wrist. What do Americans do weekend? We Indians work on 7 days. We attend conferences. He said, on weekends I go rock climbing to a person who was 100% disabled. So we started on a brink, 14 failed surgery, and a brinkmanship, well thought out strategy, execution, mutual faith and trust in the surgeon and the patient. In summary, if you have a soft, supple skin, the deeper repair of reconstruction of nerves and tendon is possible. Just make an inventory of what is needed, skin, bone, tendons, nerves, and therapy. Just find out from where you are going to get all these things and in what order you are going to execute it and do it. Nothing can be more devastating and shattering to the patient when you say nothing can be done, it is hopeless, you have come late. Just kindle a row of hope that something can be done. Be realistic. Don't show heaven and hooray, execute, and you will have a good result. Thank you very much for patient listening and for this invitation. Thank you once again.
Good morning, everyone. I would like to be grateful for being here. Amulya sir has given me opportunity. fossa approach or the Hotchkiss approach. We have 3 variants in this approach. These are the fractures which are very difficult to approach from the lateral or the posterior aspect. For these kind of fractures, we need such an approach where we go to the fracture directly from the front. And for these kind of fractures which are literally non-fixable, we have to take bites of the fiber wires. And for that we have to visualize the joint and the capsule directly. And there are structures which we have to deal with. So I'd like to begin with the video. This is the Hotchkiss approach. We first mark the points and we begin our incision a few centimeters proximal to the medial epicondyle, giving a curved incision to distal to the medial epicondyle, and will protect the cutaneous branch of the cutaneous branches of the nerves, and we will dissect the soft tissue planes. Now we will reach the brachial fascia and will identify the ulnar nerve, and will incise the brachial fascia carefully not to injure the ulnar nerve. Once we have identified the ulnar nerve, we need to separate the ulnar nerve and to protect it with any umbilical tape or nerve tape, or I use gloves, cut end of the gloves. Once the nerve is separated, we can visualize the motor branch of the ulnar nerve, and there is the common flexor origin, and this is the medial epicondyle. When we elevate the common flexor tendon, we can see here the trochlea, the joint capsule, and the coronoid. We can incise the joint capsule to reach the joint. We have to be careful to protect the MCL here, the ulnar collateral ligament. This is the classical variant. When we have to go to approach the coronoid, we can go through the 2 heads of the FCU also. I usually do that for fixing the coronoid pieces. This is the trochlea. This is the coronoid process. This is the ulnar nerve sulcus, from where the ulnar nerve has been separated. And these are the bony landmarks. Now I'll show how I do my cases for using this approach. I have taken bites with fiber wire. The one case in which the CT was shown, this is the same case. There are fragments of coronoid here. I took bite from the fragments and the joint capsule and the brachialis tendon, which is separated. And here is the ulnar nerve, which has been holded with this infant feeding tube. And I have gone through the 2 heads of the FCU. Now, how I fix that? I use an ACL jig to make a perpendicular tunnel through the ulna to the dorsal part of the ulna, and I just use a drill bit and pass the fiber wires through that hole, and use that endo button to fix the whatever the pieces are left, or the tendon, brachialis tendon, and the joint capsule here. And in this case, the lateral collateral ligament was also avulsed from the humeral side. I use the Cocker approach to fix it with a suture anchor. And once I get done with my surgery, I always check the stability of the elbow joint. In this case, the elbow is stable in both varus and valgus stress test. And this is how I fix. These are the implants which I use. Sometimes I use anchor with endo button, and sometimes I use dual endo buttons. Sometimes I use only single endo button. And this is the same case. He is a cricketer. He'll be soon playing with Jharkhand team. This patient did not come to me for his problem. I operated him, I think, 2 years back, and he presented to my OPD a few months back. And he was not for himself, he brought some other patient to me. And you can see he's bowling again, he's a bowler, and he will soon be playing with the Jharkhand team. Thank you so much.
So we'll end the session here, and we'll invite the chairpersons of the next session to please take over and take the program forward. Thank you very much.
Dr. Rakesh Chaudhary sir, Dr. S.S. Amarnath sir, Dr. Ikram sir, and Abhishek Saraf, chairpersons for the next session. Please come on to the dais.
Good morning, everybody. As I wait for my co-chairpersons to arrive, I will start the program. I won't like to any delay. Requesting any of you around, please join me as soon as possible. Or Ramit, if anybody wants to join me, please send it to me. Otherwise, start this session straight away.
Dr. Arun sir, please join Dr. Rakesh Chaudhary sir.
This is an interesting session on pediatric trauma. We all do get it. Sometimes we manage it very comfortably, nicely. Sometimes it takes a lot of courage to go enter it, and many of the time we just avoid it. So to break it down to something simplified to all our delegates here, first I will request Dr. K. Venkat Das to talk on his infected non-union children, requesting him again to kindly continue with his second talk to pulseless supracondylar fracture and combine them both and try to get it a bit 2 minutes early. Thank you.
Thank you, respected chairpersons and dear friends. So the first talk will be on infected non-union in children. If you look at the management principles, by and large, it is going to be the same as you would manage any infected non-union in an adult. But whenever you are treating a child, there are certain... He has to load the next talk. So I will continue with the next talk on pulseless supracondylar humerus fractures, which is one of the burning topics discussed in any pediatric trauma meeting. So why is this a burning issue? The first point is there is no strong evidence which can say that this is the right thing to do, and a mismanagement can lead to a disaster or a lifelong disability. And the third part is, of course, you can have problems medico-legally if there is a compartment syndrome or Folkman's ischemic contracture. So let's start off with a case with a 5-year-old male who had a typical type 3 supracondylar fracture presented without pulse in a local place. And he was referred to a higher center because there was no pulse, where the close reduction and pinning was done. The treating surgeon, after pinning, reassessed the pulse. Pulse was not there, but he felt that the limb was looking pink, the hand was pink, so it is a pink pulseless hand, and decided to observe. Unfortunately, this was a fixation. 24 hours later, the limb was found to be cold. At that time, vascular surgeons were involved, exploration and grafting was done, and that was too late by then.
The patient presented to us like on 5 days later with a complete gangrene of the hand and the forearm, which ended up in an amputation. So this is not something which we want to see when we manage a pulseless supracondylar fracture. So whenever we get a pulseless supracondylar fracture, these are the questions which can come in our mind, whether we can manage it in our setup or should we refer. Do we need to get an Doppler or angiogram to see the vascularity? Should we call for a vascular surgeon? So first and foremost thing is a good clinical examination. So gently we can reposition the limb and immobilize and reassess the pulse and perfusion of the limb. So this is what our fellows do. This is from a WhatsApp snapshot from my phone. So all supracondylar fractures, they will send a picture of the limb with the pulse oximeter signal so that we don't miss anything. So this also they will send the clinical examination pictures. And if you look at the AOS guidelines, when there is no pulse, vascular consult should not delay repositioning or gentle reduction. A qualified clinician may reposition and assess perfusion. And regardless of the return of the pulse, we have to admit the patient and plan for internal fixation. And if pulseless, we need to consider transfer if there is no microvascular support facility available. So more than pulse, what is important is to assess the perfusion of the limb. Unfortunately, there is no objective way to assess the perfusion. So assessing the perfusion of the limb can be sometimes challenging, and you can be unsure of whether there is adequate perfusion or not. And the literature also says that there is no objective criteria by which you can measure whether the hand is adequately perfused. So this is a recent review article on that. So how do we assess perfusion? We look at three things. First is the capillary refill. It should be good, less than 3 seconds, like what we see in this video. Second thing is SpO2 signals and waveform. This has been very useful for us. So the saturation should be more than 95%, and more importantly, you should have the waveforms like how we see in this patient, nice, good waveforms. And third is a handheld Doppler. This is a very easy, handy tool which you can have in your ER, and it will be able to pick up both the ulnar and the radial artery pulsations, even though if it is not palpable. Okay, hearing it. So whenever we have a pulseless supracondylar, the goal is to assess the perfusion of the limb, and you can have two situations. On one side you have good perfusion, the other side is doubtful perfusion. Irrespective of how it is, immediate close reduction and pinning is what is recommended. But when to do it, even if the perfusion is good, you have to take it immediately. You cannot wait till the next day morning. It's a bad idea when there is no pulse. But whenever there is a doubtful perfusion, you should always think about a vascular surgeon backup. If it is available in your facilities, well and good. If it is not available, you should be able to refer a patient in a close-by setup. So that is one of the prerequisites. So when you plan for close reduction and pinning, what happens after that? How many times the pulse will come back? If it doesn't come back, what should we do? Let us try to answer all these questions based on our experience of about 448 patients. We did this study during the COVID time. Our incidence of pulseless fractures was 15%. We had 66 patients in this time period. All of them were treated with close reduction and percutaneous pinning. Only 30%, like less than 1/3 of them had return of pulse. The rest of the patients, 73%, the pulse did not come back. So they remained pulseless after close reduction and pinning. So what should we do for these patients who remain pulseless? So these are commonly termed as pink pulseless hand, which is defined as a hand that remains pink and pulseless after close reduction and pinning. And the management is controversial. It is controversial whenever we involve the vascular surgeons. They are always insisting on exploration, and we as orthopedic surgeons prefer observation. And the literature is still divided. There are no clear, strong evidence recommending one or the other. So in our series, what happened, of the 48 patients who did not have return of pulse, we assessed the perfusion again. 40 of them, about 80, more than 80% of them had good perfusion and just needed observation. So it is not the pink pulseless limb, it is pink pulseless perfused limb which can be observed safely. The rest 8 patients who had poor perfusion underwent exploration. The other thing in the literature is whenever there is a pulseless limb with a median nerve injury, there is a recommendation that you should go ahead and explore. Is that true? So this is the literature about that. There are a couple of articles. But in our series, we did not find that true. So of the 21 patients who had median nerve injury, 16 patients were in the observation group. So about 75% of the patients with median nerve injury who did not have pulse did fine with just observation. And this is yet another recent article which is also saying that median nerve injury is not an absolute indication for exploration when you have a pulseless supracondylar fracture. So then what is the definitive indication to explore? Obviously, a poorly perfused hand that remains poorly perfused after your closed reduction and pinning is an absolute indication to explore. And the other way around, a well perfused hand without pulse to start with, and after your reduction and pinning becomes doubtfully perfused or poorly perfused, again it's an absolute indication. This has happened a couple of times for us. The limb was perfused well, pulse oximeter signals was good, but after reduction and pinning, it will go off. So that is definitely an indication to explore. If you look at all our 8 explorations, only 2 of them had significant arterial injury, which needed microvascular work. The rest all were like kinking or spasm or release of some fibrous tissue was done. A case example, an 8-year-old child with type 3 pulseless reduction and pinning was done. On the right side, you can see that saturation and waveforms are good. On the left side, the saturation is not picking up on the flat line. So this is not a good sign for perfusion for us. If you look at the capillary refill, left side, it's not looking great. On the right side, the capillary refill is good. So you can always compare with the opposite side to see how the capillary refill is. And this patient did not also have Doppler signals both in the radial and ulnar artery, was explored, and he had a arterial injury which was thrombus which was excised and anastomosis was done. To summarize, whenever you have a pulseless supracondylar fracture, there is an indication to do emergency closed reduction and pinning, but you should also think in mind about vascular surgery backup, whether it is available, and assess the perfusion, properly document whether the limb is perfused or not. If the pulse comes back, it is important that you admit the patient and keep them at least for 24 hours observation. If there is no return of pulse, again you reassess the perfusion. If it is well perfused, inpatient observation, again, if it is doubtful perfusion or no perfusion, exploration is indicated. Thank you for the kind attention.
Thank you, Dr. Venkatesh. Due to a bit, we are short on timing, so I'm not allowing any question now. Anybody requiring can contact to the speaker directly. Second topic, again on infection, osteoarticular infection, surgeon's nightmare, requesting Dr. Ritesh to go ahead, please.
Respected Chairperson, sir, my seniors and colleagues, today we are discussing a lot of cases in which we had problems and the problems which taught us something new. As we all know that patients are our best teachers, and if we stay with our patients, we learn a lot of things. I'll be discussing a few cases in which we had some problems and we learned something new. This is about a patient, 2.5 years old child, who presented to us with a pathological fracture and discharging sinus. This patient was having problem for last 6 months, and she had a osteomyelitis, had a pathological fracture, and she was kept on traction and antibiotics, but it was not healing. The moment the patient reported to us, we found that there was a large diaphyseal sequestrum, and it was there was a pathological fracture, and she was unable to bear weight. If you see the literature, lot has been talked about it, because pathological fracture in osteomyelitis is not very common, but still not uncommon. In around 5% of osteomyelitic cases, the patient has pathological fracture. And these cases are usually having a virulent type of infection, which leads to pathological fracture without trauma. What happens with the sequestrum? Because there is a question that if there is sequestrum, many a times we say that leave it, because gradually involucrum will form, and once the involucrum is formed, then we will take out the sequestrum. But this is not the case with all the cases, because sometimes small sequestrum resorbs. If it is good enough in the cortical area, it is incorporated in the involucrum. Sometimes it is discharged through the sinuses, but sometimes it requires removal because a large sequestrum which is not getting resolved by the body, it needs to be removed by the surgical procedure. Also, it has been discussed in one of the book by Dr. Manoj Padman in his chapter. Very nicely they have discussed about the management of pathological fracture in osteomyelitis, and they have segregated the management in prevention and treatment. Once there is pathological fracture, then we need to stabilize it either by operative method or non-operative method, and there should be adequate control of the infection. So considering all these principles in mind, we found that the patient is not improving. There was large sequestrum which needs to be removed and adequate control of infection should be done. So we removed the sequestrum thoroughly, debrided, and filled that gap with stimulant with antibiotics and kept the patient on hip spica. 6 months later, we found that infection is under control, but there was a large gap. Since the child was around 3 years, we don't keep the patient on bed. We made the brace and asked the patient to walk around, and the patient was happy in moving around. And if you see how to manage the gap, the next question was how to manage the gap and how to get the bone. So fibular graft is one of the good option, and we went in November 19, we went for fibular grafting and local bone grafting, stabilized with the K wire and hip spica. But 6 months later, we found that all the fibular graft is resorbing gradually, and the gap is maintained, and the patient started walking. At that time, COVID lockdown started in February, and the patient sent these photographs from their home that the patient is not on plaster, she is mobilizing with a gap. 2 years later, the patient reported to our OPD, and now the patient was walking with severe limp. Now there was around 10 to 11 centimeter of shortening, difficulty in walking, attending school, and fibular graft was totally resolved. This is the condition. 6.5-year child now, large femoral gap, and there was shortening around 12 centimeter. Femoral shortening was 10 centimeter and tibial 2 centimeter. The major question was from where to get the bone, because if there is no bone in pediatric age group, nothing can be done. So we started getting some bone out of that and applied the LRS. Over 4 months, gradually the LRS came out, but again it was readjusted and recorticotomy done, and it was lengthened. You can see that. Finally it was removed at 1 year. As you can see that 2 years back when we started with LRS, there was a small bone, a small proximal part of the femur and large gap, but now the patient has good amount of bone. The parents were fed up with the fixator device. They said that now we don't want any device, only the brace was applied and the patient is walking now, attending a school also. We have advised 2 years of rest. By that time more bone will form and we can go some secondary procedure done in these cases. But this is not the situation with all the patients. This patient presented to us at the age of 16 months with pathological fracture discharging sinus due to osteomyelitis. The patient was kept on hip spica for around 3 to 4 months. Then sequestrum was removed and a stimulant was applied with antibiotics, and you can see that good control of infection occurred. She was kept on brace and mobilized, and you can see 4 years down the lane the good femoral bone has formed with canalization, and the patient is walking with limp of 2 centimeter shortening. Another patient, 11 years old, with the same problem of post-septic sequelae of the hip, left hip joint. He was limping and came with the problem of pain in the hip joint. After first reporting, the patient was again lost in follow-up due to COVID lockdown. This patient was managed by, initially we planned for two-stage management. First was abduction osteotomy or pelvic support osteotomy was done in the proximal part, followed by femoral lengthening, and you can see that the patient has good femoral length restoration and the patient was able to move around comfortably. Videos. You can see. So in these type of patients where the pediatric patient having osteomyelitis, bone is the most important factor because loss of bone, we cannot bring it from anywhere else. And restoration of bone length, that can be followed by union. That is the most important thing. And second, when to intervene, when not to intervene is one of the most important question. So never go for over surgery in these patients. If we wait for some time, good soft tissue healing occurs, the results are very good. Thank you.
Thank you, Dr. Ritesh. I know these were difficult cases to deal with, and you have dealt it with a lot of care, and we find some good results. Carrying on, may I request Ritesh Pandey, please do his presentation on leads presenting Monteggia fracture and dislocations.
Thank you, sir. So, at the outset, I thank Amulya sir and the whole organizing team for making me a part of this event. And I will be speaking about management of neglected Monteggia fracture dislocations in children. So let's start with this 9-year-old boy who had injury 6 months back, and to us he presented with deformity and restricted movements around his right elbow. So the questions that arise here are what to do and how to do. Can these injuries be left untreated? If surgical intervention is chosen, then how much delay is safe to get a good outcome? Should we do acute reduction or try gradual reduction with the external fixators? And should we go for open reduction or try the closed reduction of the radial head? And do we need annular ligament reconstruction in such cases? So these are the learning objectives. We will be seeing the reasons for late presentation. We'll try to understand natural history of untreated injuries, and we'll discuss the current concepts of treatment. So we all know a Monteggia event is a combination of radial head dislocation and fracture of proximal ulna, and this can be of different types as per the Beddoes classification. And if they present after 4 weeks of injury, then we label them as delayed presentation. And as per the literature, the misdiagnosis rate can be as high as 28%. The most common reasons being the family issues where the patient themselves present late. But another important reason is the unusual site of injury. In children, the ossification centers develop sequentially, and this may make the assessment of the joint and their alignment difficult. The other reason can be the casual approach of the treating physician, where the physicians are more concerned about treating the ulna fracture and may be totally unaware of what is happening around the joint. And we all know that children are non-compliant for physical and radiological examination, which makes the diagnosis further challenging. And hence, it is advised to have images of the contralateral elbow for comparison whenever it is found necessary. So clinically, the children present with an antebrachial protuberance, and they give the history of trauma in past. Radiologically, the plastic deformation of ulna can be appreciated by ulnar bow sign by drawing the Mubarak's line as shown here, and radiocapitellar alignment can be assessed by drawing the Storen's line and lateral humeral line. And if we see the natural history, the literature has reported many significant complications if these injuries are left untreated, and hence early surgical intervention is recommended. Furthermore, the literature says that if the delay for surgical intervention is more than 3 years, then it is likely to give poor outcomes.
So the management principles are to correct the angular deformity in ulna and to get a stable reduction of radial head, thereby restoring the proper ulnar, proper alignment of radiocapitellar joint. And all these objectives can be achieved by doing a distraction angulation osteotomy in the ulna and getting the reduction of radiocapitellar joint. So the site of the ulnar osteotomy should be in the proximal third as high as possible, allowing placement of at least 2 screws in the proximal fragment. Now, a proximal location of osteotomy gives better control in manipulating the radial head as well. But if the angulation is quite severe, then ideally the osteotomy should be performed at the cora. And the osteotomy is always directed in a direction opposite to the direction of dislocation. And if you ask me about the sequential steps, then first do the ulnar osteotomy, then we move to the radial head and try an open reduction of the radial head. And as soon as the radial head is relocated, the osteotomy will attain a distracted and angulated position automatically, and then you need to go back to the osteotomy and fix it with the plate and screws. Open versus closed reduction. So it has been found that closed reduction is usually not successful because there will be lots of fibrous tissue filling the original position of the radial head, and also there will be buttonholing in the capsule through which the radial head has dislocated. So open reduction is needed in almost all the cases. Regarding the use of transcapitular wire intraoperatively and reconstruction of annular ligament, the literature is again divided. But in our experience, we don't feel that this is needed. If you have done a good distraction angulation osteotomy, then you will get a stable reduction of the radial head. For example, here we can see the radial head is stable in all range of movements without any transcapitular wire or annular ligament reconstruction. Now, few studies have reported doing the same thing by gradual distraction of the osteotomy using an Elizarov fixator. But again, in our experience, we have not found good outcomes by this method. The radial head remains dislocated or subluxated because we are aiming for a closed reduction in this technique. Now let's go quickly through some examples. This was a 4-year-old girl, injury 30 months back. And if we see the initial radiograph, it is very difficult to say whether she has a Monteggia fracture dislocation or not. But when the patient presented to us later, the radial head dislocation is quite apparent in the other X-rays. So she underwent distraction angulation osteotomy and open reduction of radial head, and these are the follow-up images showing good outcome, satisfactory alignment and good range of movements. This was another case, a 6-year-old boy, injury 12 months back, and here the movements around the elbow were also restricted. The flexion range was 40 degrees to 120 degrees. So he was also managed by the same technique, and we can see there is significant improvement in the range of movements, and the outcome was good. Now, because the theme of this conference is based on complications, I will show few complications which we experienced with this technique. So this was 9-year-old boy, injury 6 months back, and he was also managed by the standard technique. But at 4 months, he presented to us with this wound dehiscence. The plate and osteotomy site both were exposed, but luckily the osteotomy had healed by this time, and so for him the plate was removed, the debridement was done, and wound was resutured, and further follow-up was without any significant issue. This 14-year-old boy, injury 24 months back, so he was also managed with distraction angulation osteotomy and open reduction of radial head. And we can see here the radial head is quite stable while moving the elbow. But at 3 months, these were the radiographs. We can see the radial head subluxation at the follow-up of 3 months. and osteotomy has healed and somewhat remodeled. The amount of angulation has reduced here. And clinically, the patient was complaining of a click whenever he was moving the elbow joint. So we were thinking of revising it, and the same was conveyed to the patient, but they were not willing actually for so early revision. And when the patient presented at 12 months, we can see the things have settled down. The head is quite stable here in both extension and flexion, and the click which we was complaining of clinically has also settled. So the take-home message is prevention is always better than cure. Don't wait for a delayed presentation. The idea is to pick up these injuries at the early stage and fix them for a better outcome. Acute reduction and osteotomy, fixation with plates and screws is usually effective and has good outcome. Closed reductions are usually not successful, so and open reduction of radial head is needed in most of the cases. And regarding transcapitular wire and reconstruction of annular ligament, usually they are not needed if you have done a proper distraction angulation osteotomy. Thank you very much.
Thank you, Dr. Ritesh. May I request Dr. Saurabh Chaudhary? Okay. So now there is a change in program. Dr. Manoj Padmansari is supposed to deliver the lecture on a case of post-traumatic avian following fracture femoral neck.
So that'll be my final talk for the session, and here, so I'm going to kind of present to you a case, fortunately rare, but one which doesn't have any easy solutions. This is a post-traumatic avascular necrosis following a fracture neck of femur in a child. Fracture neck of femur in children are thankfully rare. But it's a dreaded complication when you have it. So this was a case. It's not treated by me early on, but it can happen easily in anyone's hand. So I don't have any of the injury films. He presented, his father is actually a doctor, presented at 11 years with a fracture neck sustained 2 years prior, which is fixed with closed reduction, not open reduction, with cannulated screws. And on follow-up, the surgeon saw avascular necrosis, so took out the implants. And because he felt that this was behaving, this was extruding and collapsing, similar to what you could expect in a Perthes disease, decided to try out adductor release and put an abduction Petri cast, which is reasonable, but Perthes is a completely different beast. Post-traumatic avian is not going to behave that way. So, but this is how we presented with. So in all of these problems, in all of these situations wherein the initial X-ray looks like you immediately want to kind of jump into management, I would suggest that you take a step back and kind of list out, what are the problems, and what are the problems that you can address, and then you can say, that's how I would kind of look at it. And I would suggest that some of these situations, that's a good way. So if we were to interpret this X-ray, you don't need any further advanced imaging to kind of list out what are the problems. That's clear. So it's not just a collapsed head, that's a subluxing femoral head. Yeah, so that's going to this thing. So Shenton's line is clearly disrupted. So you have a central area of necrosis. You have an extruded femoral head, that's the Perkins line, and you can see that's there. It's probably more visible there. Unfortunately, the central area of necrosis is directly beneath the primary compression trabeculae under the sourcil. So that is going to cause problems further down the line. Sorry, I'm not pressing the right buttons. Yeah, so then you look at what is happening to the angles. So normally, as a rough rule, the neck shaft angle can vary in children depending on different positions. So if you have a sphere outlining the femoral head, the tip of the trochanter should be roughly the same, kind of at the same level, and the distance should be 2 spheres from this thing, as you can see in this. And if you draw it on the other side, you can see that That's where it should be, but that's where it is. So that is coxa vara, irrespective of what the neck shaft angle is. So that trochanter has gone up. And it is also the horizontal distance, as you can see, it's medialized. So you have coxa breva, which is like, a short neck, which again creates problems for abductor function. So coxa breva and coxa neck, even though the neck shaft angle looks reasonable, it's not too bad. It's not too bad compared to that, but that would need to be addressed because abductor malfunction or trochanteric override is a significant impediment. Okay, so that's your list of problems that you need to sort out. In a hip, in a growing child, as you can see that the whole pelvis is this an attempted functional view, abduction, internal rotation, in a hip which is stiff. Okay, so these are the things. So then you kind of say, okay, these are the problems. How do I kind of address it? Okay, so what are your options? Conservative, there is really, you're just waiting for an accident in slow motion. This is going to become eventually painful and stuff like that until you feel that you can replace the head. So conservative at this stage is really nothing to discuss. There's no point sending them off for physiotherapy or abduction casting. It's not going to work. What are your surgical options? Can you get this piece of malformed head back into the head by containment or some form of proximal femoral osteotomies, be it varus, rotation, whatever you want? Is that possible? Can you ignore that and create a shelf over it or a chiari as a salvage option, as Dr. Venkat talked about yesterday? Just ignore where the femoral head is, create a buttress on top. Can you distract it and pull it down to address this thing? Would that kind of create some form of congruency? What about wait for it to become painful, or even at 11, excise the head because it's a stiff hip, excise the head, create mobility, and then do an Ilizarov hip reconstruction? Or say, okay, look, I don't want to kind of deform the femoral head, let it burn out, let it become painful over a period of time. So you kind of have to develop a mechanism, a stepwise mechanism of how you're going to address this, or anything else. Okay, so that is again taking us back to the picture. So that's the outline of the head. So if I were to put it across to you, if I can get that piece of head inside by a varus osteotomy, that's definitely exaggerated varus, but I can get it. That's relatively healthy cartilage. This is the central area of the necrosis. What are the problems here? The trochanter is going up. That's going to impinge, and the abductors are not going to work. So you may have a good-looking X-ray, but you'll have a patient with a very bad walk, okay, and they are not going to be happy. So if I can get it in, but also bring the trochanter down, so I have a situation wherein I'm anticipating a problem and I'm addressing it. Okay, so that has been well loaded. This is one paper which I would recommend that those of you interested in hip surgery should look at this. So it is based on the principle of creating an extended retinacular flap, so that you don't actually lengthen the neck, but you use part of the trochanter to recreate the neck. And that does all of this. There is a pictorial illustration of what we do, how we do it, preserving the blood supply. So this is what we went about doing it. So you created varus. In fact, I would have considered a bit more varus than this, but brought the trochanter down. And this is how he is at 3 months post-op. So you can see that sentence is restored. The central area of necrosis is medialized, but probably not medialized enough. I would have wanted it a bit more in. The trochanter has come down with the varus osteotomy. So that's at 6 months down the line. So if you look at this, was what the pre-op picture is, and if you now trace the outline, sentence is intact. That's the central area of the necrosis has moved a bit further in. Extruded head, better, but I would have wanted it a little bit more in. Okay, so it's off, or I've offloaded the central necrotic head. I've recreated the abductor biomechanics, brought the trochanter down. That's the tip of the trochanter. And that's the neck length I've created by relative neck lengthening. That's him. You can see his range of motion has improved, and you have reasonable congruency. So that's further down the line. So you can see that the results are holding good over time. That's a year down the line. You can see how it is remodeling. That's close to about 2 months post-op when he came for implant removal. And this is both 3 months post-implant removal, no fixed deformities, full flexion, little bit of terminal rotation restriction. The only issue is leg length discrepancy, which I will tackle with a contralateral epiphysiodesis at the right time. So the objectives of hip preservation in this case is, yes, they will eventually need a total hip replacement, but to kind of delay it as much as possible by adhering to these principles, getting a relatively healthy cartilage under the dome of the acetabulum, achieving congruency and impingement-free motion. Thank you.
Thank you, Manoj. I think we'll not take many questions, but definitely we'll give the floor of thought. Any two, I think each speaker can have one question, probably. And I could restrict that. Can I request all the speakers, Venkat, Ritesh Runu and Ritesh Pandey, Manoj is here already, and Venkat to come on the stage. One question for each speaker. By the time they come in here, I would just comment. You can, yeah, please come. One thing, I mean, we were listening to the elbow fracture dislocation, SE, in children. One thing which I had a nightmare, I'm not sure whether you guys have had it. It was only one in my life. It was in Sheffield Children's when I used to work as a junior consultant. We had a major issue. Simple dislocation in the ER, they tried to reduce it, and then it was a pink arm, and it was a nightmare. I think nobody should be, neglecting that. It's extremely important. Anybody from the floor? Any questions?
So what is your cutoff limit as far as time is concerned after in the emergency you've reduced and percutaneously pinned it? How long would you wait even though it's pink? First thing, and where would you get an access to those portable Doppler machines that you had?
Okay, so that's a very good question. How long to wait before we decide into explore? So there is no magic figure. So roughly I would say that 20 to 30 minutes is the cutoff. By the time you will be able to know whether the limb is perfusing or not. So that is the maximum time. There has been instances when we were willing to shift the patient inside the OR again from the post-op. The vascular surgeon comes, and when he comes back, the pulse is back. So usually we pin with the limb in abduction. You have to keep the limb, so you remove this abduction, keep the limb in like 30 to 40 degrees of flexion, warm the limb. So all this will help to get the pulse back or the perfusion back. You do all the steps, wait, give a good 20 minutes time, and then you decide whether it is coming back or not. The second question, I'm sorry, I don't know from where it is procured. I will find out and let you know. But it's not very expensive device. It's a handheld Doppler machine. Yeah.
It's available in the market. It's pretty simple.
One thing I want to highlight.
Yeah.
Decide where the artery is, and they mark it out and then do a flap.
Your plastic surgery department should be.
Adecco is the company and it costs 30,000 rupees.
Can I ask a question to Dr. Manoj? Yeah. My question was on your central sector AVN, which was post-traumatic. You showed an X-ray where the abduction was only 20. Doesn't the 20 degrees of abduction limit the amount of varus you can dial into the hip? So.
No. If you're doing if you're not doing an osteotomy, then you would be able to. That the previous surgeon had tried an adductor release, so these things won't move in with just a soft tissue release. But once you have done an osteotomy, you should be able to move it in. Yeah.
So the restriction in abduction is not related to the joint deformation.
Not yet.
Not
it
yet.
might eventually become. Yeah.
One thing I want to highlight in cases of that pulseless pink hand, that when we are asking our residents to tell me that what is the SpO2, usually they will apply probe and they will say 100% or 99%. We should stress on the waveform of the reading, that whether waveform is coming or not. Many a times there is only flickering, no waveform is there, still it will show 98 to 99%. It means the major arteries are not clear. They are kinked, and we need to clear them out by proper and keep these patients under observation, because many a times developing hematoma, day 1 it is fine, 6 hours it is fine, by 12 hours the pulse is gone. So constant observation is very essential. Thank you.
Thank you, folks. I think we'll end the session here and we'll move on to the next session, which is session number 19. I will be calling upon chairpersons, Ravi Bharadwaj. I thank the chairs for sharing the session, please. Thank you.
Thank you. Ravi Bharadwaj, Ashish Devgan, Mahesh Prasad, Shamshul Huda. Who is there? Shamshul is not here probably, obviously. Okay. Now, while the chair is going to be assembling, one question, or probably one comment I would say in Patna. We had this infection session earlier on. Do we have blood bank, a bone bank I asked. I believe we don't have bone bank in Patna. It's pretty simple. In Bangalore we have it. You could definitely approach for allograft. And even in Patna you could definitely have the organ donations, limbs, muscles, tendons, joints, bones can be harvested. It will be a good idea to look into that, and it's a very, very economical when compared to stimulant. Thank you, thank you.
Thanks.
So now we'll start our next session, and I would like to invite our speaker first, Dr. Arnab Sinha. So please come on the stage to speak on the topic of a very complex thing, and that is the huge misuse and confused limitations of the gene expert test in diagnosis of spinal tuberculosis.
Thank you, the organizers, for this wonderful opportunity, and with the permission of the chair. This is a patient of spinal tuberculosis who was clinically positive for TB. X-ray was positive, MRI was positive, early signs of TB spine, managed as a case of drug-sensitive tuberculosis, and recovered after 13 months of conventional ATT. Simple story. So where is the catch? The catch is that this patient was gene expert negative for tuberculosis. The patient holds this test very close to his heart, looks dead into your eyes and asks, डॉक्टर साहब मैंने ये जांच कराया है, काफ़ी महंगा जांच है, इसमें तो नेगेटिव बता रहा है, टीबी का बीमारी नहीं है. How to answer that? That is the topic, limitations of gene expert test in the diagnosis of spinal tuberculosis. All of us know that it is a nucleic acid hybridization probes. It detects MTB and rifampicin resistance. The PCR amplification of the rifampicin resistance determining region is done. And all of us realize that it has become a game changer. After coming into practice, it has become a game changer for the diagnosis of tuberculosis as well as for the diagnosis of resistance. It is automated, closed system, minimally technical expertise is needed, it is fast, less cross-contamination, requires much less biosafety infrastructure. And many tests have shown that after this test has been used, it has reduced the time to start the definitive treatment from 56 days to 5 days. That the correct diagnosis has been done and the treatment has been started. The difference is 56 days to 5 days in many studies which has been published. Now the WHO says that it has to be used as an initial diagnosis test for suspected MDR-TB or suspected HIV-associated cases, and follow-on test to microscopy where MDR or HIV-associated TB is of lesser concern. These are some of the results of extrapulmonary samples. Lymph node samples, CSF samples, joint tuberculosis samples, very good sensitivity, specificity, positive predictive value, negative predictive value, everything is fine. From spine, these are the tests. Again, the data is very good. But what are the problems with this? The impact of gene expert technology in tuberculosis control. TB diagnosis with gene expert remains problematic for certain subpopulations as pediatric populations as extrapulmonary tuberculosis. Implementation of gene expert testing is also difficult in settings where molecular testing is not routine and infrastructure is poor. Results of gene expert also depends on the sample type. Serosal fluids, which constitute a major challenges in extrapulmonary tuberculosis, the diagnostic utility is limited, but it is good for lymph node and cold abscesses, which we are talking about, spinal tuberculosis, cold abscess. It is very good, the results are very good. So where is the problem? Getting a sample from the spine is not easy. It is a diagnostic challenge because of the difficulty in sampling from this extrapulmonary site and the paucibacillary nature of the specimen. That is, getting a specimen is difficult because of deep inaccessible lesions. Even if one gets a sample, a paucibacillary state is the condition, and in many cases, initiation of empirical ATT has already been done before starting this test. There are certain barriers to the sample. One is the patient barrier. The patient doesn't want to get this test done. Next is the surgeon barrier. The surgeon doesn't want to get this test done, or the anatomical barrier, especially in the cervical region. And the important thing here is there's the physician barrier. All of us know the spinal tuberculosis is treated by physicians, neurosurgeons, and as orthopedic surgeons. So what have been my limited experience is that the physicians are reluctant to get any invasive tests done. They get a lot of blood tests done, lot of imaging done, but no invasive test is of their liking. Till today, we have got tests like this, where only X-rays were done from the starting to the end. No other test was done for the diagnosis or the treatment of TB. The patient recovered. Barrier, MRI, the best investigation. This MRI said that subtle marrow signal changes in atlanto-occipital joint, mild soft tissue thickening adjacent to the joint and around the odontoid, but nothing was commented about it being a case of spinal tuberculosis. The patient refused a gene expert test. I sent the patient again for re-reporting of the MRI. The re-reporting came back, which was supposed to help my diagnosis. The re-reporting said these subtle changes may be seen as various inflammatory and infective etiologies, or may be non-specific, to be correlated with clinical and laboratory investigations. So this re-reporting actually increased the confusion rather than clearing the confusion. This same patient, it was managed as a drug-sensitive tuberculosis, recovered after 12 months of ATT. Another barrier is that gene expert is negative, but it is being done from the wrong side. There are many instances I've seen where the patient is suffering from tuberculosis of the spine. The patient goes to a physician. He gets a gene expert done from the sputum sample. The sputum sample is easily accessible, easy lab facility. It is given free by the government. So the patient thinks that I've got my gene expert done. It is negative, it is positive. But the point is that it has been done from the wrong side, not from the site of the lesion. Other limitations are it only detects the rifampicin resistance or the sensitivity. It is a surrogate marker for multi-drug resistant tuberculosis. It may lead to overestimation of MDR-TB even in regions where rifampicin monoresistance is high. A line probe assay is probably the answer, but that is not freely available. The gene expert test is also sensitive to higher temperature and humid constituents, which are quite prevalent in countries with a high TB burden like our country. It does not eliminate the need for conventional microscopy, and it does not eliminate the need for culture and sensitivity. Gene expert test is not suitable for monitoring the response of the treatment. डॉक्टर साहब मैंने 3 महीना पहले कराया था, ये जांच आया है, मैं 6 महीना से दवाई खा रहा हूँ, मेरा फिर से जांच करके देख लीजिए. That doesn't hold any water because it detects DNA from viable as well as non-viable bacilli. An MRI lacks the clinical picture, agreed. But still, this is the only investigation which is the best bet for judging the response to the treatment. Here we can see the MRI at 0 months and 16 months of ATT. Studied on the use of gene expert for monitoring the response to the treatment, starting of the ATT before the sample collection cannot be solely attributed to the negative results of gene expert. A further study may be for the role of the gene expert after treatment with the ATT in diagnosis and monitoring of spinal tuberculosis. Analytical limit of gene expert. Every investigation has got its limit. What is the analytical limit? 131 colony forming units per ml of the specimen, provided the specimen is collected properly, provided the specimen is sent properly, and provided the study is done properly. 131 colony forming units per ml needs to be there. In culture, it is just 10 to 100 CFU per ml. So how do we increase that? There's this investigation known as Gene Expert Ultra, which is coming up for use in tubercular adenitis in this study, which says 15.6 CFU per ml of specimen only is needed, and this may be useful in paucibacillary states of tuberculosis like spinal tuberculosis. This paucibacillary condition differentiates it from other form of tuberculosis like pulmonary tuberculosis, in which you give a sputum sample, easy to get, you get a gene expert test done, which is again easy to get, and you come to the diagnosis, but that is not the case in spinal tuberculosis. Future directions: increasing concern about the sensitivity of the gene expert in paucibacillary individuals and in HIV infected individuals. In our country, the proportion of patients who have got the infection of tuberculosis all with HIV is increasing day by day. Either Expert Ultra is to be used, or Abbott is coming up with Abbott MTB assay. And not only these two companies or these two tests. Just 2 slides, sir. This is future directions. All these are coming up. These ways and assays to increase the efficiency of the gene expert test, and soon we may expect a one-stop solution to the diagnosis of this condition. So no test for spinal tuberculosis is perfect. Even if the yield in spinal tuberculosis is low, conventional culture is still the gold standard. There's no doubt about it. Gene expert clearly outperforms microscopy, but it has its limitations too. If gene expert test is positive without rifampicin resistance, patient should receive appropriate first-line ATT immediately. If the gene expert test is negative, clinico-radiological presentation, culture, histopathology should be rechecked before excluding the diagnosis of spinal tuberculosis. Thank you.
Thank you. And the question answer is the last. So I would like to our next speaker, Samsu.
So do we have Dr. K. Saran sir here? If not, then we have Dr. P.K. Raju sir for management of sacral fracture, sir.
Well, good afternoon. This is my second and last talk in the Gofcon. Thank you very much for the chairpersons. And there's nothing nightmare about this talk or cases here. I'm going to just show you the modalities of managing sacral fractures. Together with the iliac crest, sacrum forms the cornerstone of the ilium, and it acts as a center of the pelvic load. Essentially, it plays a fundamental role in giving stability to the pelvis. And it is in contact with several structures, neurovascular structures, hence sacral fractures are troublesome and may have serious consequences like this, neurological injuries. And 30% of sacral fractures are identified late due to poor visualization. And they're missed in 49% of patients who are neurologically intact. Like this is a more common nerve injury seen. And 12 months mortality rate is about 28%. And it is threefold higher in patients over the age of 65. So let's focus on the diagnosis and managing this, and some errors during the judgment or diagnosis and management as well. See, you need to take a proper history and proper examination should be done. You should know the zones of relative weakness to identify the fracture lines, and considering the age, insufficiency fractures. You need to be aware of this in elderly people. And this is the typical fracture line seen on the lateral side in an insufficiency fracture pattern. It can be diagnosed by SPECT scan. And you need to be aware of soft tissue trauma around the pelvis, especially moral level lesions and bleeding from vaginal or urological lesions. And you test for pelvic stability. Neurological examination should be done. It includes bulbocavernous as well as the anal wing reflex. And you need to be aware of traumatic dural tears as well, and the incidence is quite high. Take a good quality radiographs before moving on, and sensitivity is only about 10.5%. And you need to suspect the sacral fractures if there is a L4, L5 transverse process fracture, or if there is a paradoxical inlet view like this due to a transverse fracture at S3. And CT defines all this, number of fragments, comminution, the displacement, and insufficiency, fragility fractures, and you can assess the corridors for placement of the screws. MRI is helpful in patients with unexplained neurological deficits and fragility fractures. So we'll move on to management. Classification, I'm not going to deal with this because there are numerous classifications. And most commonly we follow this is the Dennis classification. All of you know that. So the errors, most commonly made errors during the management of sacral fractures is, one is diagnosis because you miss, second is identifying the stability, and the third one is errors in the definitive management, especially failure of reduction. So definitive management can be a non-operative management if the displacement is less and if the fracture is stable. This is a 56-year-old man with fractures seen in all the three zones. And it was managed by non-operative treatment. At the end of 6 months, you can see the consolidation. So it can be treated non-operatively as well. So there are potential complications with non-operative management like chronic pain due to malunion, sacroiliac joint arthritis, changes in the alignment of sacrum, neurological deficits, which can persist in fractures like this. And operative management is indicated if the displacement is more than 1 centimeter and if it is unstable. I'm going to show some cases. And it should be done as early as possible within 5 days. These are the different modes of treatment. Surgical management, we'll move on to one by one. Percutaneous screw fixation. Most important aspect of percutaneous screw fixation is you need to do reduction. Screws won't reduce. So reduce the fracture, then fix. This is a 45-year-old male with a hemipelvis going up and X-ray doesn't show fractures in the sacrum. Here you can see. Dennis type 2 fracture in the CT, fixed by iliosacral screw after a good reduction, and anteriorly first posterior fixation was done, and then this is a good result. Even the second case, Dennis type 2 closed book injury with a sacral fracture type 2. We tried to reduce it in the CT scan room. So it was, we could reduce the fracture. So then we took him to OT, fixed under C-arm, reduction was done, fixation was done with percutaneous screws, and anterior column screw was placed. Not a good reduction, but after 3 months, patient had good union and good results. So this is the case axillary where you cannot diagnose. It looks normal. All the views, inlet, outlet, as well as AP view looks normal. Look at this, the break in the arcuate line. So you need to look for this. Then CT shows both sacral fracture, Dennis type 2, and anterior column fracture. So which was again fixed by screws posteriorly, then went ahead with anterior column fixation. So coming to errors in the management, most important, it's essential to be aware of sacral dysmorphism. So this, up to 40% of patients can have this, and you can diagnose with these features: residual upper disc space, and a large non-circular sacral neural foramina, and acute alar slope, and a tongue in groove SI articulation. So please be aware of this before doing iliosacral screw fixation. And in this case, it's better not to use an S1 screw, go for an S2 screw. An example is, this is a case where ilium, you can see the sacrum at the level of the ilium. It's an 18-year-old girl where this X-ray doesn't show anything. CT was done, Dennis type 2, and we went ahead. We placed the screw first, by mistake. We used it for the upper one, which was wrong, and then we went down, fixed for S2 vertebra. This is how it was, and she was doing well. And this is another case where there is a hemipelvic injury with, vertical shear injury with a sacral fracture. Went ahead with fixation. Everything was good. Postoperatively, looks well. Everything, even the inlet view looks good. But patient developed paresthesia in the distribution of S1. He started complaining of severe paresthesia, pain, because he was a nuisance in the ward. So I'm sorry to say that, but what to do? We just explained him, and after some time, after 3 or 4 days, we got the CT done. It was compromising the foramina. Then look at this evidence. Some do advise neurolysis as early as possible, but another study says early decompression doesn't afford any benefit. But we went ahead with the removal, and patient symptoms definitely improved. And we have done about 155 SI screws till last year, and about them, only one had this problem, a neurological injury. This is Dennis type 3. Yes, is involving the sacral foramina. So what we did is, anyway, this is we thought it is a stable fracture, went ahead with a fixation through and through, and anterior fixation. Reduction of symphysis was also good. After, another 1 minute, after 10th day, you can see the diastasis there, diastasis of the. So this is due to instability. We could have used, you can see the loosening as well. So we could have used 2 screws for the sacrum because it's very unstable, or we could have gone for a lumbopelvic fixation. Then this is a bilateral sacral fracture with diastasis, fixed,
What is wrong with this? It looks nice. Patient continued to have pain after some time. Look at this view. So it was not reduced. The posterior displacement was not reduced properly. So he continued to have pain. We couldn't do anything. We'll have to plan. We'll have to remove the screw and wait for the results. So errors in the definitive management. Another case. Look at this. Dennis type 2. Here tension band plating was done, and results were good. Results were good. This lumbopelvic fixation provides good stability in a highly unstable pelvic fracture, especially vertical and a transverse component is here. Fracture, there's a transverse Dennis type 3, transverse fracture, and bilateral sacral fracture. Here we went ahead with spinopelvic stabilization. It gives very good vertical control support. It's most biomechanically stable. But one study says that he did encounter plenty of complications. There was a need for reoperation to remove all this fixation in 95% of patients. Well, we need to know about these complications. Most important is to prevent the errors in the management. Proper diagnosis, CT is obligatory, and you need to choose conservative management in certain cases. Identify all the areas of instability, fix properly, and reduction is very important. Thank you very much. Pelvis is a place to work, not a place to play. Thank you very much.
Thank you, sir, for a wonderful talk. Next, we invite Dr. Santosh, sir, for his talk on acute pelvic injuries.
Thank you very much again, sir. So it was a very fantastic conference, and I enjoyed a lot here. So this is my second talk, and it is a very common problem in the emergency services. So the management of pelvic fracture, the first 24 hours. The first 24 hours is a step ladder approach, and one form step at a time should be taken for the proper treatment. So overall incidence is about 2% of all fractures, and among polytrauma it is very high, 25%. So pelvic rake injuries are the high octane injuries associated with the high morbidity and mortality. The main emphasis of initial management is control of the life-threatening hemorrhage is there. So tamponade is the closure or blockage of the bleeding, and traditionally it is assumed that the amount of volume accumulation in the pelvis correspond to this cylinder. But in pelvic ring disruption, this can be greatly increased and resulting in life-threatening situation, which we cannot imagine how much bleeding is there. So always during the primary survey, remember the ABC of the trauma, and thoroughly assess the pelvis in the polytrauma patient, and suspect a pelvic involvement in all high energy patient, so that always go through X-ray for the pelvis as well. So value of 2.5 centimeter displacement is somewhat arbitrary and controversial with regard to the stability and reliability of the pelvic injuries, and radiography forms the cornerstone of the treatment, and the tile classified it is based on the penile and tile Jude and Laternal. The determining factor is the integrity of the posterior sacroiliac complex, as Dr. P.K. Raju has already said that. So the tile classification system is based on the integrity of posterior sacroiliac complex, type 1, type B. Type B injury is caused by either the external or internal rotational forces, resulting in a partial disruption of the posterior arc. These are often unstable. Whereas in type C, these are characterized by the complete disruption of the posterior arc and are both rotationally and vertically unstable. So these injuries are the result of the great force, usually from a motor vehicle crash. And type B injuries are, generally speaking, these are rotationally unstable, and B1 is open book, B2 is ipsilateral lateral compression, and B3 is the bilateral lateral compression is there. So in the type C injuries, generally speaking, these are the rotationally and vertically unstable, and they are also classified in type 3. Whereas the associated injuries are the chest, abdominal, genitourinary or head injury, and these are the sites where we can lose maximum blood. So these are some associated injuries as well. So the cause of mortality in these patients are the uncontrolled hemorrhage, and in these subgroups of patients that require the maximum attention to save the life. So you have to be a global view and save lives. You have to be an orthopod, urologist, vascular surgeon, colorectal surgeon, gynecologist in your team whenever it is required. So the two main principles to follow are to save the life, or do not do anything to compromise the definitive reconstruction at a later stage, and when you need, use your cell phone and call a specialist, or to call your friend to know the situation, how to manage in these cases. So open pelvic injuries require the immediate attention. As an orthopod, we should be able to identify the clinical signs of the urethral injury, although Foley's catheter is a preferred modality. Remember to pass it only if there is no contraindication is there, and in sometimes suprapubic catheterization may be required. So do a careful examination to detect the possible nerve damage and properly document the injury and the deficit, because alarming is the fact that lumbosacral injuries can damage up to 45% of in the type C injuries. So assessment of stability is very, very important, and it may be the normal, stable or unstable as well. And there may be the mechanical stability may be found. So the true definition of pelvic stability is more complex, and it should be radiographic, hemodynamic and biomechanical. So it is important to differentiate between the term shock and hemodynamic instability. So hemodynamic instability is behavior of consumption coagulopathy. Secondary hemorrhage can be uncontrollable. Aggressive monitoring should be there. The blood transfusion as required is essential in these cases, and start aggressive replacement of the things which you have. So increased risk of hemorrhage occurs in the anteroposterior compression and vertical shear in the Young and Burgess classification of group. So there is a very important to, we should know the sheet wrap to control the hemorrhage in the emergency department. So it should be in the supine position. Two wrappers should be there. The placement of sheet is very, very important, and apply the gradual force, and then clamp should be placed on the zip. So this is a very immediate emergency measure in case of these. So this is a X-ray before the sheet wrap, and the second one is after the sheet wrapping. So there is a pros and cons about the sheet wrap. The pros is quick and easy, inexpensive, can be done in emergency room, and good tamponade of expanding hematoma. But no definitive stabilization is by this, may impact on the exposure. So you go for the external fixation if required. So there is a good control of anterior instability and depend upon the bone quality, but it is not also a definitive treatment. So there are different locations for the application of the external fixation, and each has a different clinical application. When you use on the anterior iliac spine, resuscitative, anterior superior iliac spine, this will be augmentative, and if C clamp is used, then there is a definitive fixation. So this is our the various position where we have to use the X-fix in these cases. So C clamp is the definitive treatment in these cases, but it is not present everywhere, and it requires a surgical skill as well. So management algorithm is primary survey, and after that we follow this stop external blood hemorrhage and treat the hemorrhage or pneumothorax, assess of the long bone injuries, and chest, cervical and pelvic X-ray. So the overall resuscitation and documentation is mandatory in all these cases, and assessment of the abdomen is very, very important as well. So many of the times we should give the diagnostic peritoneal aspiration for the confirmation of all that. So this is stabilize the pelvis and non-invasive device, and fluoresces using the small liquids of fluid. If there is abdomen positive, go for the immediate transfer to the OT for the laparotomy and X-fix, and keep the patient warm. And if abdomen is negative, go for the continued fluid resuscitation, maintain the systolic blood pressure, and reassess the monitor the patient and keep warm about them. So in the If there is a systolic blood pressure is less than 70 mm despite the fluid resuscitation, immediate laparotomy for the surgical control of arterial blood should be there, and pelvic packing with the large sponges, and reassess the patient and reassess the patient every time with the regular interval. So beware of the consumption coagulopathy. So in the summary, there is in the trauma unit, all unit receiving trauma must be able to save life in major pelvic injuries. This is the very, very important goal of the, and you should be determined whether this is patient is hemodynamically stable or unstable. It is very, very important, and define the fracture pattern on the X-ray. Is it mechanically stable or unstable? So as to, you have to assess, assessment will be better in follow-up cases. So the only injuries that require you to operate as emergency are those are mechanical and hemodynamically unstable. Detect all complication of pelvic injuries as soon as possible and get it right first time. Speak to the pelvic fracture unit as soon as possible. Do not compromise the definitive treatment, reconstruction by inappropriate early care. Thank you very much, sir.
Thank you, Dr. Santosh. It's a very elaborated and impacted pelvic fracture. And our next speaker, Dr. Gautamar Prasad, who will speak on difficult cases in a spine.
Yeah, good afternoon, everyone. So the theme is nightmare. So difficult cases can be nightmare, and it's not very uncommon. It can happen. Let's see how we actually take that cases and whether it takes as a nightmare or challenge, because nightmare need not occur only at night. It can occur pre-op, it can occur intra-op, and it can occur even post-op. Let's dwell with the first two right now. So this is MRI and X-ray pics of a 3-year-old. She came to us with dribbling micturition. Even at the age of 3, she could not walk. She had a deformed leg, spasticity, which was mistaken for foot deformity. So what she presented with, this is a CT scan. So you have two vertebrae which are going into the canal, and this is some toppling of the vertebra, spondyloptosis at 2 levels. And the cord was low lying, the cord was getting severely compressed, and she had spastic paraparesis. She was too tiny for her age. She was just 3 years and 5 days, almost the age of my daughter. So there was some emotional attachment. Single mother, that adds to the complications socially, because economy and single mother, so all those things were going on. She is so small that a normal 4.5 pedicle screw is out of the question. So what we did was, we started off, and intra-op, there was no demarcation whether it's actually the bone or cartilage or the soft tissue. So it was a hell lot of thing. You don't have too much of blood, that blood loss that was permitted. We started by around 3:30 p.m. and the patient was shifted to ICU by 1 a.m. in the morning. And because of the post-op things, I was there in the ICU even up to 2 a.m. in the morning. This is what we did, and after 3 months of this surgery, her neuro was intact and she walked well for the first time in her life. And this nightmare fortunately did well for her, and now she's almost 6 years old and she comes every year just before her birthday. Another case. So this is a typical angst-spawn case. 45-year-old had a fall and he had just a flicker present in one of the toes. So the neurology was not completely damaged. Now remember, these are the ankylosed spine, the bamboo spine that we commonly call as, and there is a large fulcrum. So such cases needs anterior and posterior fixation. The cord was severely contused, and that was the reason for his neurology. This is the intra first pic which got. The plan was do anterior first, anterior stabilization, fixation, and then come posterior fixation. This was the thing, we could not have a complete reduction intra by positioning. I could manage reduction with a small plate, and I was very happy because it came off in like 35 minutes. Going in and coming out, I was very happy. I had a doubt that I should have put in longer plate, but I said, chalo, I'm going to, as it is fixed posteriorly, and 30 minutes I'm done, so I will go home early. Again, it was a Saturday. So you know that Saturday you have to go home, be with the family. We positioned the patient prone, and this is what I saw. The plate was actually falling short, and it has actually gone into kyphosis worse than what it was pre-op. But again, thoda sa apan manipulate karte, it's like cheating hum log thoda kar le. So I thought, why not to put in posterior screws and do some manipulation and put in rods and fix it. I tried, but I failed miserably. This is what I got. It is still deformed, though the screws are in anterior and posterior. So what to be done next? Again, went in, removed the rods, then went anteriorly, tried many times. Then anteriorly we put in a longer plate in whatever direction we could get, and then again went behind, put in a rods and got a fixation. Now remember, because the neurology was involved, but the flicker was there, so it was not zero. So always that back of the mind, the thing was whether I have actually caused more harm to the patient. Fortunately, the same flicker was present post-op, but he was on ventilator support for a long time because of the neurologic condition as well as the Angst-Swan's test, which is bad. He was on tracheostomy, had a prolonged ICU stay. We have to reduce all the charges, get into CGS package and all those things. Fortunately for everyone and the family members, he's a walker now, and this is how it pays. So the patience, the persistence, the thing to get him back on the thing, that was continuously going on. So that paid, and this is what makes the nightmare as more challenging and more rewarding if you're on the positive end, if you have a positive end result. So what it depends on, whether you can take up the challenging cases as a challenge or it ends up as a nightmare. Well, it's like the learning curve. So the learning curve starts with being with a guru, your books, your colleagues with whom you discuss your cases, then online study, cadaveric training, which is very of utmost importance. Then you train under some senior who do cases, start doing cases under some senior, and then learn from the tricks from various surgeons all around, and then that's when you start your practice. And I believe this is what should be the ideal thing which we should follow in our life. Second learning comes with mistakes. Your mistakes from your own, and the smarter ones learn from the mistake of others. Skill is something which is God gifted but can be developed. I could not use my left hand during my PG. Now I can do 60% of my work with my left hand and non-dominant hand. Patience, that's of utmost importance if you're in spine. Persistence, innovation, try to make things ready for you. The plan B, the plan C, what if the plan fails? And ultimately, what ultimately is needed is the blessing of God. Very lucky to have this guy as my guru, Dr. Shekhar Bhojraj. If you're an orthopedic surgeon, you will be aware of him. I was lucky to be with him for 5 years. And these are my good pals, whom I can call at 11 p.m. and even early in the morning. These are the ones who even have helped me at times during my intra-op calls, Raghu and Samir. Your books, your ever friends, your ever ready friends. And during your practice, you should keep on improving yourself. Analyze your own cases. Analyze what you have done, what you could have done, and what you should not have done. Look out for your own mistakes rather than somebody else pointing out your mistakes. You try to look at your own mistakes. Even an X-ray comes out somebody else's operated by somebody else. You check out whether there was something mistake, whether the mistake in the planning or whether the mistake of execution, and try to think about what went wrong with that. What was the condition, what might have actually forced him to do something wrong, and try to analyze that and try to correct in your scenario as to how you should improve. Try to improve every steps. So if somebody who's associated with me, they know that it's the same step I follow through and through. So if there is some steps which is actually going wrong, you will be aware of it. So always try to be meticulous, always try to do same thing again and again, and that's how you improve. Keep calm during tense situation. I remember I was doing a C1, C2 fixation, and we had a nick at the plexus, and it, just 1 minute more, sir. So in a fraction of like 3 to 4 minutes, I lost 1.5 liters of blood. But that time when the anesthetist was shouting, I actually asked them to play my music, start my music, which always goes on in the behind. So you have to keep yourself cool. And remember, God, that's my personal take, it's up to you. So your challenging cases will be challenging. You should have a good foundation. That's the learning curve that you should be proud of, and you should always continue to be in that learning process. Keep on learning from your own self, your own mistake, others' mistake. Have patience, and that's it. Thank you. Thank you very much.
Thank you, Gautam. It's a nice presentation. And our last speaker, Anupam.
He's talking on maximum surges via minimum approach, endoscopic spine intervention.
Thank you everyone for having me here. Gautam sir, lovely presentation. You got to give me some time so that I get chance to train and learn from you as well. So my talk is going to be on Destandu's technique. My presentation is never going to start until I pay mention to this person, Dr. Jean Destandu. He is a neurosurgeon from France, Bordeaux, and he was the one who invented this prototype instrument which is called Destandu sleeve system, and this revolutionized the way spine is being approached everywhere, whether it's India, Asia, Korea. There are multiple societies, PASMIS, ISMIS. There has been a superlative shift from approaching spine by open to endoscopic techniques. So this is what he designed, and this was patented by Karl Storz, and it was marketed worldwide. You can see the instruments. There is an operating tube, obturator, and then there is a working insert, and then the marking devices. So it has basically 3-4 holes through which we approach our spine endoscopically. The keyhole techniques, as you see, if you want to get an appendectomy today, I think none of you would opt for an open procedure. I think lap is the way to go. So that is how spine is evolving if the indications are right. So why do you want to make a shift? We want to attain the same thing which we do by open spine. We want to decompress our stenosis, our discs. We want to free our nerve roots. We want to improve our claudication and all. But we want to do minimal collateral damage. We don't want to do a wide laminotomy or a laminectomy. We want to do a lesser collateral damage so that we avoid the unnecessary fusion. We don't want to fix. We want to preserve that segmental mobility and also the safety to the patient and the surgeon. This technique, Destandu's, it has an advantage that you have very less radiation exposure as well. So this is how a typical OR setup looks. You need a good C-arm, you need an endoscopic setup, you need a good table which can be adjusted up and down, you need a workstation, and you need basic instruments which were designed by Jean Destandu. You don't need costly tables. You can make use of simple bolsters. These are bolsters from OT, and you can place the patient in knee chest position, typical of a spine surgery. So typical of open spine surgery, you have to give hypertensive anesthesia and all that. I'm not going to go into that. Your abdomen should be free. So what we do typically in this is we localize our level. We just need couple of shots. We don't need more than that. And what you need to learn is how to triangulate your instruments, as in any scopy procedure. So your hand movements. So if you know your arthroscopy, I mean most of our orthopedic surgeons are arthroscopists. So if you know your spine anatomy, if you do open spine and you know your arthroscopy, the things are a bit easier. So this is a demonstration from past MISAP conference, which was in Ahmedabad, and we had a chance to demonstrate it on a pig model there. So just a snapshot of how we do this case. Can we have this out? Yes. How the procedure is being done. So basically we mark in our level. As you can see in this case, L4, L5, there is a disc which is significantly causing stenosis. We have a stable grade 1 listhesis. So we went in to approach this patient. We marked our level under C-arm. So this is what you can see. So we give a paraspinal incision and then we approach. So what I'm hitting with my suction tip, you can see, is the lamina, the L4 lamina. And I'm going to take in my Keresons. 345 and 390 are usually the workhorse in Destandu. 3 mm 45 degree, that is what I mean to say. You can see that I'm taking the same way I'm taking, how you take punches in your open spine, this is how you take in endospine as well. So I'm trying to create a laminotomy, and this is how I'm removing my phlegm. Everything is the same, just that I'm trying to enter through a small incision, and I'm trying to attain the same thing. So this is how I'm trying to dissect out my phlegm. And this is the first look of the cord, as you can see. I don't have much time to show a lot, so I've sped up, and this is how we attain a decompression. So you can see that how things have changed from 20 years ago. You can also reach your spine in a similar way, but through a smaller incision. So you can see the nerve root, the traversing nerve root, which is getting decompressed. And this is how it looks after full decompression. So your magnification is around 25 times higher. The tube is mobile, that's the best part of it. So you can approach your central as well as paracentral as well as extraforaminal. All kind of disc and stenosis can be approached by this. You can also do interbody fusions. There have been very derivatives like EasyGo, tubulars. After this, UB, DEST lifts. This is the disc space, and you can do discectomy as well. So that is how you get the clear picture. This was one of my cases, L5S1, approach through a 2 centimeter incision. We decompressed spinal cord. We got both the nerve roots free. So there is a learning curve. Yes, as Dr. Gautam sir was saying, you have to spend time with your mentors, learn. You should have good friends whom you can go back to. You can do another one of my cases, L4, L5. You can see a big posterior disc down migrated, and I did endoscopic discectomy. The patient is instantly relieved, mobilized the same day, discharged another day. The amount of disc which can come out, and you have to learn the dexterity, how you put in your patties, how you dissect your phlegm and all. I'm not going to go into all this. Have I done enough? And you will always realize endoscopically, since your magnification is high, you always end up doing more than what you intend to. So you can do a bilateral over the top decompression from unilateral laminotomy only. So ULBD very much. You can see the nerve roots which are going in through the foramen and all. Epidural vessels are also visible. So yes, that's it. So dura tear, yes, it does happen. You have to learn through your complications, how to preserve your neurology and all. How you read your MRI, there will be a pattern shift. I mean, those radiculopathies which you would feel that I was not able to tackle before and they were not subsiding by conservative treatments, you will be able to reach those hooks and corners by these techniques. You should invest in your growth. They are superlative instruments now, 3D endoscopes which give you depth perception and all, because depth is an issue when you start these cases initially. So yes, buy good cameras, 3D techniques, augmented realities and all that, which are going to push you and give maximum help. Long-term results, multiple papers have been published, Asian spine journals, and index surgeons, their prodigies. Dr. P.C. Day, he is right now the vice president of MISAB. He is also the president of World Endoscopic Spine Society. We were lucky enough to have got a chance to do Westcon at Bodh Gaya. Dr. Amulya sir was there. He honored us there as President-elect of Bihar Orthopedic Association. Dr. Praveen Sahu sir was there. He helped us through it. Mahesh Prasad sir was there. He had a talk at ACDF there. So it was done exactly this day last month. And we did the first endoscopic spine cadaver course here, just last slide. And we had around 50 registrations. Carl Stroh supported us greatly, and we had a great time there. So that's a pic of Amulya sir with us. And with that, I'd like to close. Thank you so much. Thank you so much for having me here.
Thank you, Anupam. It's a wonderful presentation. And I would like to invite all the speakers come forward to take some questions from the audience. So our speakers Arnab Sinha, Santosh Kumar, Santosh Singh, and Gautam Prasad, and P.K. Raju sir. So, any question from the audience?
Yeah, Dr. Anupam. Yeah, this side.
Yes, sir. Thank you.
We have always seen that discs are very common.
Yes, sir.
When you are moving, and most of the people, and 80% of the people are supposed to have back pain.
Yes, sir.
And most of the time when you go for an MRI, there is, whenever the MRI radiologist reports, it is something degenerative with disc prolapse or something like that. How often you plan for surgery as such? Because there has to be some factors taken into consideration when you will decide to do, how long you are going to wait. This question is both for you and Gautam both.
Yes. Before Sir can put, I think I'm going to give a short statement about that. I think my presentation is not as to how we select our case. I mean, that selection is going to be very less. I think hardly if there are 100 discs, I think you would be operating around 5 and I would be doing the same. I think 95 of them will be going conservatively only. We got to give them time. All of us are going to suffer from low backache and that's written in our books. We were supposed to walk on 4 legs. We are walking on 2. Our spine became erect. It's going to degenerate with time. Our hair is going to go gray. So it's not about endoscopically if I'll operate more. No, I will not. The indications are going to go same. I'm going to give conservative treatment, wait for it to subside. The natural course is that it's going to go, the disc is going to either stabilize or resorb. The spine is going to stabilize. So the natural history of disc degeneration. So very less, I think very less. But where it is indicated, yes, I'll go endoscopically. That gives better result in my hand, but it's just a way of belling the cat in a different way. Whether you do open or tubular or endoscopic, I think at the end of the day, your nerve should be decompressed, your radiculopathy should be released. That's it.
So if I may answer, so the surgery is not decided on MRI. It is actually decided on the patient. So you cannot treat the MRI. That is never going to happen. So if the clinical symptoms warrant surgery for anything, yeah, so if it's a disc, so severe pain not getting better with conservative management, neurological weakness, recurrence of pain, it does get better, but recurrence of pain, which is not getting the patient back to the normal. So if a tennis player is having pain on and off and his tournament is lying like 6 months down the line, I cannot subject him for a conservative management. So depends on the patient's condition. And regarding the method, so if patients ask me, sir, do you do endoscopically? Yes, I do. But it's like I tell them this line actually, which everybody can have. Like Indian Army has got a sniper, a pistol, a AK-47. They have got ATGM. They have got Howitzers, tanks, and everything. So let your surgeon choose how to kill your disease. Okay, it depends on the surgeon's skill, the surgeon's approach, and what the pathology is. So just a month back, somebody actually asked me to do an endoscopically decompression of his spine, which had OLF, ossified ligamentum flavum, and I did from, he wanted endoscopically, which I refused, and I did from D3 to D7, D10 to L1, and then L4 to S1. And removing that hard bone endoscopically is not possible. So you have to choose your pathology, and then based on the pathology, based on other things, and I even add into that the economics. Based on pathology, I even add into economics, because with endoscopy, I'm investing more than 50 lakhs in my setup, and if the patient is going to pay me with the PM Yojana, sorry, it's going to be open surgery. So there are multiple factors which count into decision making, and 1, 2, 3, 4, you have to light on that. Thank you.
Yeah, Dr. P.K. Raju, yeah.
I'll just add one thing. There was one discerning factor that endoscopy is going to be very, very costly. And that is not true. It's going to get down, it's going down and down and down. It's going to get more standard, not only in India, but world over. Why? Because the cost of instrumentation is coming down drastically. Instrumentation and fusion needs are going down drastically. That's it.
Thank you. Time is less. Dr. P.K. Raju from Bangalore. About the sacral fractures, percutaneous fixation, open fixation, how you decide?
Sir, most of the fractures now we do percutaneous only. None of them. See, open fractures, if I cannot reduce the sacral fracture after 5 days, and if you take the case after 3 weeks due to some other reason, where you cannot reduce, then we do open posteriorly, we use a distractor, laminar distractor, distract, and then reduce, then fix the fracture. So otherwise, most of the acute fractures we fix by closed method, that is percutaneous technique.
Hello, my question is from Dr. Gautam Prasad. Can you allow every movement, every activity, normal activity to the patient which treated by open method?
So I have patients who are actually commandos in Indian Army.
Yeah.
One is a boxer, another is a boxer. All post-op they are back to their routine. So there is a gradual rehab that you should associate it with. So after surgery, there are some restrictions for first 1 month, then that restriction comes down every 3 months. And then by the end of, like, my football player, the guy who is a football player, he's actually playing into this Calcutta leagues. So 1 year down after the surgery, he was back to his professional football.
Can you advise some precaution after long time, for long times?
For long time, like, see, you have to improve your posture, take care of your back, do your routine stuff, maintain good posture, not to be overweight, all those things, the same routine which we advise to everybody, that should be followed. Yeah, thank you.
Thank you all. And one question I would like to ask Arnav and Santosh Singh. Santosh Singh, do you feel the acute pelvic injury is a very critical situation? How can you decide whether to go first resuscitation or go fixation in the emergency room?
Always, whenever you feel there is a instability and on the reassessment, the patient cannot be controlled and it is metabolically unstable, then you should always go, if you don't have any X-ray at that time, then you have to apply the sheet trap as well. If you find there is some instability, and in the polytrauma patient, if it is he is unconscious, then you will definitely keep in your mind that there should be some pelvic injury will be there. So there is a protocol in the polytrauma patient, the cervical spine, lumbosacral spine and pelvic injuries. They should all be covered whenever you send the patient for the x-rays. But in the because the golden hour is very, very important at that time, so there is no harm to sheet trap the pelvic without knowing it is unstable or unstable. So my takeoff is this, to always apply the sheet trap.
Thank you.
Sir, if I may answer for this. See, initially all patients, 97% of patients in pelvic injuries, if they bleed, it is due to venous injury. Only 3% they bleed arterially. So initially the pelvic wrap, that whatever you do, pelvic binder, is most of the times it's enough to control the bleeding, or else X-fix. And if you can't do a packing, open immediately, stopaz, do a packing, you can save the patient. Even then, if it doesn't improve, do an angio. So wait till the patient becomes stable, then go for fixation.
Thank you.
2 days.
Thank you, sir. And one question from Arnav. So your topic is the gene expert testing, whether to do or how much it is important to diagnose the tuberculosis. So sometimes we confused even the diagnosis by the MRI or the test. So how can you treat those cases where there is confusion, not expert opinion about the diagnosis of tuberculosis? So should we start ATT first, or when we confirm the tuberculosis, then start a tuberculosis drug?
Sir, one is a practical life, what we are facing patients. One is that answer, and one answer is the ideal answer. So ideally, ATT should not be started because of 2 reasons. One is there may be some other pathology for which we are putting in ATT. So that pathology may increase if it is a case of malignancy or tumors. The next reason is that if you give a patient ATT, if the patient is like drug resistant TB, and you are giving first line drugs, you are not knowing about it, so it may increase the chance of resistance further. So this is the ideal answer. Practically, trial ATT is still used, but ideally it should not be used.
Thank you, thank you.
Thank you, sir.
So this is the thing, conclude the session.
Yeah, thank you so much, all the brilliant speakers, respected chairpersons. Now we have come to a session for which everybody eagerly waits. Can I have the photograph of Dr. B.N. Singh, sir? The last session of Gofcon every time. People always ask why you keep Dr. B.N. Singh oration at the last. I always say, you have to see the hall, then you believe how much respect Dr. B.N. Singh had, late Dr. B.N. Singh, had in the mind of the people. As such, that's why people keep on waiting for this magnanimous personality, Dr. B.N. Singh, the past president of Bihar Orthopedic Association. May I request Padma Shri Dr. R.N. Singh, sir, to kindly come to the dais. May I request Dr. Ramit or Dr. Firoz, please escort him to the dais. He will be chairing the session. Padma Shri Dr. R.N. Singh, former president of Bihar Orthopedic Association, president of Vishwa Hindu Parishad, and so much. Along with him, we have Dr. Vishwendra Kumar Sinha. May I request Dr. Firoz, kindly escort. Former HOD of Department of Orthopedics, Patna Medical College Hospital, Department of Orthopedics, and also the past president of Bihar Orthopedic Association. This B.N. Singh oration, organized by Global Orthopedic Forum under aegis of Bihar Orthopedic Association, is duly supported today by Patna Menopause Society. May I request the president of Patna Menopause Society, again Dr. Firoz, please escort Dr. Kumkum Sinha ma'am to the dais. She will be chairing the session of this prestigious oration. Even after 5 years of his death, Dr. B.N. Singh sir is in our mind. We always remember day and night. But the family, I am truly honored. Professor Usha Sharma sir, ma'am is here along with the daughter, elder daughter, Dr. Archana. Hope I am correct. The name is correct, Dr. Archana. Archana, 2 words from you before I hand over the mic to my chairperson, Dr. Archana, who has come all the way from Delhi. She's working there in All India Institute of Medical Sciences, New Delhi. This will be the true homage from a daughter to her father.
Good afternoon. Good afternoon, sir. Good afternoon, ma'am. As usual, for the past few years, we are always humbled as a family to be here and to see the appreciation and your dedication to carrying forward my father's legacy and his professional ethic, because public memory is short, but this oration has ensured that he will live on in the minds and hearts of not only orthopedicians but his family and those colleagues who knew him. I am very proud to be his daughter, and it's really again humbling for me to come here and be allowed to say a few words. Thank you again. Thank you, Dr. Amole.
Thank you so much, Dr. Archana. I do remember in 1989, when I came back after leaving armed forces to Patna, I was going with my father, late Dr. Hariram Singh, at Patna Medical College Hospital as an intern. A very senior doctor, I'm not naming his name, he told my father, गर्व होता है हरि बाबू कि आपका बेटा डॉक्टर हो गया और हम लोग को अच्छा लगता है. My father told him, I will feel more honored when people say I am father of Dr. Amulya. This is the vision of each children, each parent. And there are some people in this world who are doing wonderful, but people recognize them also on behalf of their children. One such person in this hall sitting. I may be correct, I may be other way around. This is for the person who will say, father of Miss Manushi Chilla, former Miss World. May I request Dr. Mitra Basu Chilla to come on the stage, the orator of this prestigious Dr. B.N. Singh oration, who has come all the way from Mumbai. Sir, please, your laptop will be adjusted here. Sir. He will adjust it. You please have a seat. May I request you, the chairperson, to address first, because first I will request Padma Shri Dr. R.N. Singh, because I have seen you, sir, Dr. Vijay Narayan Singh और सर आप हमेशा हम लोग यही माने बातें यही होती थी हॉस्पिटल में, सर गलत हो सकता हूँ, रंगा बिल्ला की जोड़ी, और सर आप हैं तो आज पहले तो आप ही से सुनेंगे सर के बारे में, फिर इनको इंट्रोड्यूस करूंगा मैं।
बहुत बहुत धन्यवाद अमूल्या, ये बहुत खुशी की बात है कि आज आपने मुझे इनको रिजल्ट में बुलाया और चेयरपर्सन बनाया। आज आई एम गेटिंग लिटिल बिट इमोशनल, बट आई मस्ट टेल यू दैट ही वाज ए फ्रेंड ऑफ माइन एंड ए फ्रेंड ऑफ माइन। हम लोग एक साथ कितना बिताए सो हमको पता नहीं। We lost him, but he is still alive with us. And people like you or people like us who remember him on these days, the great occasion. And Dr. Vijay, हम इनको कभी डॉक्टर नहीं कहे, विजय जी, विजय भाई, चाहे विजय क्या करना है बताओ। और ज़रूरत पड़ने पर ये हमको डांटते थे, मैं इनको डांटता था। और भाभी जी वहाँ बैठी हैं, उन्हें पता है कि हम लोग किसको डांटते थे। ही वॉज ए ग्रेट मैन, ग्रेट सर्जन, और ये बराबर कहते थे कि इट टेक्स 10 years to know how to operate, but it takes another 10 years to know when not to operate. This is the lesson a surgeon should take. It takes 10 years to know how to operate, but it takes another 10 years to know when not to operate. Many a times he told me, क्या ये सर्जरी करो, इसको नहीं करना है। हम कहते भैया अब मैं तो करता हूँ, तुम्हारे एक्सपीरियंस के चलते अगली बार से मैं नहीं करूँगा। तो many a times he was a real judge and a good physician, good surgeon, good friend and a fine gentleman. That is what I can say about him. Thank you very much for calling me there.
Thank you sir. और मैं नेक्स्ट डॉक्टर विश्वेंद्र सर को बुलाऊं, उसके पहले मैं चाहूँगा प्रेसिडेंट सर बिहार ऑर्थोपेडिक एसोसिएशन सर उपेंद्र प्रसाद सर, प्लीज फर्स्ट रो में आप आइए सर प्लीज। एंड इवन सेक्रेटरी बिहार ऑर्थोपेडिक एसोसिएशन डॉक्टर प्रवीण चाहिए हियर। थैंक यू या तो डॉक्टर विश्वेंद्र सर प्लीज।
Everything or many things have been said about Dr. B.N. Singh. He was such a popular in our association, and I was quite junior to him. And after his demise, I needed his thesis, and Madam gave it to me to write a paper on the history of orthopedics. So he was one of the person like a history of orthopedics. Thank you very much.
Thank you, sir. And President of Patna Menopause Society, Dr. Kumkum Sinha, ma'am.
Thank you, Dr. Amulya. Since everybody is talking about this oration, I'll start with some remembrances of Dr. B.N. Singh. It was in, I think, 2007 and 8, or 2.5 years, I was posted in Patna City Hospital. And Dr. B.N. Singh was the orthopedician there, posted just like me as one of the doctors there. And I was the gynecologist there. So we had lots of rapport and we knew how the administration was going on, lots of duty we were doing. I remember one time I had numbness in my hand. Every morning I used to get up and then my hand used to not work. So I just consulted him. I thought it was carpal tunnel syndrome and I needed some injection there. But when I went to him, he just saw me and he said, no, nothing doing, you don't need anything. It will pass off after some time. I did some exercises and I got relieved. And so I remember him. And his wife, Dr. Usha Sharma, all my undergraduate days have been passed together. She was 1 year junior to me. So lots of remembrances. So I wish you all very well for this oration. And moving ahead, I thank, as the president of Patna Menopause Society, I thank Dr. Amulya Singh to have associated us for this prestigious session that is going on. And I welcome both my co-chairpersons, Padma Shri Dr. R.N. Singh and Dr. Vishwendra Kumar Sinha. They are my, and also I wish all the best for Gofcon 2025 and all the delegates who are there present here. And I welcome all the members of Patna Menopausal Society, my founder, President Dr. Kusum Gopal Kapoor, patron Dr. Usha Didwania, Dr. Saroj Singh, Dr. Usha Sharma, Rita Jha, Meera Singh, and Usha Kumari from NMCH, ex-principal, civil surgeon, and Dr. Zareen, Dr. Nutan, Dr. Neelam, all of them are here today. And it is such a good thing that we from PMS also giving us some Shraddhanjali to Dr. B.N. Singh. So you have organized this, all the best to you, and we go ahead with the session. And of course, I welcome our speaker. We've heard so much from him for all his update on newer techniques on health, well-being of the health, and newer techniques of aesthetic introducing into this. So I wish him all the best. Thank you.
Thank you. Thank you, ma'am. Now we will be shifting towards the oration as such. And Global Orthopedic Forum is privileged to acknowledge Dr. Mitra Basu Chillar. Your illustrious career as eminent physician whose career is worthy of emulation. You hold an MBBS, MD Medicine, MBA, Healthcare Administration, and FAM. You began SOMA, described a unique regenerative medicine concept, and serve as the medical director of SOMA Wellness Clinic in Mumbai. Your training includes the multi-agency Gold, CBRN, and Police National CBRN Center in Wrighton Coventry, UK. You are a faculty member for biological warfare at the National Disaster Management Authority. You are also trained Six Sigma quality manager from Hyderabad and a panelist for Lok Sabha TV's Healthy India program. Your awards and accomplishments include the Best Paper Award in the 20th Annual Conference of the Association of Physicians of India, held at Hubli, Karnataka, India. You were recommended by the Director Debble for your high scientific contributions in developing a cardio risk analyzer during medical evaluation. You received a Technology Group Award for establishing a high-end telemedicine link between Pandit BDS PGIMS Rohtak, India, and your own institute. Additionally, you received a Technology Group Award for managing coronary risk factors in DRDO population. You were also awarded a certificate appreciation from the Professor and Head and President of the Association of Physicians of India for your contribution and arranging the update on critical care medicine. You contributed to hospital management guidelines during disaster by the NDMA and serve as faculty at the National Disaster Management Authority. Your education credentials include a fellowship in aesthetic medicines from 2023, an MBA with first class from Delhi University FMS, Delhi in 2012, an MD medicine from PGIMS MD University Rohtak in 1994, and an MBS from PGIMS MD University in 1990. Your professional experience includes roles such as junior resident at the Department of Casualty, Deen Dayal Upadhyay Hospital, New Delhi, and from there you never stopped, you kept on marching ahead. You are a member of FMS Alumni Association, the Association of Physicians of India, so many organizations. You have got a significant number of publications with 55 in various national and international journals. You have also edited 6 books and authored a book chapters. We are intensely proud of your academic and professional success and pray for your long life in the service of humanity. Over to Dr. Mitra Basu Chillar, sir.
Namaskar. Before I start my sharing of my thoughts to you all, I would like to thank Dr. Amulya for giving me a chance to share some of my experiences and experiments with what I did in my past about 30 years of medical practice. So, with the permission and blessing of the dignitaries, the chairs, I'd like to start my today's see for about 25 to 26 years, I worked with DRDO as a medical researcher. And there I realized that most of the things which we claim as known might not be known and will be known after a couple of years. And sometimes as medical doctors, we feel we know a lot. But by this age, we all understand that it's not like that. My father was an astrologer, by the way. And I used to just mock him about the way he was advising people. He was also a consultant to people. Like, to me, he was a psychotherapist. So I used to mock him कि बाप आप लोगों को बेवकूफ़ बनाते हो. So in return, he used to counter argue like this, that आप भी तो ऐसा ही करते हो. मैंने कहा, how come doctors do that? They say, because you all are too much focused on your accomplishments and positive results. You have got a blind eye to what you actually don't see or you don't want to see, and that is what you don't know. That used to confuse my mind. So is it true? Is it really that there is so much we miss in the data, in the patient which comes to us, in the things which happen around us? As medical doctors, is it really significant proportion of the data we are missing or not? Let me share a couple of case studies with you in that direction. How many of us know that now it's very old news that there are heavy metals in various cosmetics which we use day and night? And most of those heavy metals, the most prominent is mercury in that. And why mercury? Because it gives a mercury in parts per million concentration, but remember, all heavy metals handled directly, they cross your skin barrier. Why mercury is used in these cosmetics? Because it gives a particular little bit of shine. Even if it is not labeled, they use them, and there are many particular, like these brands. I am very sure most of us know some of these brands, like Aroma Magic, Olay, Natural Ponds, White, some Fair and Lovely is also there. I use Fair and Lovely for many years. L'Oreal, Revlon and Batik. So mercury remains the secret ingredient in many of the cosmetic products. How many of us as medical doctors know this? Anyhow. Regarding COVID-19 attack, how many of us think, was it an attack, a sort of a biological? I was a biological warfare expert at DRDO. Was it a biological attack or was it a freak laboratory accident which happened unintentionally? Or nature, it was a mutation of virus? Was it really lab made? Or as medical doctors, do we have a definite viewpoint on this, what actually it was? We still are confused because nothing concrete has come out from somebody else's mouth for us to reproduce. But anyhow, I like to just draw your attention to one of those internet screenshot where it is written, terrorist likely to conduct biological attack by 2020, US intelligence report warns. It is not important that somebody predicted that there will be a biological, they use the word terrorist and attack or a biological event or something like this. It's not important that somebody predicted it, that it will happen in 2020. Important it was predicted in 2005. How many of us as medical doctors really knew about this, that in 2005, somebody had a strong prediction of a very significant biological phenomenon happening in year 2020, which actually happened in year 2019, just 1 year of error was there. As medical doctors, as service providers, as guardians of the health of the community, we missed to notice this data, that's all. Almost all of us know that heavy metal like lead, it gets deposited in bone marrow and it leads to anemia. But is it so significant that there are more than 5,000 publications of anemia and lead poisoning only from India? And whenever there is an adolescent person with anemia comes to us, how many times we actually want to estimate the lead load of that particular person to find out if it is a heavy metal poisoning. There are so many studies, and this, like one of the papers, it quotes that lead level for children with lead level more than 10 microgram per deciliter. In this study, more than 10 microgram per deciliter could be deleterious as far as just anemia is concerned. But this is one of the reports of a laboratory, a standard laboratory, which shows biological reference interval of lead should be less than 150. Of course, it is microgram per liter, so in deciliter it will be 15. So up to 15 microgram per deciliter, they say it is a normal biological reference interval. Now, another study says, okay, more than 47% of children in India could be suffering from lead poisoning or lead intoxication or lead accumulation. They include our own children also, don't. And not only this, even these low levels of lead, less than 5 microgram per deciliter, it is not 15 microgram per deciliter, which was put as biological reference interval as normal in this. It is, they say, even less than 5 microgram per deciliter shows lead toxicity and long time accumulation effect, which are associated with impaired intelligent quotient, means IQ of our own children. More than 47% of our children are suffering from lead toxicity, and it is impairing our IQ of our children. तो आपके आधे बच्चे तो हमारे तो क्या mentally retarded होंगे? Because most of us just look at those biological reference intervals given by these laboratories to judge if a particular person is suffering from a disease or not. Another lab, it is showing biological reference intervals less than 25. वो less than 5 पे बोल रहा है आपका brain damage होगा. Why less than 25 is taken as biological reference interval? I don't know. So, when even less than 5 microgram percent of serum lead has deleterious effect, then why biological references? I don't have an answer. If anybody in this forum can answer this, why this is kept as biological reference interval, the person is welcome. I don't have an answer to this. I thought about it, but I don't. Only thought which came to my mind was, maybe somebody must have taken a community sample, random sampling of thousands of the people, drew the mean and plus minus 1.95 standard deviation, that gives 95% of that becomes your normal niche. That was the only thing which came to my mind. Otherwise, there was no logic that why even presence of just presence of lead itself should not be warning us to remove. So of course, beyond anemia, we know these are the other lead things. Some other phenomena which we miss so easily as medical doctors. Understand, one of the phenomena is this. This is a publication which I was a part of that thing. This happened when I was a senior resident in medical college. We published in 1997. In 1996, it happened that we had the publication about 66 persons suffering from falciparum malaria admitted to our ward, and see our language here. While only a minority of cases presented with an uncomplicated course, all others developed one or more complications, some of them very rare. The usual manifestations with cerebral malaria, black water fever and algid malaria seen in past were observed in less than half of the patients, the remaining present with unusual complications like this. We presented and forgot about this. We thought malaria is changing its clinical profile. Now, after decades of this, we know we were wrong. This particular change happened only in 1996, never happened after that. Why? Now, after working in DRDO, working with Ministry of Defense, I realized, sometimes I think, was it a biological attack on us? Was it a modified form of malarial parasite which was somehow done as an experiment in a particular part of the population, and was it observed how we react, how that disease reacts, how we respond to that, how we mitigate, and what our resources? I really don't know. I don't have an answer. I don't know. These are unanswered questions. So it never happened afterward? No way. Another case study. How many of us have the memory of 1994 Surat? There was a plague incident. Anyone remember that? Yes, there was a. Was it really plague? Till date, WHO says no, it was not plague. And till date, we maintain that this was plague in Surat. What happened? Okay, we know plague is not a new phenomenon. It has been mentioned since prehistoric times. There was a mentioning of this thing, but no deaths were reported between 1967 and 1993. And in 1994, here 56 people are dying from a disease, presumably plague, declared plague by us, but not yet accepted by many. Explanation? No explanation, but it was. But what actually happened at that time, I can give you a glimpse. 3 lakh people migrated in 2 days from that place. There were immediate international repercussions. You can just see there's a lot of data, like how our exports were cancelled, how many flights were cancelled, how the tourism was postponed, and so many things happened. And several countries, they had a ban on India. And ultimately, we lost this much of revenue because of those 50 plus deaths. I don't know. I am not able to read this. I really don't know how much is this amount. This amount, anybody can tell you kitna amount hoga? मेरे लिए बहुत सारा है. आप ये बोलेंगे इतने 1000 करोड़ है, तभी मुझे लगा हाँ इतना सारा पैसा है, बस दैट्स ऑल. इससे ज्यादा मेरा माइंड नहीं चलता. Never forget, this was in 1994. आज सेंसस कितना है, उस समय कितना हो, इसकी अगर आप आज की वैल्यू निकालेंगे तो हमारा कितना लॉस हुआ था उन 56 डेथ से. Just calculate in your mind as medical doctor that what happened to us that time. Was it an attack on us? We don't know. What did we miss? But even in 2020, somebody is publishing that a forgotten case of bioterrorism. आप गूगल सर्च कीजिए, कभी इंडिया के ऊपर बायोटेररिस्ट अटैक हुआ? आंसर होगा नो. Why? We don't ring the bell. We don't suspect. We are in that Hakuna Matata state, कुछ नहीं होगा, हम किसी का बुरा नहीं करेंगे तो हमारे साथ कोई बुरा नहीं करेगा. अरे हम क्या सोच, why are we missing this data? जो दूसरे, even in 2020 somebody has not forgotten. Just see, this is not my paper, मैंने तो इंटरनेट से लिया है, but just in 2020 this fellow is publishing. And another one in 2000, another one, this publication says plague that never was. There are people, and the words they use, in resembled plague during 1994 in Beed district in Surat were certainly not due to plague. This word certainly is 100%. Researchers don't use such words. If they have used this word, it means they are very sure that this was not plague. They have not used the word probably. They have used the word certainly it was not due to plague. अब हम क्या करें? How to counter argue? We means Bharat, we means India, we means us. We have declared that it is plague. Somebody is saying it is certainly not due to plague. What to do? Anyhow, moving from plague. How many of us remember कि एक बार दिल्ली में हुआ था ना, that Mayapuri radiation incident? There was a scrap market and couple of people were exposed to radiation. They got. Anybody has got a memory of that? I saw this patient. History is typical. This fellow breaks open a irradiator, uska thoda piece liya, put in his pocket as a sample piece. After a couple of days, he gets pain, he gets discoloration of the skin. He goes to his GP, diagnosed as kuch nahi hua sir, pain mein hoga, theek ho jayega. Then the discoloration happened, he went to skin specialist examined him, कुछ नहीं हुआ सर, आप ये एक वो क्या बोलते हैं क्वाड्रिडर्म टाइप्स जिसमें स्टीरॉयड भी होता है सर, वो लगा लो आप कुछ नहीं हो जाएगा. Then he got pain, he went to an orthopedic surgeon also, who also examined, कहते कुछ नहीं हुआ, maybe some infection, he added an antibiotic. Then there was an ulcer, he was admitted in hospital 1, he was admitted in hospital 2, I am not naming them, they are Apex hospital. You know how it was diagnosed that he got this radiation related injury? In his own words, in patient's own words I am telling. कि सर वो मैं उस हॉस्पिटल के बेड पे लेटा हुआ था, डॉक्टर्स रोज देखते थे कि मेरा वुंड क्यों नहीं ठीक हो रहा, तो सडनली एक दिन एक स्टाफ मेंबर आया कि सर आपको रेडिएशन तो नहीं हुआ. मैंने कहा क्यों? कहते सर आपके ना न्यूज़ पेपर में आया हुआ है कि आपकी शॉप है ना वहाँ के ऊपर रेडिएशन फैल गया है. सम साइंटिस्ट, सम रिसर्च फेलो वाज रोमिंग इन दैट मार्केट with a radiation detector in his pocket which was inadvertently kept on, and he was searching for a couple of equipment, agar kahin se mil jaye koi second sasta sa mil jate, and that equipment started beeping, beep 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 beep. And then he realized that there is a lot of radiation in this area, and then he called for another equipment. Then again it was confirmed that there was a radiation in that area, and that became a news. And once that became a news, then our colleagues, we doctors thought, is it because of that radiation? Not before that. Why did we miss suspecting radiation? Because we never suspected. That's all, simple. So these are the things which we usually miss. 1990 to 1997 endosulfan, लोग अब भूल गए हैं. There was a lot of mention about how endosulfan was used, especially in a place like Kerala. Cashew plantation hoti, is very pricey thing. So by 80s and 90s there was a significant rise in birth defect. Endosulfan happened in 60s and 70s. 80s and 90s there was a significant birth defect. See the decades ka wo story uske baad. And in 2011, 60s में जा रहा है, 70s में आ रहा है. Only in 2011, after years of activation and legal battle, the Supreme Court of India posed a ban on. Story doesn't stop here. The best part of the story is this. National Institute of Occupational Health, and they had researchers, they concluded, yes, this there was a higher prevalence of birth defect in children in 2002 who were exposed to endosulfan, but a journalist, Sri Padre, in 1981 suspected endosulfan causing birth defects. So a non-medical journalist is decades ahead of medical doctors in suspecting this relation. Why these things are happening, I don't know. Okay. So integrated medicine, now I am propagating this word a lot, that we should all come out of our boundaries and become a part of integrated medicine by everything we encompass together. It's an orthopedics conference and I am a medical specialist, I am here talking to you. So what is integrated medicine? Is it an integration of various systems of medicine, or focusing on the whole body rather than on a disease, or acknowledging the role of mind, spirit and beyond in disease and health, and interplay of various environmental health over individuals, or acknowledging the presence of a variable yet to be found as significant in our scenario? We don't know. Framingham heart study, we all know. This was a study which was started in Framingham town of USA in 1950s on 5,000 population, still going on. The main objective was to find the coronary risk factor. उस समय पता नहीं था heart attack क्यों होते हैं. चलो coronary risk factor का पता लगाते हैं. Let us enroll thousands of the people. You know what did they realize? In one of their data groups, they found out obesity is an infective disease. It spreads in population. And how is it infected? We said it's a communicable disease, non-communicable disease. They found out obesity is a communicable disease. In what way? 57% more likely of obesity when one friends become obese. अगर आपका दोस्त मोटा हो जाता है, you have got 57, तो choose your friends wisely. 40% if your sibling becomes obese. आपका सिबलिंग तो 40% चांस आपके मोटे होने के, आपका फ्रेंड के 50. फ्रेंडशिप का रिश्ता आपके बहन और भाई के रिश्ते से ज्यादा गहरा है. 37% if spouse becomes obese. आपके स्पाउस का रिश्ता मतलब भाई और बहन से भी नीचे है, जबकि रोज शिकायत मिलती होंगी कि आप अपनी बहन के लिए इतना कुछ करते हो और भाई के लिए इतना कुछ करते हो. तो वो शिकायत ठीक है ना. नो इन्फ्लुएंस फॉर नेबरहुड. सेम जेंडर इन्फ्लुएंस मोर देन अपोजिट सेक्स, बट नॉट फॉर स्पाउसेस. तो स्प्रेड ऑफ ओबेसिटी इन इट स्प्रेड्स इन जस्ट टाइम. एंड डिस्टेंस, even if your friend or if your sibling is even 760 kilometers away from you, it doesn't matter. It still has got an effect. This is proved by data science. This is no manipulation of data. So what is the explanation why? If your friend becomes obese, you will become obese. ऐसे ही होता है. Again, that if it is 760 kilometers away from you. Is it? Is it? Our environment influences our priority towards food and exercise. Is it? We could subconsciously normalize our health status as an average of people we are connected to. Or emotional bonding of the humans cannot be ignored in health prognosis. Good health status of our near and dears, could it affect us? If yes, then we must try to keep them healthy. Okay, fine. Do you dream? Do you remember your dream? Is it possible that some of us do not dream? Think about it before you say yes or no. How many of us take dream history of patients? None. But there was a talk on nightmare in your operation theater. I'm just giving an example why taking the dream history. Just asking this question from patient that do you dream? या कल क्या सपना आया था? सिर्फ इतना ही पूछना कई बार कितना इंपॉर्टेंट होता है कि something we have heard of pyridoxine deficiency B6. These are the signs and symptoms of pyridoxine deficiency as per literature: fatigue, irritability, depression or mood changes, poor sleep quality, neurological symptoms like confusion or neuropathy in severe cases, and reduced ability to recall dream. I have treated hundreds. टीटी बोलूँगा, ड्रीम नहीं आते, मैं इसको बीमारी मानता हूँ. सपने नहीं आते, बीमारी मानता हूँ. मैंने उसको भी ठीक कर दिया इस बीमारी को, जस्ट गिविंग पायरिडॉक्सिन. आस्क एनीवन इन योर हाउस, आस्क योरसेल्फ, डू यू ड्रीम? आंसर आएगा नहीं यार मुझे सपने नहीं आते. जस्ट टेक पायरिडॉक्सिन 40 milligram per day for 1 month and then again ask yourself that question. And never forget, one of the sign or symptom of pyridoxine deficiency is depression. Okay, now this we know. Sugar, जैसे like for example, I was talking about holistic medicine and integrative medicine. The moment a person with depressive symptoms come, we start antidepressants. Should we think of actual causative agents to stop before actually starting antidepressant? Just stoppage of sugar, hundreds of the patients treated of depression. Genes, presence of toxins in us. I'm not talking about Parkinson syndrome. Diagnosed Parkinson disease, standard treatment Syndopa or deep brain stimulation. Do we ascertain a cause in established Parkinson disease? Arey, cause in Parkinson disease is the cause hai? No. What is the cause of Parkinson disease? There are causes of even Parkinson disease. We have to go beyond our diagnostic labels sometimes, and we proved that if there is significant presence of pesticides in your system, it could lead to Parkinson's, not syndrome, disease or Alzheimer's disease. And depending upon what type of alleles of some genes you are carrying, you can accumulate different type of, you can concentrate different type of these pesticides differently. Some of us will concentrate beta HCA, some will dialdine, some will concentrate aldine, some will concentrate DDT, depending upon what type of genes we are carrying. So that way we are vulnerable to these pesticides which are present in our system. Again, lead toxicity and not low IQ, Parkinson's disease, understand that way. Carbon monoxide exposure. How many smokers are there in us? Here. How many non-smokers are there? That's all. Can burning a coal, cigarette or a stove inside a room to combat extreme cold or smoking cigarette put to you Parkinson? Increased risk of Parkinson's disease in patients with carbon monoxide intoxication. I got more than 56 persons who were exposed to carbon monoxide at high altitude by burning cigarette who have Parkinson on my follow-up. Just single exposure of carbon monoxide. And incidentally, carbon monoxide exposure has been the strongest predictor of Parkinson's disease, stronger than family history, exposure to pesticide, brain concussion, midlife migraine, exposure to environmental toxin, milk consumption, high dietary intake of iron, excess body weight, higher levels of education, history of anemia. Carbon monoxide intoxication or exposure has been the strongest predictor of development of Parkinson's disease. In a Parkinson's patient, should we ask for the history of whether he or she was exposed to carbon monoxide? But for good news for cigarette smokers or smokers. Smokers, somehow there is a link between smoking and a lower risk of Parkinson's disease, is one of the strongest environmental or lifestyle association in neuroepidemiology. No explanation given, this is just an observation, but this is not a recommendation to start smoking. Can we, should we, do we, or would we be able to time travel to treat our patients, or are we already doing it? Study says yes. Actually, we are time traveling to treat our patient. I'll just show you one of the studies. There is a, just 2 minutes, sir. There is the effect of, this is published in British Medical Journal. This study show that the heading is effect of remote retroactive, future में की गई prayer, intercessory prayer on outcomes in patients with bloodstream infection, randomized control trial, not an observation study, not a case study, not a cohort. It is a randomized control trial. Supposed to be, this is where it is published even now. You can go and Google it. What was the objective? That they will do a prayer and whether it has got effect on the outcome. What did it was double-blind parallel group, and what did it was done on more than 3,000 patients with bloodstream infection, septicemia, who were in the hospital during 1990 to 1996, and prayers were started when? In 2000. Confusing है, थोड़ा ध्यान से समझिए. Patients were 3,000 patients were in hospital during 1990 to 1996. Discharged, died, not discharged, lama, हमें नहीं पता क्या हुआ. There were 3,000 patients randomly selected by this group who did prayers on them. When did they do? In July 2000, after this thing has happened. 3,000 पेशेंट्स रैंडमली हमें दे दो, हम चूज करते हैं, इनके लिए हम प्रेयर करेंगे, इनके लिए हम प्रेयर नहीं करते. अरे ये सब कुछ हो चुका भाई, ट्रीटमेंट हो चुकी है, कुछ मर गए थे, सर भूल जाओ उस चीज को, हमें रैंडम असाइन करने दो. लेट अस प्रे फॉर ए पर्टिकुलर ग्रुप. मेन आउटकम मेजर क्या रखा उन्होंने? मोर्टेलिटी इन हॉस्पिटल, लेंथ ऑफ स्टे इन हॉस्पिटल एंड ड्यूरेशन ऑफ फीवर. मोर्टेलिटी का कोई फर्क नहीं था, बट लेंथ ऑफ स्टे इन हॉस्पिटल एंड ड्यूरेशन ऑफ फीवर वर सिग्निफिकेंटली शॉर्टर इन द इंटरवेंशन group than in control group by the prayer which was done years after this event has happened. Conclusion, a shorter, how many of have actually understood what has happened this? मेरे को नहीं समझ में आया क्या हुआ, मुझे सिर्फ एक चीज समझ में आई, time travel is possible. prayer which will be done for us in future, is affecting us as on date. Our outcome as on today is being affected, measured, declared by somebody who will be praying for us in future. मुझे ये समझ में आया है. मुझे ये समझ में आया है कि जब हम अपने एंसेस्टर्स के लिए प्रेयर करते हैं तो हम उनकी लाइफ में शायद जब वो जिंदा थे हमने अच्छा प्रभाव डाल दिया होगा. मुझे इस ब्रिटिश मेडिकल जर्नल की स्टडी से ये समझ में आया है. As medical doctors, if priests and they can do, should we also not do? Should we also not make it a part of our treatment, Katie? If already there is a randomized controlled trial. So, this is my final message. Treating the symptom is important to provide relief. Controlling disease is more important to prevent sequels. Treatment of the disease is important to cure. Finding the cause of the disease is the first step of treatment. Look beyond patient's body to find out the cause of the disease. Never fall for a variable in isolation. Confounding might change its nature. We don't know everything about our subject. Let us know this at least. We need to accept that those who are less literate than us could also provide us with knowledge that we don't have. It is always a healthy habit, never a healthy human being. Before we say goodbye, there is this study just आपको दिखाने के लिए बता रही है. A chemical signal in human female tears lowers aggression in males. अगर आपके सामने कोई फीमेल रोना शुरू कर देती है तो आपका एग्रेशन डाउन हो जाता है. There is a study on this. So, and you thought only a hunter can subdue a tiger. ये गाना बज नहीं रहा. इस गाने के बोल थे वो अखियों से गोली मारे. Means just simple female का tear. If you sniff, no order percept. इसमें कोई खुशबू या कुछ भी नहीं होगा. Just sniffing of female tears lowers your aggression. So, who are the scientists among us? What they should be doing now? This is a tip from me. बाद में मुझे रॉयल्टी दे देना इसका. Isolate the compound from this tear, synthesize them, pack them, and then sell. Thank you so much.
Thank you so much. Yeah.
Thank you very much, Dr. Chilla. It reminds me to say that मरना तो सही है, लगता है जीना ही एक ये क्या कहते हैं विश्वास है. क्योंकि जिस तरह से चिलर साहब ने बताया कि हम कितने चीज़ों के बीच जिंदा रह रहे हैं. It's not surprising that we are dying. It's surprising that we are living. This is what is important. This is the message perhaps we are giving. Thank you very much for saying.
I will request our chairpersons to kindly honor. Sir, please, बीच में आ जाइए.
From Gofcon, 25.
Thank you so much, sir, for honoring us on this Dr. B.N. Singh oration. Big round of applause for Dr. Mitrabasu Chilla. Finally, we will be concluding this Gofcon 2025 on a very positive note. Final words from Dr. Kumkum Sinha, ma'am.
We just heard something very much thought-provoking, Nothing was given for granted. All the researchers were contradicted, and then you have to think back. So it was a bit confusing also, and also promoting us to do some research work on our own and not believe everything that is being said. And also to look at some investigations such as lead and all that is so important in the role of anemia and fetal, all brain mental disturbances that has caused. So it was very good, Dr. Chiller. And also from us, best wishes to his daughter, Miss World. So that was also a great introduction. As we just saw, the daughter of somebody so great as Dr. B.N. Singh is here. So your daughter is also being mentioned. She did a great thing. And from Patna Menopausal Society, we wish Dr. Amulya Singh all the best for, and he did so well. Thank you to you, and thanks to Dr. Chiller for giving that speech, and my co-chairpersons, Padam Shri, Dr. Arun Singh and Dr. Visheshwar Kumar Sinha. And I thank all the Patna Menopausal Society members who have come here, and the senior member. Madam, will you come up for a photograph, madam? Aye, madam. Padma Shri Dr. Shanti Roy, madam, she has come to bless this occasion.
May I request Dr. Professor Usha Sharma ma'am and all members of PMS, please come to the dais. And in between, I will also request our President, Dr. Upendra Prasad, and Dr. Secretary, Dr. Praveen, to kindly honor our chairpersons as such. Please, Dr. Upendra. First to Padma Shri Dr. Arun Singh. Padma Shri Dr. Arun Singh. Shawl. Next to Dr. Professor Vishwendra Kumar Sinha, sir. Dr. Manisha, please. Dr. Archana also, please, for a group photograph, please. I will request to honor Madam Kumkum Sinha, ma'am. Our President will honor. I will request everybody, please, all of you. And this global star, Ma'am Kumkum Sinha ko main bolunga, main apni bitiya, she has come all the way from Bombay. Dr. Akriti, please, and Akshat, both of you. My son and daughter are here. So they will present the small lapel pin from Global Orthopedic Forum to the President of Patna Menopause Society.
Thank you so much. This was very nice and very sweet.
उसको दबा के पीछे से क्लिप दबाओ बेटा ये ऐसे इसको दबाओ नहीं यहाँ पे ये पीछे में काम रहता है ऐसे दबाओ निकल जाएगा जी जी may I request प्लीज एक ग्रुप फोटोग्राफ के लिए आप लोग आगे आ जाइए प्लीज थोड़ा आगे आ जाइए यहाँ पे इसका भी फोटो आ जाएगा सब लोग आ जाएंगे, मैम लोग आ जाएंगे, जो लोग हैं प्लीज आइए। The lunch is in Kautilya Hall. The lunch is starting. Please start the lunch. नरेश प्लीज देख लीजिएगा। हाँ, स्प्रेड कर दीजिए। आर्यन सिंह सर, डॉक्टर मित्र बाशु चिल्लर सर प्लीज। हाँ, आर्यन सिंह सर को, सर विश्वंदर सर इधर आ जाइए। हाँ, हम यहाँ पे हैं, लाइन में हैं, इधर आते जाइए, स्प्रेड कर जाइए। आर्यन सिंह सर थोड़ा सा आगे से, विश्वंदर सर थोड़ा सा, हाँ फोटोग्राफर हम लोग का है, मिल जाएगा, सारे फोटोग्राफ, सब फोटोग्राफ मिल जाएगा। Thank you so much. Thank you so much, ma'am.
Now everyone please move for lunch.